HIV-NAT stands for the HIV Netherlands Australia Thailand Research Corporation. It is Asia's first HIV clinical trial center established in Bangkok in 1996. It started from the burning need of having life-saving medications for thousands of infected Thai patients at that time. AIDS came to Thailand in mid-1980. By mid-1990, several thousands of Thais have been infected. Most of them were untreated, mainly because of the high cost of medications. In early 1990, I had the chance to meet Professor David Cooper from Sydney and Professor Jup Lange from Amsterdam. Both of them were famous HIV/AIDS clinicians. They also had their own HIV clinical trials unit in their own countries. So I asked both professors to help me setting up a similar trials unit in Bangkok so that Thai patients can benefit from the free AIDS drugs by clinical trial settings. Fortunately, both Professor Cooper and Professor Lange were able to convince the drug companies at that time to invest setting up a similar trial unit in Bangkok. HIV-NAT opened its door in July 1996 at the King Chulalongkorn Hospital of the Thai Red Cross Society. At that time, there were only 3 staff, including one doctor, Dr. Eugene Kroon from Amsterdam. Right now, HIV-NAT is an organization with 120 personnel with 5 doctors. At the beginning, HIV-NAT performed post-marketing drug trials by comparing the safety and tolerability and efficacy of various combinations of antiretrovirals. Later on, it gradually gained recognition to the point that HIV-NAT can join international new drug studies, including the strategic trials like a when to start trial. HIV-NAT started by doing post-marketing drug trials by comparing various combinations and various dosing regimens of many antiretroviral drugs. It gradually gained recognition to the point that HIV-NAT can be involved in new drug trials, as well as some new strategic clinical trials like when to start trial. For the last 7 years, HIV-NAT has been a part of the NIH-sponsored Clinical Trial Unit or CTU, together with University of Chiang Mai. During the last quarter of century, HIV-NAT with the HIV clinical trials, tuberculosis trials, hepatitis B, comorbidity trials, more than 200 studies involving more than 4,000 patients have been involved. With all of this, the following achievements have been done. First of all, lives of several thousands of Thai infected people have been saved. From 1996 to 2006, when antiretroviral drugs were included in the Thai Universal Health Coverage Program. In fact, the Universal Health Coverage Program in Thailand was fueled by or influenced by the Thai network of people living with HIV, as well as by the clinical benefit of patients from HIV-NAT studies. Secondly, HIV-NAT has helped in building up the competency and infrastructure of HIV clinical trials in several hospitals, including several medical schools in Thailand, as well as 2 units in Phnom Penh, Cambodia. The results of several HIV-NAT studies have been used as a guidelines in Thailand as well as international guidelines. But the most importantly, HIV-NAT has established the Bangkok International Symposium of HIV Medicines for the last 23 years, including the one this year, which is the first time in a virtual conference. One and a half years after the establishment of HIV-NAT, the first Bangkok International Symposium of HIV Medicine was held in January 1998. The rationale of holding such conference because the 3 co-directors were scheduled to meet annually for the HIV-NAT retreat. It would not be difficult for Professor Jup Lange and Professor David Cooper to invite a few more of their friends to join them in Bangkok and also to hold lectures for Thai healthcare professionals when they were here. This is why the first Bangkok Symposium was started and has been continuing on for the last 23 years, including this one, which is the first virtual conference. Starting from local audience, it gradually gained the recognition from clinicians from the region as well as from the world. In fact, out of these 500, 600 participants every year, half of them are non-Thais. The unique feature of the Bangkok Symposium was the educational nature. Speakers, both from Thailand, the regions, as well as from Australia, Netherlands, and USA, were asked to review the recent development for the last 1 or 2 years, so that audience don't have to go to all over the world for the meetings. I hope you enjoy this year's conference. HIV-NAT stands for the HIV Netherlands Australia Thailand Research Corporation. It is Asia's first HIV clinical trial center established in Bangkok in 1996. It started from the burning need of having life-saving medications for thousands of infected Thai patients at that time. AIDS came to Thailand in mid-1980. By mid-1990, several thousands of Thais have been infected. Most of them were untreated, mainly because of the high cost of medications. In early 1990, I had the chance to meet Professor David Cooper from Sydney and Professor Juk Lange from Amsterdam. Both of them were famous HIV/AIDS clinicians. They also had their own HIV clinical trials unit in their own countries. So I asked both professors to help me setting up a similar trials unit in Bangkok so that Thai patients can benefit from the free AIDS drugs by clinical trial settings. Fortunately, both Professor Cooper and Professor Lange were able to convince the drug companies at that time to invest setting up a similar trial unit in Bangkok. HIV-NAT opened its door in July 1996 at the King Chulalongkorn Hospital of the Thai Red Cross Society. At that time, there were only 3 staff, including one doctor, Dr. Eugene Kroon from Amsterdam. Right now, HIP-NAT is an organization with 120 personnel with 5 doctors. At the beginning, HIP-NAT performed a post-marketing drug trials by comparing the safety and tolerability and efficacy of various combinations of antiretrovirals. Later on, it gradually gained recognition to the point that HIP-NAT can join international new drug studies, including the strategic trials like a when to start trial. HIP-NAT started by doing post-marketing drug trials by comparing various combinations and various dosing regimens of many antiretroviral drugs. It gradually gained recognition to the point that HIP-NAT.
Good morning, everyone. Welcome to the second day of virtual Bangkok International Symposium on HIV Medicines Conference. I'm Suvaporn Jumpon. I'm a clinical trial physician at HIP-NAT Thai Red Cross AIDS Research Center. Today, we're going to start with tuberculosis sessions. Our first speaker is Dr. Amita Gupta. Dr. Gupta is a Deputy Director of Johns Hopkins Center for Clinical Global Health Education and Professor of Infectious Disease at Johns Hopkins School of Medicine. She specialized in international public health, clinical research, and education in infectious disease, especially in tuberculosis, HIV. She was involved in many TB preventive therapy studies. Her topic today is latent TB infection. Please welcome Dr. Gupta.
Hello, I'd like to talk to you today about the treatment of latent tuberculosis in persons living with HIV. So let's go ahead and begin. I want to briefly touch upon the epidemiology and the progress of treatment of latent tuberculosis, discuss what reasons there are to treat when you're already on antiretroviral therapy, what are the different regimens and options for treatment, what considerations we need to take into account given the antiretroviral selection and known drug-drug interactions, and also briefly describe some special situations such as drug resistance exposure, pregnancy, and the role of repeat courses. So let's begin with what is the TB burden and the goal of TB elimination. So the WHO has shown that between 2000 and 2019, TB incidence has been slowly declining, and that is both with people living with HIV, as is shown in the red lines, as well as those who do not have HIV. However, the decline has been slower than desired, and currently tuberculosis is the #1 infectious disease morbidity mortality among persons living with HIV, with the greatest burden happening in low and middle income settings. There are a total of 10 million cases, of which 10% are estimated to occur in persons living with HIV, making this a very important problem. And specifically for Thailand, when we look at the epidemiology, in 2019, 105,000 people were diagnosed with TB, of which 10,000 are estimated to have been TB-HIV co-infected, and there were 11,000 deaths. And importantly, of those 10,000 individuals who fell ill with TB, we also have to think about preventing people with HIV from becoming diagnosed with TB. And so we have some room for improvement in places like Thailand. Here in the lower left hand shows the TB preventive therapy, and it's estimated that 0.41% of HIV positive people are on TB preventive therapy, and 56% of children under the age of 5 are on TB preventive therapy who are contacts of a known TB case. And so this, I think, will really benefit from improved scale up of TPT, as it's known, which stands for TB preventive therapy, and I'll use that routinely. I think the other challenging factor, of course, the world is a very changed place. 2020 brought the impact of COVID, and Fortunately, COVID has had a dramatic effect, particularly in some countries more than others, on TB notification. Here you can see several countries, high burden countries, with Thailand on the bottom panel showing some decline in reporting, particularly over the summer months, and other places like India where there was a dramatic decline because of a national lockdown. Now, there are clear goals that have been set as part of this ambitious NTB strategy that the Global TB Program through the World Health Organization and partners has undertaken. And they're listed here, and they include a dramatic reduction of 95% in number of TB deaths by 2035, a 90% reduction in TB incidence, and 0% of families facing catastrophic costs due to TB. In order to do that, it is clear that finding and treating active TB alone is not enough. And these are data from some time ago showing the different strategies that can be used to address the TB epidemic. We can address risk factors, things like smoking cessation, diabetes, treating HIV with ART. In the orange bar, you can prevent infection. And then, of course, you can treat latent TB, which has an important impact. You can see that light blue line. And then treating both active and latent TB, the combination is really the best strategy in the absence of effective vaccines. So really, we need to do both. And the way that we can also address preventive interventions for tuberculosis is to prevent infection. So doing good infection control, particularly in healthcare settings, and doing case finding strategies, reducing susceptibility by taking care of smoking cessation and diabetes. And a lot of these comorbidities exist in our HIV co-infected individuals. And of course, much of this lecture is going to focus on the role of TB preventive therapy. So what's the current guidance for latent TB treatment in persons living with HIV in low and middle income settings? So for this, I turn to the WHO guidelines, and you can see these are available on the web. But the statement that they make for adults and adolescents living with HIV, first, obviously, they should not have evidence of active TB, but all persons living with HIV should receive TB preventive therapy as part of a comprehensive package of HIV care. And treatment should be given to those on antiretroviral therapy. They also recommend to pregnant women, as well as those who've previously been treated for tuberculosis, irrespective of their degree of immunosuppression, and even if the LTBI or latent TB infection testing is unavailable. This is a strong recommendation and has high certainty in the estimates of effect. With respect to children, the recommendation is that infants less than 12 months who have HIV, who are in contact with a person with TB, and who do not have evidence of active TB should receive TB preventive therapy. And children who are 12 months or older with HIV should also be offered TB preventive therapy as part of a comprehensive package of HIV prevention and care, particularly if they live in a high TB incidence setting. And that's regardless of whether they have known contact or not. So there's a differentiation between very young, less than 12-month infants and those who are children 12 months and older. So what's the role of latent TB testing in persons with HIV? Well, it is recommended to perform testing in low incidence settings as a matter of standard of care. So tests like the tuberculin skin test, the IGRAs, are what are routinely done. However, in high incidence settings, and also because of the challenge of getting access and the cost and the need for return visits with things like the tuberculin skin test or a specialized lab setting, as in the case with interferon gamma release assays, the recommendations generally do not absolutely require it. However, they do help to identify persons who are at high risk of progression. But I will say that in HIV-infected persons, the sensitivity and predictive value is truly suboptimal. And so these tests, while they provide an increased risk stratification, they have poor predictive value and therefore have not are not sort of tests that are required to start TPT in high incidence settings for persons living with HIV. Now, there are some new tests, such as the QuantiFERON Plus. It's a similar test to the older generation IGRAs. It just has some additional TB-specific antigens and involves 4 tubes as opposed to 3 tubes, so a little bit more blood collection. It still requires a specialized lab. The manufacturer is looking to do more field-friendly testing modalities. There are also new skin tests such as CTB, which use the ESAT6 CFP10 antigens that are in the QuantiFERON assays. However, these novel tests are not routinely available just yet, so they're not yet recommended by the guidelines. And then there's several other correlates of risk that have been studied or are being studied, and these include host gene signatures, measuring inflammatory profiles, and correlating that with clinical factors to try to develop risk prediction tools. But again, none of those are yet recommended for prime time. And I just very briefly draw your attention to this recent review, given that you may have heard of a lot of the excitement or heard about studies looking at how whole blood transcriptional signatures could be used to determine who's at risk of developing tuberculosis. And this recent systematic review and patient-level pooled analysis looked at 17 of the published signatures, which were RNA signatures between 1 and 51 gene transcripts in length. And they really found that these reflected, at best, short-term risk of incipient TB, and none of them met the WHO target test profile for prediction of TB in a 2-year period. And so these are not yet used for prime time. And there was a recent trial called the Cordis trial, which was presented using the host gene signature and targeted TPT strategy. And there they showed that there may be some role for it, but I would say that it needs a little bit more assessment before it has clear guidance on how to use these signatures for clinical management. So the current algorithm that the WHO proposes is shown here. If you're HIV positive, and if you have any symptom of either cough, fever, weight loss, or night sweats, you need to get investigated for TB. If you're ruled out or don't have any of these symptoms, then you ask about if preventive therapy is contraindicated, such as having had a severe allergy, or they're on a medication that has clear indication for a severe drug-drug interaction. If that's not the case, then you can go ahead and initiate your TB preventive therapy. So a very simple algorithm. And I think that there's now absolutely no question that giving a combination of TB preventive therapy along with antiretroviral therapy is actually better than either one alone. This was a recently published systematic review looking at 3 trials that studied the risk-benefit of antiretroviral therapy with INH preventive therapy, and it found that the combination was better than either one alone to reduce both TB incidence as well as mortality in persons living with HIV. And specifically, there was 32% more reduction in TB with the combination. So definitely, if you have patients doing well on ART, there is added benefit to using the TPT. Now, mind you, these studies are all from very high incidence settings of South Africa, Malawi, and Cote d'Ivoire. So we know that in lower incidence settings, obviously, there may be a different actual absolute risk reduction, but regardless, the WHO and the rest of these high incidence setting guidelines do recommend the combination. So in terms of prior to treatment, I think you all know this. You want to assess for medical conditions, ask about liver disease, neuropathy, test for pregnancy, and what medications are on, ask if they've ever been treated for LTBI or TB disease, and establish rapport with the patient and explain therapy and adverse effects. One question that sometimes comes up is who should get baseline liver enzyme testing. This depends on your various individual practice and guidelines, but these are some of the broad recommendations if they have known underlying liver disease, if they're pregnant or recently have delivered, if they consume alcohol regularly, or they're on other medications that could cause hepatotoxicity. Those are guidelines for testing for LFTs. Now, what are the regimens to consider? So basically, the premise of TB preventive therapy lies on the power of two classes of drugs, isoniazid and the rifamycins. And for the longest time, we've sort of relied on isoniazid monotherapy, either for 6 months or 9 months, and there are even studies showing lifelong, but those have sort of not gained a lot of favor in the guidelines. And then there's using rifampin, which is a cheap and readily available TB drug. And there's data to support 4 months of rifampin daily. There's a combination of INH and rifampin given daily for 3 months, known as 3HR. And then more recently, there's a lot more interest in these combinations of INH and a longer acting rifamycin known as rifapentine. And this can be dosed either weekly, given for 3 months, or daily given for 1 month, and I'll briefly go over those. So there have been now several trials looking at this regimen known as 3HP, which is the weekly INH rifapentine given for 12 doses, and it's essentially shown to be non-inferior, almost superior to INH in adults, adolescents, and children. It's safer, and it has better adherence and treatment completion. And these are just the data showing the difference between 9 months of INH and the 3HP regimen, showing reduced TB incidence in both HIV uninfected and infected. And then more recently, there was a large trial involving 3,000 HIV-infected persons, a global trial from many high-burden countries, where most with CD4/470, most of these individuals, if they were on ART, were in an efavirenz-containing regimen. And this was a 1 month daily isoniazid rifapentine regimen. So imagine this was compared to 9 months of isoniazid. So a short, ultra short course of 1 HP, as it's known, showed that it was more readily completed, had fewer side effects, and had the same reduction in TB incidence as did 9 months of INH. And that's shown more clearly here, irrespective of whether you had a positive IGRA or TST, or if you were on ART or not. And that's just, again, shown figuratively here. It was completely non-inferior to 9 months of isoniazid. The other trial I wanted you to just be aware of that was published in 2018 was this 4 months of rifampin. And this compared to 9 months of INH, showed excellent safety with the 4 months of rifampin, both for adults and children. The main caveat here is that there was a relatively small number of HIV-infected persons, but nevertheless, this is another option, particularly in places where rifapentine may not be readily available. And if you have ART that can manage to be co-administered with rifampin, which we'll talk about in a few minutes. So these here are the guidelines for the different regimens that exist for treating latent TB infection for HIV-infected persons. So I showed the CDC guidelines, the DHHS guidelines, which are ART guidelines, the OI guidelines, and then the WHO guidelines. The green boxes showed the preferred regimens, with the regimens on labeled in the top, and the yellow are sort of alternatives, and the magenta sort of / red color is the no evidence is either available or there's no specific recommendation made. And so here we have for 3HP is the preferred regimen for all the guidelines except for the DHHSI guidelines. And you can really only use this for raltegravir or efavirenz-based regimens based on the OI guidelines there. You can see that the 4R is an alternative regimen for the WHO guideline. The 3 months of rifampin INH is a preferred regimen, as is the 9 months of INH, as is the 6 months of INH. And the 1HP has just recently made the guideline, and for now is an alternative regimen. And part of that has to do with the fact that we have not studied the impact of daily rifapentine and many of the antiretroviral regimens that are commonly in use. And I'll go over those in just a few minutes. So in terms of selecting a LTBI regimen for persons living with HIV, well, you want to sort of choose based on adherence, drug-drug interactions, the potential for side effects, and preferences. You also want to take a look at certain side effects such as flu-like hypersensitivity with 3-HP. Clearly, drug interactions are a big issue. The longer the regimen, you have to worry about adherence issues. And for INH, you have to think about alcohol and the risk of hepatotoxicity. And then I think for, when you're going through counseling patients, you want to show them what are the potential number of pill burden and number of doses they'd have to take. So obviously, the longer the INH regimen, the more pills and the more doses over the lifelong. Whereas with the 3-HP, that's 12 total treatment doses. So that's the shortest regimen. And then, of course, 1-HP is 30 doses because it's daily. Here just is showing you a schema for the type of pill. There is now a new co-formulated isoniazid rifapentine pill, which can be done. And so if you're on 3-HP, once a week, you take 3 pills along with vitamin B6. And if you're on the 1-HP, you would have to take one of the co-formulated and have to have the 2 rifapentine given separately. Based on weight-based dosing, and then, of course, your vitamin B6. So you would want to explain that and counsel patients accordingly. I'll now switch to drug-drug interactions, which I think is really critical to when we're thinking of selecting a regimen. Here I show the ARV class, and you can see that isoniazid is sort of really has the least number of drug interactions with ARVs. The only exception is in that a subset of slow metabolizers of efavirenz and slow metabolizers of isoniazid, you can have increased levels and risk of higher drug concentrations of efavirenz. Otherwise, right now, what we know, Biktarvy has significant drug-drug interactions with rifamycins, both rifampin and rifapentine, and should not be used. With dolutegravir, you have to double the dose of dolutegravir, so with rifampin. And with 3-HP, the Dolphin trial published by Dooley et al. Shows that you can use dolutegravir with 3-HP safely. It has not yet made the most recent guidelines, but that is expected. However, with regimens that are combination dolutegravir rilpivirine, you should not use the rifamycins. For ralotegravir, you have to double the dose with the rifamycins. And you cannot use elvitegravir or cobicisstatin or TAF for that matter with the rifamycin. So this is important given the rollout of integrase inhibitors. With respect to efavirenz, you can, that is the one class of drugs that can be used safely with the rifamycins. However, the other NNRTIs such as etravirine, nevirapine, and rilpivirine cannot be used with rifampin or rifapentine. And similarly, the protease inhibitors cannot be used due to the significant drug-drug interaction. And then lastly, we don't use maraviroc much, but you need to use a higher dose of maraviroc with the rifampin. And I show these slides here. You can review them on your own time. I'm not going to go through them in detail. I just have all the details of the regimens and the interactions for your reference, and you can look these up. This is just a reminder that it's not only the antiretroviral therapy you need to worry about. Please do remember to look up the other medications patients may be on, because there are other interactions of importance that also have to be considered. And another piece, obviously, is the counseling and monitoring adherence. Many of your programs and our programs have self-monitoring, and that's, these are otherwise healthy people who are not having signs or symptoms, and therefore they're taking a medication for prophylaxis. You want to be able to give them warning signs of what to look for should any of them develop hepatitis, including the anorexia, dark Rearin, rash, fatigue, fever, and to stop taking medication should any of these symptoms develop, and to seek prompt medical evaluation. With the 3HP, there's occasional reports of flu-like illness, hypersensitivity reactions, so to counsel patients about that. And of course, if anyone has abnormal LFTs and you feel you need to implement them or they develop them, you have to continue to monitor their LFTs and certainly maximize adherence using strategies such as video DOT or phone call or pill box reminders. There's no test of cure, but adherence prevents up to 90% of subsequent disease. So I'll briefly end on talking about a few special situations, what to do about multi-drug resistant TB. I mentioned that for quite some time, WHO had a watch and wait policy. Now there's some recommendation based on a limited cohort study data with very few HIV infected persons. The WHO recommends doing the LTBI testing for people who've been exposed to multi-drug resistant TB, and recommends regimens that either include fluoroquinolones alone, fluoroquinolone with ethambutol, or fluoroquinolone with ethionamide plus or minus isoniazid if a 3-drug regimen is warranted. They've also been reports of using drugs according to the DST, the drug susceptibility of the source index case. On this slide, I won't go through all of it. It just shows the various small studies that have looked at the types of regimens offered to people who've been exposed to multi-drug resistant TB. And you can see most of these have included a fluoroquinolone, and either alone or in combination. There are currently now 3 trials underway to really study this question, and some of them are including HIV-infected persons, the TB-CHAMP and the Phoenix trials. We will have hopefully some information about how to manage an HIV-infected person who's been exposed to multi-drug resistant TB with more robust data. What about if your patient's pregnant or breastfeeding? For most latent TB therapy, it certainly is a question of whether the participant wants to initiate it during pregnancy or delay it until after delivery. When they're HIV infected and not yet on ART, the guidance from the WHO is to recommend initiating it. However, I will say it's important to think about knowing some of the literature and to counsel your pregnant women. We recently completed a trial and found that HIV infected pregnant women who started their INH in pregnancy compared to deferring it till after delivery had an increase in some composite adverse pregnancy outcomes. However, there's also some data showing that this risk is mitigated by the benefit of preventing TB. So the WHO is still recommending IPT initiation in pregnancy for the time being. We'll also say that the 3HP regimen appears to be safe based on a small study of 50 women, half of whom were HIV infected. And so the 3HP regimen can be used for pregnant women who are on an efavirenz-containing regimen, but not really known if they can be used. It's not been tested for any of the other ARV regimens. Isoniazid is safe for breastfeeding, given with pyridoxine, and it's likely that 3HP and 4R are also safe, but there's little data. And one of the issues is to keep in mind that while there are slow concentrations in breast milk, if someone is on a rifamycin and an infant's on nevirapine, you want to think about some potential small risk, theoretical risk with interaction. and reducing the nevirapine efficacy in breastfed babies. I'll end on saying a few things about recent data. There was a trial to look at whether giving repeat courses of latent TB treatment for those residing in very high incidence settings, such as South Africa and Ethiopia and Mozambique, where they gave a course of 3-HP every year, comparing it to just giving it once and done, if you will. And these were results presented at CROI 2020 of the WIT3 TB trial. And importantly, giving the annual course did not provide any additional benefit than giving to people who just needed one course for people on ART. So basically, no benefit of doing additional repeat courses. Once is enough when you're on ART to get the benefit of LTBI therapy. There's a whole bunch of tools to promote adherence, and you can pick and choose if you have these at your access. You can use smartphones, you can use pill boxes, you can use urine dipsticks to check to see if INH is actually being taken. This here is shown the isoscreen assay, MERMS, and EMOCA smartphone approaches. And I think what's exciting is that there still is a lot of future for looking at new interventions for latent TB therapy and prevention. So these include getting shorter and shorter regimens, as well as the advent of TB vaccines. So I'll end by saying that we'll probably be testing some new combinations that include things like bedaquiline with or without other agents, which are shown here, which can very rapidly reduce the TB in the mouse model. And you have here also, like with ART long-acting drug formulations, interest in developing long-acting bedaquiline or other TB drug regimens with nano formulations, but it's still early days. And then, of course, there's really some exciting news for TB vaccines with these new subunit vaccines or recombinant BCG vaccination or ID93. And so we really do need to see how these products fare for HIV-infected persons. But this is exciting days and going beyond the standard BCG at birth strategy for preventing TB. So in summary, I want to let you know that TB preventive therapy works and is necessary to end the TB epidemic. Uptake of TPT needs to be improved and is of additional value beyond just giving antiretroviral therapy. LTBI testing is helpful but not required. There are several newer short course regimens that have the potential to greatly increase the use of preventive therapy in high-risk populations such as those living with HIV. The 3-HP regimen is easy, safe, and effective and can be used with efavirenz, raltegravir, or dolutegravir. The new ultra short course 1-HP regimen is also easier, safe, and effective. It can be used with efavirenz, but we need to know how it will work with these other integrase inhibitor regimens. We don't have data for that yet. Using short course rifampin regimens, you need to double dose integrase inhibitors such as dolutegravir. And then we'll be hopeful for the future that they're going to be that they'll be long-acting injectable once and done type of regimens, as well as TB vaccines for the future. So I'd like to thank all the organizers and appreciate your time and attention.
The next speaker is Dr. Frank Kobilens. Dr. Kobilens is a professor of global health at the Amsterdam University Medical Center and chair of Executive Board of Amsterdam Institute of Global Health and Development in the Netherlands. He has served on several global expert panels and advisory body of TB, and is one of the initiators and scientific co-chair of the Union TB Science Conference. His recent work focuses on tuberculosis, including TB-HIV co-infection, TB diagnostic and evaluation of novel interventions for TB control. His topic today is TB vaccine update. Please welcome Dr. Kobilens.
Good morning, everyone, and thanks for the opportunity to present this overview of tuberculosis vaccines. I have no conflict of interest to declare. there has recently been quite some excitement about tuberculosis vaccines, both from clinical studies, as you can see here on the left, and from more basic science, as you can see from the right. I will discuss them later on. For now, what I'll show you here is what I'm going to talk about. I'm going to talk about the need for new tuberculosis vaccines, about barriers to developing those new tuberculosis vaccines, about the current TB vaccine clinical development pipeline, about recent developments in discovery, and then finally a few words about implementation. So let's start with the need for new tuberculosis vaccines. So what you see here is a summary of the TB data from the latest WHO Global Tuberculosis Report. They're about 2019. As you can see, the World Health Organization estimates that in that year, 10 million people worldwide fell ill with tuberculosis, leading to 1.4 million tuberculosis deaths. The majority of these TB cases are in the two WHO regions, basically around here, around Bangkok. Southeast Asia and Western Pacific together account for more than 60% of all the cases, and 25% of the cases occur in Africa. And what you can see from the little map here on the left is the incidence rates, and you can see that the highest incidence rates are in sub-Saharan Africa, but also pretty high incidence rates in South and Southeast Asia. Clearly, TB HIV co-infection is still a major problem. The WHO estimates that in 2019 there were over 800,000 people living with HIV who got tuberculosis, over 200,000 TB deaths among people living with HIV. The majority of the TB HIV cases are in Africa, about 3/4 of them, and almost 15% in Southeast Asia. And here you can see again on the map, you see here the proportion of notified tuberculosis patients who have HIV infection. And you see that is definitely highest in Southern Africa, but also pretty high in, for example, parts of the former Soviet Union. There is a vaccine, there has been for a very long time a vaccine against tuberculosis. It's called BCG, which stands for Bacille calmette-guérin. It's a live attenuated strain of Mycobacterium bovis. It was actually developed in the 1920s and 1930s, has been in use since the 1930s. And what you see here or in the graph is a meta-analysis of randomized controlled trials that have been done up to 1988. And what it basically shows you, and you can see here so this is the relative risk, and the further the relative risk goes away from 1 to the left, the higher the vaccine efficacy. And you basically see that the vaccine efficacy in these trials is all over the place. It ranges from 0% to 80%. People have been doing over the years a lot of work to try and understand what this heterogeneity is due to. And this is from this same overview, which is actually a meta-regression of those various trials and other studies. And that clearly showed that vaccine efficacy for BCG is associated with higher latitude, meaning that the farther you get away from the equator, the better it works, that it is associated with neonatal age and with higher quality studies. And the overall conclusion is that BCG does offer protection in neonates, in particular against meningitis and miliary tuberculosis, which are the main causes of TB-related death at that age. And that for that reason, it is the worldwide use for neonatal immunization, at least in most of the countries, at least in those with high TB incidence, should definitely be continued. However, it has a questionable efficacy in adolescents and adults, and it has compromised safety in those who have cellular immune deficiency, including HIV, because of its live attenuated nature. And this is basically to show that we do need something new. This is the basically the levels of achievement of the targets for the End TB strategy, which is WHO's strategy to eliminate tuberculosis by the year 2030. And it tells us where we stand on the three main targets in 2020. And you can see that for TB incidence rate, the target was a reduction of 20% worldwide. We've only reached 9%. For the number of tuberculosis deaths, target 35%, only reached 14%. and the percentage of people with TB facing catastrophic cost target was 0% by now, is still looking at 49%, meaning we are definitely not yet there and the pace is too slow. And what this graph here shows you is the estimated tuberculosis incidence. All tuberculosis cases is notification, but this is what we should be looking at here. And it shows you how far we're still off from the target for 2030, the elimination target, which is here. So there is still a huge gap to be covered. And already earlier on, modeling work has showed, and this is what is here shown in this arrow here in the middle, that in order to reach elimination, we need to have such a drop-off in tuberculosis incidence and number of deaths that we definitely need new tools, and a new vaccine is probably the essential one here. This is why the WHO has, over the past few years, defined a number of product profile characteristics for the new tuberculosis vaccines. So this is basically saying this is the kind of vaccine that we need, and this is the minimum characteristics it should have. And these 3 PPCs, as they're called, are from left to right: a safe, effective, and affordable TB vaccine for adolescents and adults. This is definitely the most important one because this is going to have the impact on the epidemic. The second is an affordable TB vaccine for neonates and infants with improved safety and efficacy compared to BCG. And the third, and that's really rather new thinking, is a therapeutic vaccine to improve tuberculosis treatment outcomes. If we look at the one here on the left, here really the aim is to prevent pulmonary tuberculosis disease, because that is also, it's the most important form of the disease clinically, but it's also the one that is infectious. And the desired characteristics here are 50 or greater % vaccine efficacy with a duration of 10 years or more in subjects, both subjects with and subjects without evidence of already existing latent mycobacterial tuberculosis infection, with a favorable safety profile, amongst others safe in people living with HIV, other immunocompromised people and elderly and so on, with a minimum number of doses and boosters needed, and the price that would not be a barrier to access, including in low middle income countries. For the childhood vaccine, it would really be about prevention of TB disease, including severe disseminated tuberculosis, so that's miliary TB, TB meningitis and pulmonary TB, with an 80% or greater efficacy, all superior to BCG. Again, duration of 10 years or more. Here, co-administration with other vaccines in the expanded program on immunization is obviously very important. The vaccine should have improved safety compared to BCG. Again, the minimum number of doses and boosters needed, no interference with other EPI vaccines, and price not being a barrier. And then finally, for the therapeutic vaccine, the idea is here to have a vaccine that would either prevent recurrence after cure, so that's a patient who's been treated successfully for tuberculosis, but we know that they look at 2 to 5% risk of relapse or recurrence, and the vaccine should prevent that. Or the vaccine should increase the cure rate when given during treatment, for example, in people who are for some reason hard to treat. And obviously, drug-resistant tuberculosis would be an example. A therapeutic vaccine should be effective in all TB treatment, both drug-sensitive and drug-resistance. The desired vaccine efficacy would be during the 1 year of follow-up. Clearly, in this case, one would follow up for a shorter period. 50% of greater, again with favorable safety profile, minimum number of doses, and price not being a barrier. Now, in the second part of my presentation, I wanted to talk a little bit about the major barriers that currently exist to developing new TB vaccines. And for doing that, I would like to start with just quickly going over the TB vaccine development pathway, which is not very much different from any vaccine development pathway, but it's just sort of to synchronize our watches on the various phases in the pathway. So it starts with discovery, and this is the phase in which antigens that are immunogenic are identified, in which platforms are identified and developed, in which adjuvants are identified. So basically, this is where the engineering of the vaccine is done. Studies here are proof of concept studies, clearly animal studies, to see whether these candidate vaccines would have any efficacy at the biological level. The next stage is the preclinical stage, in which especially the manufacturing and the quality control process, so making sure that one has a product that can be reproducibly evaluated, that product is available, that is very important. So it basically prepares for phase 1, also looks at dose ratios, and again, here animal studies are very important. And then if a product passes that stage, candidate, it goes into clinical development, and here the stages are classically 1, 2A, 2B, and 3. And in phase 1 is the first in human phase, which is primarily looking at safety in healthy volunteers, but also to some extent immunogenicity. If that is successful, a candidate can move on to 2A, and from 2A, basically studies are done in the population of intended use. So if we're looking for a vaccine that should be used in the elderly, one should look in the elderly from phase 2A onward. So this is really about dose finding, phase 2A, safety and tolerability again, and immunogenicity. From phase 2B onwards, in addition to the other characteristics that are evaluated, clinical efficacy becomes important. Usually, if phase 2B are relatively small studies that can give an indication of clinical efficacy, and then obviously the phase 3 studies that are meant to complete a dossier for licensure, for registration, is really about clinical efficacy at large scale and safety and tolerability. And then after introduction, there is a lot more that generally needs to be done. For example, safety surveillance, pharmacovigilance, effectiveness in the real-life world, barriers to vaccine implementation, impact, the public health impact of these vaccines, cost effectiveness, and so on. So this is the entire pathway in terms of the research that needs to be done. Now, if we look at those barriers, I have identified 5. The first one is really in the discovery space. And that barrier is that we have very limited knowledge of the human protective immune responses that are needed to prevent tuberculosis disease. What we know by now is that conventional T-cell responses are necessary for protection, but they're not sufficient. We need something in addition to that, and we basically don't know exactly what that is. And if you look at this little graph here, this is the sort of current paradigm as it is emerging about the natural history of tuberculosis. So one gets infected, then can eliminate that infection in early stage, but can move on also in early stage quickly onto having tuberculosis, or have latent TB infection that can remain for a very long time, also in later stage be eliminated, or lead to rapid or less rapid, slow reactivation of disease. So all these various stages. Now, basically what we don't know is what drives the transitions along this natural course of infection, and what drives clearance and what drives this move towards disease. We basically don't know what the key immunological parameters are here. We also don't know what the role is of non-conventional cellular immunity, of antibody responses, and of trained innate immunity. Both antibody response and trained innate immunity are getting a lot of attention at the moment, and they seem to be much more important than we previously thought. And then a third important element is how to direct immune responses to the lungs, because that's where these vaccines should be active. So if a vaccine is given intradermally, how do we make sure that it's actually at the level of the lung parenchyma that they exert their protection? A second barrier has to do with the animal models. Basically, we don't know whether our animal models really predict prediction in humans. And what you can see here is the 3 animal models that are used most. It's the mouse, it's the guinea pig, and it's non-human primates. And the further we go to the right, the more we think that the immune responses mimic those in humans. But we're not entirely sure. So as a result, the correlation of what we predict in terms of protection of a vaccine candidate in animals and humans is limited. It has to do with the animal biology. It has to do even in, for example, non-human primates, quite some variability in outcomes. So animals respond pretty different to challenges with Mycobacterium tuberculosis responds pretty different to candidate vaccines, and we don't know exactly why. Another thing that we don't know exactly yet is what an infectious challenge or an infectious dose looks like. Is that something that's one-off? Is it something that needs to be given over a prolonged period of time in very small doses? So what is actually the natural biological way in which humans get infected, and how can we mimic that best in animal models? And the problem here is really that because there have been so few studies, clinical studies this far, that have shown protection signals of vaccine candidates, it's been very hard to validate these animal models. And we're only starting to do that now that there are studies that are showing a protection signal. The third problem, I think, is really key, and that is that there is a lack of agreed laboratory correlates of protection. And I want to illustrate that by the by now notorious example of the BCG-MVA-85A boost combination. So this was a pretty promising vaccine candidate. So it was giving this affected vaccine with the 85A antigen as a boost in people who had been primed with BCG. And actually, in studies in non-human primates, and what you should be looking at is here, BMVA, it actually looks quite promising. This is the lung pathology. This is the bacterial load in the lung in animals that were vaccinated by these various vaccine candidates and then challenged. And you can see that the MVA 85A boost performs pretty well in both cases compared to BCG and compared to non-vaccination. And in human studies, these were phase 1 studies, there was actually quite nice immunogenicity as expressed by the interferon gamma responses. This was at the time that people were convinced that if you look at interferon gamma response, so basically T-cell activity, you'll get an idea about how immunogenic these vaccines are. And you can see here, this combination, BCG, MVA, 85A, by far the best. But then the phase 2B study was done in South Africa in infants. And it was reported in 2013, and it basically showed no clinical efficacy whatsoever. It was around 0. So this really set back the field because it showed that, first of all, that what we thought we knew from non-human primate studies didn't really translate into clinical efficacy. And the same was true for our interferon gamma responses. So basically, we have no agreed laboratory correlate of protection. And this is very important because as long as we don't have that, trials need to be very large and of very long duration. So we basically don't know which candidates afford protection until we have tested them for clinical endpoints in phase 2B and phase 3 trials. And these are very high-risk trials. So they are high-cost trials, and for that they are very high risk because we don't know if a candidate is likely going to succeed. The problem here also is that the key clinical endpoint for licensure of a TB vaccine for adolescents and adults is prevention of TB disease. So we want to make sure, in phase 3 trials, prevention of disease has to be the primary endpoint. But that requires very large numbers of participants, very large trials. They have to be followed up for a long period of time. That's basically just due to the natural course of disease. So duration of follow-up is generally 3 years or more. Now, there are several alternatives being tried in so-called proof of concept phase 2B trials with alternative endpoints. And the ones that are being used are POI, which stands for prevention of infection, and POR, which stands for prevention of recurrence. Now, POI trials basically look at conversion of intergamma release assays, IGRA conversion, as we used to have tuberculin skin test, nowadays IGRA, or sustained conversion. And in POR trials, one looks at recurrence to see whether after a patient has been cured, whether relapse or recurrence can be prevented by a vaccine. The problem with these endpoints is that we don't know how well these endpoints translate into protection of disease. So even if we have a phase 2B trial that shows a signal, for example, for prevention of infection, we are not yet sure that it will do well in a phase 3 trial with POD as the endpoint. So now currently, as I already said, we are in the stage where we can start trying to identify these correlates for protection, and also to validate these animal models, because now we are seeing, we do have trials that show protection signals. So this work is now actually only starting. Now, the fifth barrier, I think, is really the major one. That's funding. This comes from the Treatment Action Group report of last year, really a very important piece to read if you're interested in this field. Very thoroughly investigated. What you see here on the left is the 5-year research funding targets. And this is how well, so these are the white bars, and then the blue bars, greenish blue bars, they show you how far we are in the first 2 years. Now, and the two areas that are of relevance here are basic science and vaccines, and we see we are very far off target still. And a major problem here is the disbalance in funding. This is looking at funding for TB vaccines spent in 2019, a little over $100 million. $100 million. Now, I think that currently into COVID-19 vaccine discovery, I think spending has been on the order of 10 billion. So you can see what the huge difference this is for between these two diseases. But the real concern here is that is only two funders, the National Institutes of Health, US, and the Gates Foundation, that together account for 80% for all of the funding. So this is really a problem. And my big question is here, where are the BRICS countries? Where are the middle-income countries that basically have the largest share of all the TB patients, and definitely should have also the funding to engage in vaccine development and clinical evaluation? All right, so let's move on to our current TB vaccine clinical development pipeline. This is the pipeline, almost complete as recently presented by the WHO in their global report. The different colors, and you can see here, it goes from phase 1, 2A, 2B to phase 3. The different colors represent different types of vaccines. So the dark red are live attenuated vaccines, just as BCG. The ones that are sort of reddish here are whole cell vaccines, which basically means inactivated mycobacteria, or an extract of that. And then the green ones are adjuvanted protein vaccines, and the gray ones are viral vector vaccines. So these are the ones that we are now currently seeing a lot in COVID-19 vaccine development. So you can see that there are various platforms are being used, even though some of them are not too far yet in the pipeline. So what I'll concentrate on is the ones that I think are the front runners: M72, VPM1002 BCG revaccination, but also spend a little bit of attention to these 3 vaccines here that are also in phase 2B or 3. So let's start with M72. So this is a fusion protein of these 2 antigens, MTB39A and 32A, together with an adjuvant that was developed by GlaxoSmithKline. That's also basically the adjuvant in their pretty effective shingles vaccine. It's called ASO1E. This was published last year. This was the phase 2B trial, where they gave M72 as 2 doses versus placebo, 1-to-1 randomized in 3 countries in Africa with a follow-up of 36 months, and as the primary endpoint, bacteriologically confirmed pulmonary tuberculosis. About 3,500 participants randomized, and it showed a vaccine efficacy after 3 years of almost 50%. 49.7%, but as you can see here, with a pretty wide confidence interval. And this was really very good news, because after BCG, it was really the first vaccine that showed anything that looked like a sort of a serious protection signal. Now, the further clinical development looks like this. GSK doesn't have the ambition to move this product forward themselves, so they licensed it to the Gates Medical Research Institute, which now acts as the sponsor, for 2 trials. One is a phase 2A trial that's currently ongoing. It's about safety and immunogenicity in virally suppressed people living with HIV, around 400 in South Africa. And a phase 3 trial is currently in preparation that aims to answer two questions. One, does M72 protect individuals who are already infected with mycobacteria, so are IGRA positive, from disease, and then for how long? And the second question is, does it protect IGRA negative individuals from infection and potentially disease? It's currently being planned. They're probably looking at 14,000 or more subjects in very high incidence settings. And the trial will include both IGRA positive and IGRA negative individuals and people living with HIV, but primarily for safety endpoints. We'll talk a little bit more about that later. And what you can see on the bottom here is what is the current thinking about the timelines. The phase 2A trial, the safety and immunogenicity trial in HIV, is planned to report in 2022. The year after that, phase 3 will start. If it will be have a complete 5 years of follow-up, it will report only in 2031. Possibly it's going to be earlier, and then possibly with a licensure, or at least a conditional licensure, already before 2032. But that's still a long way to go. Now, the second frontrunner is VPM1002. This is a live recombinant BCG. And of course, here the question is about immunogenicity, is clearly safety. So various studies have been done. So the earlier trials were done in healthy adults, where it was safe and immunogenic, and then also in HIV-exposed and HIV-unexposed infants in South Africa. Only one small study has been published, only 36 patients, so there's not an awful lot one can say from that, but a larger study is about to be published. There are a couple of trials ongoing, and they are a bit sort of difficult to classify as being either 2 or 3. The first one is of prevention of TB infection in infants. So it's a POI endpoint. It looks at IGRA conversion. The other one is prevention of TB recurrence. So this is in patients who have been treated in order to see if the vaccine can prevent recurrence. And then there is a phase 3 currently being planned for prevention of TB disease, and that takes as the approach a household trial nested in a household context study. So the timelines here is that for the recurrence trial, one expects results in 2022, the year after for the infant trial that looks at infection endpoints, and then hopefully the phase 3 trial can be started by then. The third is BCG revaccination, and that is a bit of serendipity actually, because this was not meant in the original, this was not a goal in the original trial. So this is BCG given to adolescents who had been vaccinated at birth. And in the past, there had been studies looking at BCG revaccination. It didn't really show an effect. But this study sort of serendipitously did. So this was a trial that looked at phase 2B trial that looked at this vaccine here, H4IC31, versus BCG versus placebo in these adolescents that had been vaccinated at birth in South Africa. They were followed up for 30 months. And the primary endpoint here was quantiferin, so that's IGRA conversion, and they found no significant effect between the various study arms. But they did show that sustained IGRA conversion, which means that the IGRA remains positive also 3 or 6 months after. That actually showed a signal, and that was a vaccine efficacy of 45%, also again with a wide confidence interval, for comparing the BCG to the placebo, these two here. So that suggests that BCG revaccination actually might have additional effect, even though we don't know exactly what prevention of infection means in terms of prevention of disease. Still, it's been a reason for the Gates MRI to take this on in their BCG revax program. They are currently doing a phase 2B trial where they're basically trying to replicate this finding, again in South Africa, in 1,800 quantiferin negative adolescents, where as the primary endpoint is sustained quantiferin conversion, so it's initial conversion, and then still being IGRA positive 3 to 6 months after. But also look at exploratory endpoints, and especially to see if correlates of protection can be identified. It started already in end of 2019. Its primary endpoint analysis anticipated in 2024. Now, I think most people find it very unlikely that there's going to be a large phase 3 POD clinical endpoint trial for this BCG revaccination. So one actually expects policy recommendation just based on the POI endpoint, probably somewhere 2025. Now, I mentioned these 3 other candidates. One is known as MIP or Immunovac. It is a heat-killed Mycobacterium indicus prani, and it came to the attention because it has been FDA approved as an immunotherapeutic and immunoprophylactic in leprosy. And earlier trials actually in TB have not been too promising. One of pericarditis didn't really show an effect. It did show an increase in HIV-associated cancers. A trial where they looked at recurrence. It was in retreatment patients. They looked at a sort of additional treatment effect. Didn't really show an increase in cure rate, and a trial of pulmonary TB has not yet been reported. But still, a phase 3 study is being planned for prevention of TB disease in exposed household contexts in India. So we're looking forward to seeing more about it, even though the earlier trials have not been too promising. A second one that was actually promising in the beginning, but is now a bit of a disappointment, is DAR 901. This is a whole cell killed Mycobacterium obuense. Phase 1 and phase 2A studies showed it to be safe and immunogenic. But just recently, a phase 2B trial was published that was done in Tanzania in adolescents that had been BCG vaccinated at birth but were IGRA negative and had quantiferon conversion or sustained quantiferon conversion as the endpoint, the clinical endpoint, so a POI endpoint trial. And it actually showed that after 36 months, for neither of these endpoints was any significant vaccine efficacy. As you can see here, this is really not a matter of sample size, it's just no effect whatsoever. So apparently this is not I don't think that this candidate is going to be carried any further. Then finally, one that is relatively far down the pipeline is H56IC31, which is a fusion protein of these 3 antigens here together with an adjuvant. That's for which they completed the phase 2-1 and 2A trials, and there is now an ongoing phase 2B trials looking at prevention of recurrence in South Africa and Tanzania. And actually here the manufacturer, which is the Danish SSI, is actually planning to try and license this basically for this purpose, for prevention of recurrence. So this is where we currently are. The M72 and BCG Revax and VPM1002 are potentially promising front runners, but it's going to take a while before we know. Now, a few words about recent developments in vaccine discovery. I think one very interesting one over the past years has been the success of a cytomegalovirus vectored vaccine. So that's basically Mycobacterium tuberculosis antigens inserted in a rhesus cytomegalovirus. They tried several viruses, and just sort of the overall story of what you can see here on this slide is that it was in non-human primates, it was tremendously effective. Some of the most effective combinations that one has seen, especially because it showed in 40% of animals, it showed complete neutralizing protection, which we've never seen, hardly ever seen with BCG. So this is something that's now being taken forward, and it's now in preclinical stage. Other areas of interest have been mucosal vaccination. There have been a number of studies of mucosal vaccination giving quite different results. But this study here that came from the Netherlands was one in which BCG was delivered to the lung mucosa by endobronchial instillation compared to intradermal administration. But they used a different system for which they think is more alike what happens in humans, a different system for challenging these animals with Mycobacterium tuberculosis, so-called repeated limiting dose challenge. So here the animals were vaccinated, either vaccinated or not, and then they were repeatedly challenged with very low doses. And as you can see here, This is this combination, BCG and MUC. It actually performs pretty well in the various readouts. And importantly, also here, a number of animals are completely protected. You can see here and here and here are completely protected, which hadn't been seen before. And the same was actually seen in this study, which I think was a real breakthrough, which showed that if BCG is administered intravenously, you can see tremendously strong effects here. And this was IV BCG. This is BCG given in various different ways. And you can see that with IV BCG, there is a sizable number of animals that had no sign of infection at all. So there was sterilizing, neutralizing protection. Again, what we haven't seen before. So apparently neutralizing protection can actually be achieved if even with BCG, if it is given in a particular way. Obviously, the question is whether intravenous administration is ever going to work in humans, but this is now being looked into. Now, finally, a few words about implementation, because that is, I think, still an important bottleneck to look at. Even though we don't have the vaccines yet, obviously, we need to do the work. So there's a couple of things that to me stand out. First is the efficacy and safety in people living with HIV. Clearly, people living with HIV are a high priority target group for TB vaccination. And there are two potential issues here. First is that TB vaccines may have different safety profile in people living with HIV, particularly if they are live attenuated. And as I mentioned, also VPM 102 is live attenuated. TB vaccine candidates may show reduced immunogenicity and protection in people living with HIV. So that's the other problem. So the implications for this is that phase 3 trials of candidate vaccines should include people living with HIV, at least for safety endpoints, ideally also for efficacy endpoints. The problem is that this may be prohibitive in terms of cost and sample sizes if we don't have correlates of protection. So this is currently a big matter of debate. And obviously safety and effectiveness in people living with HIV need to be monitored closely after a vaccine has been introduced. A second issue is the problem of the target group. So if we are looking for a vaccine for adolescents and adults, it has to be used in these groups effectively. And we have very little experience of immunizing adolescents and adults, especially in low middle income countries, where almost, if not all vaccines are given at very young age. So the questions here are, do we need vaccination campaigns? Then at what age, at which intervals? What are its logistical implications? For example, how do we deal then with cold chain, route of administration? Community engagement is going to be tremendously important. We know that from other vaccines. We know that from especially from Europe and the United States, but that's probably going to happen elsewhere as well. What's called vaccine hesitancy. So these are really things that need to be addressed. And the implications are that we need real life data on the requirements and best practices. And obviously, we can probably learn from the rollout that is now starting of SARS-CoV-2 vaccines, which are also given at these age groups. Then finally is that there is still limited political commitment and funding for implementing a new TB vaccine. And the issues here are that we don't know yet how the expected public health impact of a new vaccine compares to that of alternative interventions, for example, of tuberculosis preventive treatment. And now that it's becoming more and more accessible. Another issue is the cost of vaccination. Clearly, industry is not picking this up. So who is going to pick it up? How are we going to do this in a world where this vaccine needs to be given in countries where there is limited financial incentive? What will be the expected market size? It's going to be tremendously important to get manufacturers on board. And will multilateral funding mechanisms adopt a new TB vaccine? That's also very important. For example, Gavi, if they don't adopt it, who's going to pay for it in low-income countries? And the implications are that we need political and community engagement, and we definitely need funding mechanisms that guarantee manufacturing and rollout. So not only discovery and clinical studies, but also post-marketing. So in conclusion, first, an effective vaccine, in particular to prevent adult pulmonary disease, will be important to eliminate TB. 2. Key barriers to developing new TB vaccines include, first, limited knowledge of the human protective immune response. Second, lack of animal models that predict protection in humans. Third, lack of agreed laboratory correlates of protection. Fourth, as a result of that, need for large trials of long duration. And fifth, limited funding for TB vaccine R&D. 3. M72 and VPM1002 candidates are entering phase 3 and may be licensed within 10 to 12 years. BCG revaccination may become a policy recommendation for high incidence settings, even though we don't expect a phase 3 trial there. 4. The upstream pipeline is rather narrow, but there are promising new platforms and routes of administration. And 5. Key issues around implementation of new TB vaccines include efficacy and safety in people living with HIV, logistics of immunizing adults and adolescents, and lastly, political commitment and public funding. And with that, I would like to thank you for your attention.
The last speaker in this section is Dr. Todd Pollack. Dr. Pollack is an assistant professor of medicine at Harvard Medical School and infectious disease specialist at Bell Israel Deaconess Medical Center, and the director of Partnership for Health Advancement in Vietnam. For more than 10 years, Dr. Pollack has provided clinical support for the National HIV Program in Vietnam. He leads initiatives to improve the quality of care for people living with HIV. He also leads clinical implementation research, publishing on HIV and infectious diseases. Today, his topic is management of patients presenting with advanced HIV. Please welcome Dr. Pollack.
Many thanks to the organizers for inviting me to present at this year's Bangkok HIV Symposium. I'm Todd Pollack. I'm from the Partnership for Health Advancement in Vietnam, which is a project of Harvard Medical School working in Vietnam. And I'm going to give you an overview of the management of advanced HIV disease. So for this talk, I'm going to cover the following points: the definition of advanced HIV disease, the prevention of opportunistic infections associated with advanced HIV disease, some key points about diagnosis and treatment of opportunistic infections, namely tuberculosis and cryptococcal meningitis. I'll mention a little bit about COVID-19 and people living with HIV, and finish with some ongoing barriers to implementation of the package of care for those with advanced HIV disease. So here's just to start off with a global summary of the HIV epidemic at the end of 2019. We can see in 2019, there were 1.7 million people that were newly infected with HIV and 690,000 AIDS-related deaths globally. Although AIDS-related deaths have declined by 60% since the peak in 2004 and by 39% since 2010, the reduction failed to meet the global goal of less than 500,000 deaths per year by 2020. And estimates from UNAIDS show that missing this target has resulted in 820,000 more AIDS-related deaths since 2015 than if the world was on track to meet the 2020 targets. In this slide, we see AIDS-related deaths in the Asia-Pacific region. There were 160,000 AIDS-related deaths in 2019, which makes the Asia-Pacific region the region with the second most deaths behind Eastern and Southern Africa. There were 28% fewer deaths due to AIDS-related illnesses in Asia-Pacific region since 2010. This 29% reduction is largely due to some successful testing and treatment programs in countries such as Australia, Cambodia, and Thailand that have achieved the 90-90-90 targets. However, AIDS-related mortality rates are rising in some countries in the region, such as Afghanistan, Pakistan, and the Philippines. And overall, if we look at this graph, we can see a relative plateauing of the rate of decline over time. This plateau in the decline of AIDS-related deaths globally is largely due to the persistent challenge of advanced HIV disease and its associated high mortality. Advanced HIV disease is defined as a CD4 count of less than 200 or WHO clinical stage 3 or 4 for adults and adolescents and children older than 5 years old. And all children younger than 5 years old with HIV are considered as having advanced HIV disease. Advanced HIV disease is common. It's estimated that 1 in 3 people living with HIV present to care with advanced disease. And people presenting with advanced HIV disease are at high risk of opportunistic infections and death, even after they start on antiretroviral therapy. Leading causes of mortality among adults with advanced disease globally include tuberculosis, severe bacterial infections, cryptococcal meningitis, toxoplasmosis, and pneumocystis pneumonia. Also, advanced HIV disease did not only occur in ART-naive patients. An increasing proportion of those presenting with AHD are ART experienced, having either dropped out of care or having still been on ART, but failing to suppress their HIV viral load. In 2017, to address this persistent challenge, WHO released guidelines focused on the management of advanced HIV disease. Although the data is from a few years ago, this slide shows that the proportion of people presenting with advanced disease has remained largely unchanged over time. This proportion is higher in low middle-income countries compared to high-income countries. About 30 to 40% of people living with HIV starting ART in low and middle-income settings have a CD4 cell count of less than 200 cells per millimeter squared, cubed. And 20% have a CD4 cell count of less than 100. Here's more recent data from the UNAIDS Global AIDS Update in 2020, and I focus it on the Asia-Pacific region. The pale yellow bars shows the percent of patients who presented to initial care with a CD4 less than 200. We can see that many countries have nearly 50% of their patients presenting with advanced HIV disease. For example, if you look at Thailand, Vietnam, Philippines, and Indonesia, all have more than or nearly 50% of patients presenting with a CD4 count less than 200. Also, for many countries, the situation is not really improving. If you look at the boxes to the left of the graph, the orange boxes demonstrate that the trend is not improving. More than half of the countries who have data in which to compare over 2 or more years are not improving. So to address the problem of advanced HIV disease and its associated mortality, the first step, of course, is prevention. Earlier diagnosis, better linkage to care, and improved retention are needed. This includes scaling up diversified testing strategies, including lay testing and self-testing, and implementing index case testing among newly identified people living with HIV to seek and bring to care others from their networks for HIV testing and counseling. And of course, we have to address barriers to care, barriers to care access, especially stigma and discrimination. So let's talk about how to prevent opportunistic infections that are associated with advanced HIV disease. First of all, being able to identify advanced disease is crucial to ensure that people living with HIV receive proper interventions against the associated opportunistic infections. We know that up to 50% of people with advanced disease may be asymptomatic on presentation. And so the CD4 cell count testing is crucial for identifying those patients. Unfortunately, over the past years, CD4 cell count has been de-emphasized in many countries, in part because CD4 testing is no longer necessary to determine ART eligibility. In addition, the importance of CD4 monitoring was sort of lost during the scale-up of HIV viral load monitoring. In many places, including Vietnam where I work, resources for CD4 testing went directly toward viral load testing instead. So what we need is a re-emphasis on CD4 count testing at diagnosis and at re-entry to care. Point-of-care CD4 cell testing is now available, and WHO has provided guidance on the test characteristics needed for rapidly identifying people living with HIV with lower CD4 cell counts. A qualitative test that reports either greater than or lower than 200 cells may be sufficient to allow for screening and prophylaxis for opportunistic infections and for triggering advanced HIV disease-focused differentiated service delivery. This table summarizes the WHO recommended package of care for reducing mortality and morbidity among people with advanced HIV disease. It includes recommendations for enhanced prophylaxis against tuberculosis, cryptococcal meningitis, and severe bacterial infections, point-of-care screening and diagnosis for tuberculosis, rapid antiretroviral therapy initiation, and counseling and adherence support. So let's first start with rapid ART initiation. ART is the most important intervention to prevent mortality in advanced HIV disease. WHO recommends rapid ART for all people living with HIV following a confirmed diagnosis and clinical assessment. Rapid ART here is defined as within 7 days from the day of diagnosis, and people with advanced disease should be given priority for assessment and initiation of treatment. Integrase inhibitor-based regimens are recommended as first-line therapy and may be especially important in this subgroup of patients due to their ability to rapidly decrease the HIV viral load. At the same time, this characteristic could increase the risk for IRIS, but studies to date have not shown a significantly higher rate of IRIS compared with other non-integrase-based inhibitor regimens. Nonetheless, people with advanced HIV disease require closer follow-up during the initial period of ART, when the risk of mortality is the highest. When selecting an ART regimen, there are some special considerations for patients with low CD4 cell counts or high HIV viral loads. These are summarized in the table on this slide. For example, rilpivirine and dual therapy boosted darunavir plus raltegravir should be avoided due to higher rates of virological failure in those with a CD4 count less than 200 and a viral load greater than 100,000 copies per milliliter. Now let's move on to OI prophylaxis. Firstly, I want to remind you about the reality trial, which was published in 2017, which was an open label trial conducted in Uganda, Zimbabwe, Malawi, and Kenya that enrolled HIV-infected adults and children 5 years of age or older who had not received previous ART and were starting ART with a CD4 cell count of less than 100. 1,805 patients were randomized to receive either enhanced prophylaxis or standard prophylaxis and were followed for 48 weeks. Enhanced prophylaxis included 12 weeks of isoniazid, 12 weeks of fluconazole, 5 days of azithromycin, and a single dose of albendazole. Standard prophylaxis included cotrimoxazole alone. Patients who had started the enhanced prophylaxis package at the time of ART initiation had a 27% lower rate of death at 24 weeks than those who had received standard prophylaxis. The incidence of TB was significantly lower with the enhanced prophylaxis compared with the standard prophylaxis, as was the incidence of cryptococcal disease, candidiasis, and new hospitalizations. The results of this study directly informed the WHO recommendations for management of advanced HIV disease. Based on the reality study and other previous studies, it is clear that scaling up TB preventative therapy is necessary to reduce mortality from advanced HIV disease. TB is the most common cause of death among people living with HIV worldwide, accounting for 1/3 of all HIV-related deaths. The good news is that in recent years, there was renewed political will, with commitments from the United Nations and PEPFAR to dramatically increase the number of patients who receive TB preventive therapy. As you can see in this graph from the 2020 WHO TB report, preventative treatment for tuberculosis among people living with HIV in the 65 high-burden countries has improved dramatically in recent years. However, despite this progress, gaps still remain. I show this slide to point out that the largest gains in TB preventive therapy are coming from Africa, whereas the increase in TPT in Southeast Asia and Western Pacific regions is less significant. So what are the factors contributing to these ongoing gaps? Some are listed on this slide, including a delay in rolling out the short course TPT regimens due to procurement delays related to rifapentine. For example, in Vietnam, where I work, PEPFAR planned to procure rifapentine for around 20,000 people living with HIV in 2020, but the procurement was delayed. Secondly, healthcare workers may still not fully understand the benefits of TPT. I found this to be the case, especially for patients already on ART or those with high CD4 counts. And in the busy clinic settings, counseling patients through side effects may prove difficult and result in unnecessary discontinuations. Improved systems for tracking patients, including initiation of TPT and completion rates, with reporting back to providers and managers at the site level, will help with accountability and quality improvement. Now let's move to cryptococcal meningitis. South and Southeast Asia have the second highest burden of cryptococcal meningitis among people living with HIV after sub-Saharan Africa. Here I want to highlight the REMSTAR trial, which was conducted in Tanzania and Zambia, where they randomized 1,999 ART-naive adults living with HIV with a CD4 count less than 200 to receive enhanced clinic-based care with a point-of-care serum cryptococcal antigen screening and preemptive antifungal treatment for those who tested CRAG positive, and additional community support compared with standard care. This intervention led to a 28% reduction in mortality among people presenting with advanced HIV disease. Mortality was 13% in the intervention arm and versus 18% in the group that received standard of care. It also led to a decreased rate of hospitalizations. So the REMSTART and the REALITY trial have informed the WHO recommendations on screening for and preventing cryptococcal disease. I've listed those recommendations here. Screening for cryptococcal antigen followed by preemptive antifungal therapy among CRAG-positive people is recommended before initiating or reinitiating ART for people living with HIV with a CD4 cell count of less than 100. This is a strong recommendation and may be considered at a CD4 cell count of less than 200. This is a conditional recommendation. When cryptococcal antigen screening is not available, fluconazole primary prophylaxis should be given to those with a CD4 cell count less than 100. Again, a strong recommendation, and may be considered at a CD4 cell count of less than 200. However, there are ongoing barriers to implementation of these recommendations as well. In the Vietnam context, we have some studies that have looked at the prevalence of cryptococcal antigen positivity, and it's about 2.7 to 4% among those with a CD4 count less than 100. The Vietnam national guidelines do follow WHO guidelines in recommending CRAG testing plus preemptive fluconazole treatment. However, CRAG testing is not readily available, and to my knowledge is not currently being performed outside of research studies. Furthermore, the current guidelines do not recommend primary fluconazole prophylaxis in the absence of CRAG testing. So a renewed effort is needed to ensure supply chain and financial payment mechanisms are in place to allow for cryptococcal screening. And guideline revisions should allow for primary fluconazole prophylaxis in the absence of such mechanisms. Moving on to severe bacterial infections. These are estimated to contribute to over 1/3 of hospitalizations of people living with HIV globally. The full impact of bacterial infections on mortality in advanced HIV disease is difficult to estimate due to a lack of diagnostic capabilities in many settings. In the reality study, bacterial infection-related mortality rates did not differ between the two study arms, between those who had the enhanced prophylaxis and the standard of care. And with concerns about antimicrobial resistance, cost, and supply chain issues, further prophylaxis beyond cotrimoxazole is not currently recommended for preventing severe bacterial infections. More studies are needed on the prevention of mortality from severe bacterial infections among people living with HIV with advanced HIV disease. Now let's talk about diagnosing and treating opportunistic infections. I'm going to focus on diagnostics for TB. More sensitive, rapid TB diagnostic tests suitable for use at the primary healthcare clinic level are needed so that people with TB can be correctly identified and promptly treated. A few studies now have looked at the use of empirical treatment of tuberculosis in all patients with low CD4 counts, such as those less than 50, but they have failed to show a mortality benefit to that approach. Therefore, scaling up implementation of point-of-care TB diagnostics for people living with HIV should be the priority now to reduce TB-related mortality. A new urine lateral flow LAM test with improved sensitivity and preserved specificity in comparison with the currently used test may soon be available and is expected to improve the diagnosis of TB among people living with HIV with advanced disease. For example, PEPFAR is anticipating the use of the point-of-care CD4 cell test, followed by the lateral flow LAM test for all patients with a CD4 cell count less than 200. For cryptococcal meningitis, I want to focus on treatment regimens, as the ACTA study published in 2018 demonstrated the effectiveness of two new regimens for induction therapy that are easier to implement in low-middle income countries. 1 week of amphotericin B plus flucytosine, and 2 weeks of an all-oral regimen of flucytosine plus fluconazole. Importantly, this study shows the importance of including flucytosine in the induction phase of the treatment regimen for cryptococcal meningitis. So here I remind you of the latest guidelines from WHO published in 2018 for the treatment of cryptococcal meningitis. For the induction phase, you have the option, as I mentioned, of the 1 week amphotericin B plus flucytosine therapy, followed by 1 week of fluconazole, or 2 weeks of the all-oral regimen of fluconazole plus flucytosine. Or the third option is 2 weeks of amphotericin B plus fluconazole. Consolidation is fluconazole 800 milligrams per day for adults times 8 weeks, and maintenance is fluconazole 200 milligrams a day for adults. Now, the lack of progress on reducing mortality related to cryptococcal meningitis, despite the advances in prevention and treatment, have led for calls for a global strategy to end deaths from HIV-related cryptococcal meningitis by 2030. This commentary, published just a few weeks ago around World AIDS Day, calls for a strategy that includes access to testing for CD4 cell count and cryptococcal antigen for all patients in need, fluconazole and flucytosine in every clinic, and flucytosine and amphotericin B with laboratories able to support safe administration in every hospital. A renewed focus on cryptococcal meningitis can result in reduced mortality for patients with advanced HIV disease. Now, I just want to mention a few words about other infections that cause mortality in people living with HIV and advanced disease. I focused on tuberculosis and cryptococcal meningitis. However, other fungal diseases contribute significantly to the mortality in advanced disease, depending on the local epidemiology. WHO just released new guidelines focused on histoplasma. And PCP and penicilliosis are very prevalent in some countries in our region. I don't have time to go into the details on these today. But I do want to finally mention about COVID-19 in people living with HIV, as new data is becoming available every day. The data on whether a person living with HIV is at increased risk for severe disease or death from COVID-19 is mixed. Some studies have shown a higher crude mortality among people living with HIV compared to the general population, but this increased risk seems to be driven primarily by the high burden of comorbidities in people living with HIV. However, two large cohort studies, one from South Africa, which is in a preprint form and has not yet been peer-reviewed, and one published study from the UK, demonstrate a similar, more than 2 times risk of death, even after adjusting for other factors. The South Africa study, however, showed no difference in mortality across different strata of HIV viral load and immunosuppression level. And the UK study had no data on CD4 cell counts or viral load tests in their data set. Making progress in reducing age-related deaths requires a focus on overcoming programmatic implementation challenges. We need more data to help us understand the scope of the problem within each country and each region. Countries need to prioritize the registration, procurement, and distribution of needed diagnostic tests and medications such as rifapentine and flucytosine. Implementation of the advanced HIV disease package of care requires healthcare worker training, facility readiness, and community engagement. An expansion of HIV testing, reduction of stigma and discrimination can lead to earlier HIV diagnosis and prevention of advanced disease. So to summarize, WHO recommends a package of interventions to reduce mortality and morbidity among people with advanced HIV disease. CD4 testing at baseline and at re-entry to care is important to quickly and accurately identify patients with advanced HIV disease. Patients with advanced disease should receive priority for rapid ART initiation with close counseling and follow-up, and should receive enhanced OI prophylaxis, including cotrimoxazole, TB preventive therapy, and fluconazole preemptive therapy for those who test cryptococcal antigen positive. Better point-of-care tests for TB will improve TB diagnosis and facilitate quicker linkage to treatment. Utilizing all available tools, including easier-to-use treatment regimens, can significantly reduce mortality associated with cryptococcal meningitis. And more progress is needed to prevent advanced HIV disease through earlier HIV diagnosis and so that we can raise the mean CD4 count that patients present at ART initiation. Thank you very much for your attention.
HIV-NAT stands for the HIV Netherlands Australia Thailand Research Corporation. It is Asia's first HIV clinical trial center established in Bangkok in 1996. It started from the burning need of having life-saving medications for thousands of infected Thai patients at that time. AIDS came to Thailand in mid-1980. By mid-1990, several thousands of Thais have been infected. Most of them were untreated, mainly because of the high cost of medications. In early 1990, I had the chance to meet Professor David Cooper from Sydney and Professor Juk Lange from Amsterdam. Both of them were famous HIV/AIDS clinicians. They also had their own HIV clinical trials unit in their own countries. So I asked both professors to help me setting up a similar trials unit in Bangkok so that Thai patients can benefit from the free AIDS drugs by clinical trial settings. Fortunately, both Professor Cooper and Professor Lange were able to convince the drug companies at that time to invest setting up a similar trials unit in Bangkok. HIV-NAT opened its door in July 1996 at the King Chulalongkorn Hospital of the Thai Red Cross Society. At that time, there were only 3 staff, including one doctor, Dr. Eugene Kroon from Amsterdam. Right now, HIV-NAT is an organization with 120 personnel with 5 doctors. At the beginning, HIV-NAT performed a post-marketing drug trials by comparing the safety and tolerability and efficacy of various combinations of antiretrovirals. Later on, it gradually gained recognition to the point that HIV-NAT can join international new drug studies, including the strategic trials like a when to start trial. HIV-NAT started by doing post-marketing drug trials by comparing various combinations and various dosing regimens of many antiretroviral drugs. It gradually gained recognition to the point that HIV-NAT can be involved in.
The next sections will be pharmacology and toxicology of ART. Our first speaker in this section is Dr. Charles Flexner. Dr. Flexner is Professor of Medicine in the Division of Clinical Pharmacology and Infectious Disease and Professor of Pharmacology and Molecular Science at the Johns Hopkins University School of Medicine. He is an expert on basics and clinical pharmacology of drugs for HIV and related infections, including viral hepatitis and tuberculosis. His current research includes the discovery and development of new molecules and information for long-acting parenteral administration for treatment and prevention of HIV infections. His topic today is new ART and ART formulation. Please welcome Dr. Flexner.
Hello, I'm Dr. Charles Flexner from Johns Hopkins University in Baltimore, Maryland. And for the next 30 minutes, we're going to be talking about new antiretroviral therapy, including drugs and formulations. These are my disclosures as required by the organizers of the meeting. At present, in late 2020, there are more than 20 different agents in development for treatment and prevention of HIV. That's especially true if you consider the large number of broadly neutralizing monoclonal antibodies or bNAbs that are being developed by a variety of agencies. Obviously, in 30 minutes, we could not possibly cover all of these agents. And so I'm going to focus on the small molecules and long-acting formulations that are in the most advanced clinical development. Let's start with small molecules being developed largely for heavily treatment-experienced patients with multi-drug resistant HIV. These agents have a number of targets, mostly in the interior of the cell, designed to prevent the maturation of products of the P24 antigen gene, including the capsid protein. And there are several of these small molecules in clinical development currently. That includes Beviramat, which is in phase 2, but has shown that about half of treatment-experienced patients had no response due to polymorphisms in the GP120 envelope gene. GSK 3532795 in phase 2b, which has produced a significant drop in viral load in the majority of patients, 76 to 83%, but was associated with gastrointestinal intolerance. GSK 2838232 in phase 2a has produced a 1.7 log average drop in viral load at day 10, but requires boosting. And finally, GSK 3640254 is about to begin phase 2 testing. All of these agents are oral, and at present, all of them need to be given at least once per day, if not more frequently. On the other hand, there's substantially more activity and perhaps more excitement about long-acting formulations being developed for treatment and prevention. And I'm going to start with long-acting cabotegravir and long-acting rilpivirine. These two studies have presented the phase 3 results demonstrating safety and efficacy of this two-drug combination in individuals previously taking oral antiretroviral therapy. The so-called ATLAS study was carried out in antiretroviral experienced patients who were randomized to continue their daily oral therapy or switch to a 4-week run-in of oral cabotegravir and rilpivirine to assure tolerance, followed by a switch to 48 weeks of injectable cabotegravir and rilpivirine as their sole antiretroviral treatment. The FLAIR study had a nearly identical design, but took place in treatment-naive patients who received 20 weeks of a co-formulated daily oral dolutegravir-based regimen before being randomized to the all-injectable regimen or continued oral drugs. The ATLAS study showed that the injectable regimen was non-inferior to the continued daily oral regimen, whether one looked at the number of patients failing therapy or the number of patients in whom continued therapy was successful. And that's shown in this slide. Now, unfortunately, there were some cases of resistance to rilpivirine and cabotegravir in these registrational studies, although resistance was rare. There were 3 cases reported in the ATLAS study. All 3 of these patients had resistance to rilpivirine, with 1 having resistance to both rilpivirine and cabotegravir, and all 3 cases occurred in individuals with subtype A or a hybrid AG virus. These are viruses that are most common in Eastern Europe and in Central and Eastern Africa. In addition, the plasma cabotegravir and rilpivirine concentrations at the time of failure were below the population means for all 3 of these patients, but within the range for the large majority of individuals who maintained virologic suppression. And thus, most of the people who had drug concentrations on the low end actually had successful therapy with cabotegravir and rilpivirine. Now, the FLAIR study, this was the study in treatment-naive individuals, had nearly identical results. That is, the primary endpoint showed that the long-acting therapy was non-inferior in terms of the number of patients with viral load undetectable at week 48, viral load detectable at week 48, and similarly with the key secondary endpoint, the number of patients who had undetectable viral load at week 48. But like the ATLAS study, there were 3 cases of resistance in the FLAIR study, and again, 2 of these 3 patients had resistance to rilpivirine, and 3 had resistance to cabotegravir. All 3 had subtype A virus at baseline and also had low concentrations as compared to the low drug concentrations as compared to the population means. Now, the ATLAS study had an extension which changed the administration frequency of the long-acting injectables from once every 4 weeks to once every 8 weeks. And so at the end of ATLAS, participants were offered the option of switching to this extension arm in which they were randomized to either every 4-week cabotegravir and rilpivirine or every 8-week cabotegravir and rilpivirine. And at the end of 48 weeks, the every 8-week regimen was non-inferior to the every 4-week regimen based on either the primary endpoint, that is the number of virologic failures, or the key secondary endpoint, that is the number of patients with an undetectable viral load. It's important to point out, however, that when the treatment failures on ATLAS were evaluated, there were 8 patients with confirmed virologic failure on the every 8-week regimen and 2 on the every 4-week regimen. 6 of these 8 on the every 8-week regimen had rilpivirine resistance mutations. And so although resistance was still rare, there was more resistance on the every 8-week regimen than on the every 4-week regimen. So cabotegravir and rilpivirine given every 4 weeks or every 8 weeks were non-inferior to standard of care antiretroviral therapy in 2 phase 3 clinical trials. Resistance to these drugs was rare, but mainly seen in patients with subtype A virus. Also, most of these patients had the L74I polymorphism in the integrase gene at baseline. All patients had cabotegravir concentrations in the lower quartile, and resistance was more common with the every 8-week regimen than with the every 4-week regimen. Only a single patient developed resistance because of discontinuation of therapy, and all of these treatment failures with resistance occurred in people who showed up regularly for their every 4-week or every 8-week injections. This 2-drug combination has now been approved for prescription use in Canada, has been given a favorable review by the European Medicines Agency, and is under review by the FDA in the United States, with approval expected sometime in 2021. Now, that was treatment with cabotegravir and rilpivirine. What about prevention with these long-acting formulations? Well, I'm going to talk to you about the results of a large randomized trial conducted by the HIV Prevention Trials Network, in which a long-acting injectable formulation went head-to-head with a 1-pill once-per-day PrEP regimen for HIV prevention. And this was the HPTN 083 study, presented this past summer by Raphael Landowitz from the University of California at Los Angeles. This study took about 4,500 men who have sex with men and transgender women and randomized them to an arm of injectable cabotegravir for PrEP or a daily oral tenofovir and emtricitabine for PrEP. However, this was a double-blind, double-dummy trial. So every participant was asked to take pills every day, and every participant was asked to come in and get an injection every 8 weeks. The injection would either be cabotegravir or cabotegravir placebo, and the pills would either be tenofovir emtricitabine or tenofovir emtricitabine placebo. The length of the study was based on the number of events, that is HIV seroconversions, and the study was stopped by the Data Safety and Monitoring Board after an average on-study duration of nearly 2 years. So there were 52 HIV infections, 1.4 years median participant follow-up, and the final analysis showed that the risk of failing PrEP was about 3 times as high in the daily oral arm as in the injectable arm. So there were only 13 infections in the injectable cabotegravir arm and 39 infections in the tenofovir M-tricytidine arm, a highly statistically significant outcome. Following the first 6 months of the study, there was a continual divergence between the oral arm and the injectable arm, suggesting that the benefit of injectable therapy was maintained throughout the duration of the study. Now, in addition to this large study in men who have sex with men and transgender women, there was also a large randomized prospective study carried out by the HIV Prevention Trials Network in cisgender women, most of whom had a heterosexual risk factor for HIV infection. This study enrolled about 3,200 women, and the study design was identical to that of the HPTN 083 study, that is a double-blind, double-dummy, so everybody took pills and got an injection every 2 months. But one arm received only injectable cabotegravir as their active PrEP, and the other arm received only oral tenofovir and M-tricytidine as their active PrEP. The DSMB asked for unblinding in November of this year because of an unexpected difference in efficacy in the two arms. And that difference favored the injectable arm. In fact, it greatly favored the injectable arm. When the study was stopped, there were 34 HIV infections in the daily oral tenofovir M-tricytidine group, and only 4 infections in the long-acting cabotegravir group. Again, a highly statistically significant difference, and about 9 times the infection risk with oral therapy as compared to daily every 8 weeks injectable cabotegravir. I think there are some important implications of the HPTN 083 and 084 studies. The first is that one drug, cabotegravir, was actually better than 2 drugs, tenofovir and M-tricytidine, for HIV prevention. At this point, it's unclear exactly why that difference occurred. One issue is the better pharmacokinetic profile over time of the injectable cabotegravir regimen, such that drug concentrations were maintained in the vast majority of study participants above the targets necessary to prevent infection with HIV. It also appears that there was non-adherence to daily oral PrEP, not unexpectedly, but it's possible that the difference between non-adherence with daily oral PrEP and the coverage of injectable cabotegravir every 2 months explain this resistance. It's also true that cabotegravir has a higher barrier to resistance than tenofovir or M-tricytidine, and that may have played a role, but it could be something else that still remains to be determined, and I think we're going to learn a lot more about this in the coming 12 to 18 months. Regardless of the cause or reason, this is a clear demonstration of the benefits of a long-acting formulation as compared to standard 1 pill once per day antiretrovirals for prevention. I'm going to move on now and talk about the next new long-acting small molecule, and that is lenacapavir, a capsid inhibitor developed by Gilead that is administered subcutaneously, unlike cabotegravir and rilpivirine, which are administered intramuscularly. So how do capsid inhibitors work? Well, this capsid inhibitor is a small molecule that blocks maturation of the HIV capsid protein, but also interferes with its translocation in the nucleus, thus interfering with HIV integration once the virus gets into the cell. So the drug has several distinct mechanisms of action which may contribute to its potency and efficacy. The drug does have an exceedingly low EC50 in peripheral blood mononuclear cells. It's active against all HIV subtypes. The resistance variants that do emerge in vitro have very low fitness and therefore may have a difficult time propagating in the clinical setting. The drug also has very low clearance and solubility such that it has a very long half-life when given subcutaneously, a half-life in humans of 30 to 43 days. Both oral and subcutaneous formulations are in development. The oral formulation mainly to assure tolerability, but also to allow the company to conduct drug interaction studies. The drug has very potent anti-HIV activity in short-term 10-day monotherapy studies, shown in this figure, at doses ranging from a single dose of 20 milligrams to a single dose of 450 milligrams, with up to a mean of 2.2 logs a decrease in a viral load at 10 days, as potent as the activity in humans of any other antiretroviral monotherapy. And phase 2 studies with this drug are in progress. But the drug is a long-acting injectable formulation, and this study looks at the pharmacokinetic profile in HIV or HIV seronegative individuals given 3 different single subcutaneous injections of lenacapavir, ranging from 300 milligrams in the blue to 900 milligrams in the gray and the yellow, either given as 3 1 milliliter subcutaneous injections or 2 1.5 milliliter subcutaneous injections. And what you can see from this pharmacokinetic profile is that the drug reaches and maintains target anti-HIV concentrations, in this case, 6 times or greater the inhibitory quotient for in vitro inhibition of HIV. And those levels can be maintained for at least 6 months, 24 weeks in these small phase 1 studies. But that suggests that this drug could be given on an every 6-month basis as a subcutaneous injection. We'll move on now from injectables to implantables. And we're going to talk about islatravir, a new anti-HIV drug that is also being developed as an implant. So why would one want to develop an implant in the first place? Well, implants have potential advantages over injectables. That includes the fact that they are removable. That is especially true for the inert or early bioerodible forms after they are placed in case of adverse events. They provide more consistent and predictable drug release than injectables, particularly intramuscular injections, and the pharmacokinetics are therefore not dependent on the injection site. Some of these implants can remain in place for years. The inert, non-degradable subcutaneous contraceptive implants, for example, may remain in place for 3 to 5 years before they need to be replaced. But there are some potential disadvantages over injectables. There is a specialized device required for insertion. There is a minor surgical procedure required to remove these devices if they need to be removed. At the end of their usable lifespan, that is when they run out of active drug, they need to be removed and replaced because one cannot tell by palpation whether or not these implants still are releasing active drug. Their regulation is more complicated than that of injectable long-acting formulations because they're regulated as both a drug and a device. And that may introduce some difficulties in moving these drugs into a generic marketplace, as would be required for use in most low and middle income countries. Now, there is a lot of experience in the field with implantable drugs, particularly in the field of hormonal contraception. Over 40 million women worldwide now use injectable contraception, And nearly half of modern contraception users in sub-Saharan Africa rely on injectable contraceptives to prevent pregnancy, as opposed to oral contraceptives. However, returning to a healthcare provider for an injection every 2 to 3 months has been considered a disadvantage of DMPA, methoxyprogesterone acetate, which is the most common injectable form of hormonal contraception worldwide. And the discontinuation rates of injectable contraception in sub-Saharan Africa are therefore high. And that's contributed to the growing popularity of longer-acting implants. There are several of these now available in a generic format. For example, Norplant 2, which is levonorgestrel, is available as Jadel, Levoplant, or Sinoplant. These are 2 small rods which are implanted once to deliver 5 years of effective contraception. And that 2-rod implant is now being used by millions of women in sub-Saharan Africa. The cost is surprisingly low. The cost per generic implant is less than $15 US, or about $3 US per patient per year for effective hormonal contraception, making this by far one of the most cost-effective means of contraception currently available. So along comes islatravir. Islatravir is also known as EFDA. It is a deoxyadenosine analog. It has a unique mechanism of action as an nucleoside reverse transcriptase inhibitor. It does terminate the DNA chain like other NRTIs, but it inhibits reverse transcriptase by preventing translocation of the replication complex. And that may lead to some of its unique anti-HIV properties. It also has a very long half-life, 50 to 60-hour half-life for the parent drug in the plasma, and a half-life well over 100 hours for the active metabolite, which is the nucleoside triphosphate inside human peripheral blood mononuclear cells. The drug is exceedingly potent, with an EC50 of about 200 picomolar and broad HIV coverage in terms of strains, including multi-drug resistant strains. There is a low-dose oral formulation as well as parenteral formulations in development, and the drug is currently entering phase 2 studies as an oral drug, either in combination with other agents for treatment of HIV or as a standalone agent for HIV prevention or PrEP. The drug has very potent anti-HIV activity when given in these short-term 10-day monotherapy studies. And this is a figure looking at the drop in HIV viral load in patients not taking other antiretrovirals who are given doses of islatravir as low as 0.5 milligrams as a single oral dose. Now, the high potency of islatravir also makes it a good candidate for formulation into an implant. And because the folks at Merck who are developing islatravir also develop implantable Nexplanon, which is a hormonal contraceptive implant, have used that same technology to develop islatravir implants for HIV prevention and possibly eventually for HIV treatment. And so the islatravir implant uses the same polymer, the same design as the Nexplanon implant, which is an etonogestrel implant. It is a non-bioerodible, removable implant, and it uses the same applicator as Nexplanon, which is shown here. And any healthcare provider can be trained to administer this implant subdermally. This is the simulated pharmacokinetic profile of an islatravir implant as compared to oral islatravir given as a 2 milligram single tablet once every week, showing the implant pharmacokinetics in the blue over 6 months, and the, over 4 months, and the every weekly islatravir in the red. These are actual data of humans who are HIV seronegative, human volunteers, given one of two types of islatravir implants. Either a 54 milligram implant on the left or a 62 milligram implant on the right. And the target for islatravir concentrations is shown here in the dashed line in the blue, and that is a target for several fold above the expected EC90 in peripheral blood mononuclear cells in humans. And so this is not islatravir in the plasma. This is actually the islatravir triphosphate, the active metabolite, being measured intracellularly in human peripheral blood mononuclear cells. And in this particular phase 1 study, islatravir implant is inserted at time 0 and then removed in these HIV seronegative volunteers at week 12. And in both cases, the mean islatravir concentrations are maintained well above target, but you get much higher concentrations with this 62 milligram implant as compared to the 54 milligram implant. A few of these recipients dropped below the target with their intracellular triphosphate concentrations, but none of these recipients dropped below target with their islatravir implant. Once the implant was removed, the decay of islatravir concentrations was as expected based on what was seen with orally administered islatravir. And what this proves is that all of the islatravir in these study participants is coming from the implant. That is, there's no local or distant depot of islatravir formed in these recipients, and thus when you remove the implant, the drug degrades at its expected rate. Now this is projected islatravir concentrations over time based on those 12-week studies. And based on the 12-week studies, modeling exercises suggest that a 62 milligram implant of islatravir could produce concentrations well above target, that is 0.05 picomoles per million peripheral blood mononuclear cells, which is the HIV prevention threshold. Those concentrations would be sustained for at least 52 weeks a year. And so now we have a practical approach to deliver an antiretroviral in people for more than a year with a single administration. So this is another potential game changer certainly in HIV prevention. And if we could find a partner for islatravir implants, it would also be a game changer for HIV treatment. So in summary, there are more than 20 investigational antiretroviral drugs and biologics in clinical development in 2020. We've talked about just a few of those today, some that I think are some of the most exciting and most likely to make it to drug approval. Most of these agents have exceedingly long half-lives and/or are formulated for long-acting extended release delivery. And in the near future, antiretroviral regimens for HIV treatment and prevention may involve drug administration once every 6 to 12 months or even longer. And so I think this is an exciting part of our future for HIV treatment and prevention, and something we all can look forward to. I want to end now, and I want to thank those who were willing to share with me their slides, some of which included unpublished data. I want to especially recognize Marta Bofito at Chelsea and Westminster Hospital in London, William Spreen at ViiV Healthcare, Roy Gulick at Cornell Medical Center in New York City, Susan Swindells at the University of Nebraska Medical Center, and Raphael Landovitz at the University of California, Los Angeles. And I would also like to acknowledge my funding sources that sustain my interest and research in this area. And also, I would recommend to you, if you are interested in learning more about long-acting HIV formulations, to come to the website for my research resource program, LEAP, the Long-Acting Extended Release Antiretroviral Research Program. Here is our web address, longactinghiv.org, and there will be much more information there for you, as well as links to recently completed studies. So I want to thank you for your attention today. I hope this presentation has been useful, and I hope you are all enjoying this conference. Goodbye.
The next topic is weight and metabolic change and ART. The speaker of this topic is Professor Mark Boyd. Professor Mark Boyd is the founding chair of medicine at the University of Adelaide and the director of research at the Northern Adelaide Local Health Network in the state of South Australia. Professor Boyd is an awardee for Frank Freinet Prize for Advanced Research in Infectious Disease by Australian Society in Infectious Disease for the clinical research that changed WHO guidelines for the use of antiretroviral therapy worldwide. Please welcome Professor Boyd.
Thank you very much for that introduction, and I'm very pleased to be invited by the organisers of the 23rd Bangkok International Symposium on HIV medicine to present on this very interesting and controversial topic. For those of you who don't know me, my name is Mark Boyd. I'm actually one of the early clinical project leaders who worked at HIV-NAT. I worked there from actually the Bangkok Symposium of 2000, which I think might have been the 5th or something. That's when I began work at the Student Syndicate. And I finished the end of 2003. So I spent 4 years at HIV-NAT. And I'm very pleased, very proud of the fact that HIV-NAT has been such a successful clinical research unit, as well as, of course, the Thai Red Cross AIDS Research Society. I'm very pleased and proud to have had a small part in the success of that unit. It's been about 10 years or more since I was asked to present here, so it's nice to be back in the year 2021. I've been asked to present on antiretroviral therapy, weight and metabolic changes. And this is the sort of outline of the talk I want to give. I have about 30 minutes. I've got quite a bit to get through, but I'm hoping I can keep it relatively simple. First, I want to talk actually a little bit about science, and I'll explain who Ockham was in a minute. Then I want to talk about the global health problem of overweight and obesity, because this is a problem plaguing the entire world, and particularly countries like mine at the moment, with very little clear way to resolve that. I want to focus mainly on randomised controlled trial data on ART, weight gain and metabolic changes, because there's an enormous amount of data out there. The quality varies considerably, and by preference, randomised controlled data tends to give us more reliable findings. So I'm going to try and focus on that. And in that, I'm going to talk about 3 studies in particular: the pooled randomised control analysis, and the advanced study, and NAMCEL. Then I want to sort of pick through a few other data and insights that I think we can gain about this problem and try and find a simplified explanation. I want to talk about the weight gaining or weight losing capacities of tenofovir in both its disoproxyl fumarate salt as well as its alafenamide salt, in other words, TDF versus TAF. I want to talk a little bit about observations about efavirenz pharmacokinetics and weight change, weight gain after pregnancy in women living with HIV, and also to make the point that a lot of what we're seeing is possibly explained not by the drugs themselves, but by what I would call social determinants, which we tend to forget a lot in our very biomedically focused way of thinking about health and disease. The last thing is to mention a little bit about what metabolic changes and then make some conclusions. So I want to talk with you a little bit about philosophy of science and what science is. The man depicted on the right-hand side of your screens is an approximation of what William of Ockham might have looked like. Notice the different spellings, by the way, of Ockham. William of Ockham was a thinker, a monk and a thinker, as most people were in those days. The people that got to read and think were basically people in the religious orders, because everyone else was just working to stay alive. Ockham is sort of thought about one of the first people who started to think that maybe the explanations for what went on in the world weren't necessarily to do with spirits and gods and phenomena like that, which really dominated the thought of this period, which is, now 800 years ago. He thought maybe there were other explanations that were perhaps a bit simpler from the material world, which was different from the spirit world or the world of God. And an example here, he lends his name, he's most famous in lending his name to a principle known as Occam's razor. And the notion is that if you have two explanations for a phenomena, you basically should choose the simpler one, because that's a simple explanation is likely to explain complexity more than a complex explanation will, if you can find a simple explanation. So here's an example on the left-hand side of your screen. Why did the tree fall down? You come out of your house, it's been a windy night, and the tree fell down. So there's two possible explanations. There's maybe many explanations, but two might be, well, the wind knocked down the tree. And the other one might be, well, there were two meteorites hit the Earth. One hit the tree and knocked it down, and then it hit the other meteorite, therefore obliterating evidence of its existence. That's quite complex. So basically, the notion is the simpler explanation that the wind knocked down the tree, the obvious one you might say, is the one you should choose. And this is a principle we use in science to this day. An elegant, simple explanation generally will trump a complex, messy one. That's an important thing to remember when we talk about how we interpret data, of which there's so much of course, these days. And in this topic, weight gain and antiretrovirals, there's all sorts of data, and some of it gets very hard to understand what's underlying it all. What about overweight obesity as a global public health problem? Well, I think everybody in the audience should certainly be aware of this, perhaps not so much in Thailand, where you don't have such a big problem. But where I live, we have a big problem with overweight and obesity. This is a map actually taken of the 2006 estimates of the prevalence of having a body mass index equal to or greater than 30, which defines people that are obese. And what you can see here is if you look at the darker the colour gets, the more prevalence, the greater prevalence of obesity exists. And what you can see is that when you look at the USA, or you look at Saudi Arabia, interestingly, or you look at somewhere like even Australia and New Zealand, certainly USA, Saudi Arabia are probably more than 40% of people in that society are considered to be obese. That is, have a body mass index greater than 30. And you can see the other blue colours like South Africa, the southern part of Latin America, Chile and Argentina and Uruguay, Canada, Australia, New Zealand. We also are quite big, although perhaps not quite big as the USA. If you look at places like Thailand, for instance, you can see that you're a lot better off if you consider that being obese is predisposes you to all sorts of diseases, not just cardiovascular disease, but all number of illnesses and also premature death by about 4 years. You can see that places like the US are in big trouble. Places like Thailand, India, Southeast Asia in general, except perhaps parts of Malaysia, they're generally only about 10 to 15% of people are obese. So they're much thinner, and that's something that I noticed when I travel to Thailand. When I travel to Thailand, I haven't been able to recently, of course, you notice that people are, in general, much trimmer, much leaner, much more healthy looking than they are in Australia, where I see a lot of big people, and sadly, I have to include myself in that at the moment. And that's not something which I'm proud. If you look at the US, just focusing on the US, you can see here that all the hot colours is the percentage of obese adults. So again, people with a body mass index greater than 30. You can see that every single state, pretty much in the continental USA, not so much Hawaii, but Alaska, yes. Colorado is the only one where the percentage of people in the community are obese is 20 to 25%, still a quarter of people. But nevertheless, some of these places have 30, 35% where everyone's obese. And if you look at this diagram, this shows every single state and the increase in percentage of obese people over the period 1990 to 2018. In a 30-year period, the percentage of people who've become obese in that state, or in all those states, has skyrocketed. So you can see here 30 years ago, most people in every state, the highest was 15% prevalence of obesity. This is actually in Mississippi, this top grey line here, which is a poor and fairly black part of the United States in the South. This is it here. You can see Mississippi beside Louisiana and Alabama. You can see here that 15% of people were obese in 1990, and now nearly 40% are obese. And that degree of change has happened in all these states. Again, Colorado, which is the bottom grey line, only 23% or so people are obese now, but it was like 7 or 8% 30 years ago. So something very dramatic is happening. Everybody in the world is putting on weight, particularly in countries with easy access to food, like the United States. What about in Australia? Well, as I said, I'm a 57-year-old man. I turned 57 last month. And if you look at this graph, then I'm in the 80% of people, 80% of people of my peers who are male, more than 80% are either obese or overweight. And the obese proportion is about half of them, slightly less than half of them. Otherwise, you're overweight. So I'm not, even though I consider myself very overweight, I'm not actually particularly unusual when I walk around in the streets in Australia. There are many people that look like me, and the same with women to a lesser extent. It's also important to remember that there's a socioeconomic gradient. So in Australia, we have a lot of people that are more overweight if they happen to have more social disadvantage and have greater social risks, and that particularly includes our Aboriginal population, who are quite overweight in general. They're about 3% of the entire population. And also other people with social disadvantage tend to be bigger. All right, let's get on to the topic at hand, just keeping those principles in mind and those observations in mind. Let's look at some of the randomised control data around weight gain and metabolic changes that's appeared over the last couple of years. The first study I want to look at is, I think, the best and the most revealing, and I highly recommend anyone who's confused about this topic to read this, because I think really pretty much all the truth and all the important observations are contained in this one single study, which is, the lead author is Paul Sachs, who will be familiar to many of you, who's at Brigham and Women's Hospital in Massachusetts and part of the Harvard Medical School. And this is a selection of 9 phase 3 double-blind randomised controlled trials, all of which were run by Gilead Sciences. They did a pooled analysis of these 8 selected RCTs to try and get a better handle with bigger numbers on what's going on with weight in these very controlled studies. You can see these are absolutely gold standard studies in terms of making observations that are fairly likely to be true rather than false, bearing in mind that most things published in medical journals, most of the results are false. The analysis includes over 5,500 people who were infected with HIV, and they were commencing their first therapeutic antiretroviral regimen in a trial. And you can see, sorry, just to go back, most of them were followed for 3 years, some of them were followed for 2 years. Okay, now here's the money slide for that. There's a lot of data. I highly recommend you go to this article, which really has a lot of really useful information and robust analyses. Very well thought, very, very good article, high quality, one of the best, I think, of last year. It's in Clinical Infectious Diseases. It was published, I think, in the paper version about September or October of last year, so 2 or 3 months ago. And what this shows you is the pooled analysis of all those randomised controlled trials between 2003 to 2013. And in the first panel here, you can see the mean weight gain over 96 weeks in all studies pooled. And in this first panel, it's divided between, it's stratified between people who had an integrase containing regimen. In the blue, a PI, protease inhibitor containing regimen, and in the yellow, a non-nucleoside reverse transcriptase regimen, which in those days would have been either nevirapine or efavirenz. And what you can see is that if you look over those 96 weeks, you get quite an acute rise over the first 36 weeks. And that basically accounts for probably the point at which viremia is being suppressed. Nearly everybody will be suppressed by 24, if not 36 weeks. Of course, it's much faster with integrated regimens, but nevertheless with PIs and NNRTIs, we could generally expect everyone to be fully suppressed by week 36, regardless of baseline HIV RNA level. And after that, you see perhaps an inflection. This is return to health. So this is as people get better. Of course, they put on weight because they become far less catabolic. They're not fighting an infection. And after that, there's a gradual weight rise over a period of time in the integrase regimens. And what you don't see, that's in contrast to the degree, there is still, after return to health, some degree of increase in weight, but it's not as profound, both in protease inhibitors and people taking non-nucleoside reverse transcriptase inhibitors. Okay, if we go to the second panel, we're looking at the weight, we're looking now within class. So we're looking at the difference between weight gain over 96 weeks between people with a bictegravir third agent, a dolutegravir third agent, or elvitegravir cobecistat. And once again, what you see is that there's the acute rise to week 36, return to health. And then once that's been established, you see an increasing gradual rise over a period of 96 weeks, which seems, at least in terms of bictegravir, to sort of be plateauing off at that stage. Maybe this is the point at which weight gain stops, or at least moves down to a lower gear, if you like, bearing in mind, and this is important, that after the age of 30, at least in Western populations and people generally continue to put on weight by year. So people will normally put on weight around 0.5 to maybe 1 kilo every year, even if they're regardless of their HIV status. That's across the population. So you need to keep that in mind when you interpret these weight gains, because part of it is just natural increase in weight as we get older. Okay, what's interesting about this, of course, is that the elvitegravir cobecistat arm doesn't gain the same sort of weight. And that's probably explicable on the basis that the cobecistat probably is the boosting agent, a bit like ritonavir. We generally think that's fairly poorly tolerated compared to non-boosted, and therefore people tend to put on less weight because of that adverse effect. Okay, finally, in the last panel, the weight gain across this 5,500 strong pooled population, depending on what was the most active non-3TC, non-XTC part of their backbone nuke combinations. And what you see is, again, a hierarchy. TAF has the most weight gain, followed by abacavir, followed by tenofovir, and then followed by zidovudine. And we all know zidovudine was poorly tolerated with a lot of gastrointestinal adverse events. And not only that, as a T analog, it's been associated with lipoatrophy. So these people were probably having poor intake, less appetite, and not only that, were losing peripheral fat because of the mitochondrial toxicity of zidovudine. They're three incredibly robust and very important, I think, observations that really cut to the chase of what's going on with weight gain. Okay, so just to follow up. So there were also some other observations done, and that pre-specified analyses looking at the differences between males and females, difference between black and non-black populations, and then an analysis looking at both those things expressed as either black female, black male, non-black female, non-black male. And what you can see is the same sort of increase, again, a slightly sharp increase over the first 36 weeks and then slight plateau off. Again, this is probably return to health. This has got nothing to do with the drugs. It's got to do with the person. And then black people tended to put on more weight than non-black people. And then please keep a notice on this chart, which shows that there's a hierarchy between black females, and this is not in Africa, this is mainly in the US, these studies were enrolled, then black males, then non-black males, and then non-black females. So seems to be something about race, and race I would put to you is not a scientific construct, it's a social construct. So it's probably nothing to do with your genes, but it's got something to do with being black has things around it like poor access to healthcare, discrimination, stigma, and being lower in the socioeconomic chain is probably what explains some of this, but I'll go into that in a bit more detail soon. All right, when in this pooled analysis, they modelled what the factors were that stayed in once you actually constructed a model, looking at the variables that you might expect to be associated with weight gain. What you see is that being immunodeficient, in other words, having a CD4 count of less than 200 at baseline, as opposed to being immunocompetent, and that's over 200, that made up, if you were immunocompetent, you were more likely to, if you were immunodeficient at less than 200, you put on average 3 kilos more than the people who had a baseline greater than 200. So that's a huge influence. And again, that's not surprising. I think that makes sense in that people who are immunodeficient have probably had the infection for longer. They've been sicker for longer. They may well have even had an opportunistic infection. And they're likely to be quite thin, as of course all of us who can remember treating people before the era of antiretrovirals can remember how thin and wasted our patients were. So it's a huge influence. IV drug use makes sense. You've got about a 1.4 kilo difference, and that makes sense because we know that people who use or have used IV drugs tend to have other problems that tend to interfere with their health, as well as drug use associated problems like viral hepatitis, etc. Being black meant that you were likely to put on a kilo more, and that makes sense. So if you think of those graphs the graph I showed you in the last slide, high viral load, again, it makes about a kilo difference compared to starting with a viral load less than 100,000 copies. If you're symptomatic with HIV, you're more likely to put on weight. Again, that's because if they're symptomatic, they've probably had the infection for longer and have been losing weight while they've been in that catabolic acute inflammatory stage. Females tended to put on a bit more than men. We saw that in the graphs. Age also, people who are less than 50 tended to put on more than 50. And there are some slight differences depending on what your baseline. So if you're obese at baseline versus normal, you are likely to actually put on just a slight bit more weight. Same with overweight and a very normal, as opposed to normal. Pretty minor changes compared to things like being immunodeficient, CD4 less than 200 at baseline. Let's look at one of the studies that probably really blew this whole subject apart and really made it a big deal. It was the ADVANCE study. This was a study performed in one site in Johannesburg, which is in South Africa. So bear in mind, this is a study done in a different continent, very different country compared to, say, the US or Australia or countries in Europe, where the pooled analyses were mainly done, with the SAC study I showed a few slides ago. These are very important observations to begin with, right? These were antiretroviral naive patients, 1,053, and they were randomised 1-to-1 for their first-line regimen to either be what we would call a tripler or tenofovir, FTC, efavirenz. The second arm was tenofovir, FTC, and dolutegravir, and the third arm was TAF, 3TC, and dolutegravir. The question being asked here was what was the best combination for patients in low and middle income countries to begin as first line. I won't show you this study is world famous now. It's been gone over many times. So I'm only going to concentrate on the weight. I'm not going to talk about the primary endpoints of viral suppression, etc. But what you can see is when you split for men in this panel and women in this panel, weight gain was fairly profound. Not so much in the men, 5 kilos over 96 weeks, with that, again, that sort of return to health over the first 36 weeks up to 48 and then a bit of a plateau after. Not particularly profound, but there was a difference in weight gain between people taking efavirenz, tenofovir, FTC in the green, versus dolutegravir with TDF, FTC in the blue, and then dolutegravir, TAF, FTC put on the most in the red. And the same was the case for women, but women put on a lot of weight. So over 96 weeks, there was something like a 10 kilo increase in weight, as opposed to 5 for people with dolutegravir and TDF and 3 for the efavirenz containing regimen. So same pattern, greater weight. And people really got worried about this. I've heard there were even people saying they probably should have stopped the study because this degree of weight gain was disturbing. I certainly wouldn't have thought that, but nevertheless, this really caused a stir and was probably the headline that came out of the meeting, headline news that came out of the meeting at Mexico City at IAS in 2019, about 18 months ago now. Right. Just out of interest, I just popped this one up from this graph up from the pooled analysis, because what you see there is a similar looking grade, right? We haven't got comparators for non-African people here, but for the Africans, what we saw was a pretty profound, in African people in Western countries mainly, in these Gilead studies, but nevertheless African by ethnic origin, if you like. Certainly black women put a lot of more weight on than did white women, and same, not so profound, but again, it was black men put on more weight than white men in those studies. And it sort of reflects, I think it's interesting to reflect the gradient here. There's something familiar there, I would suggest to you, that maybe is giving us some hint about what is underlying this phenomenon. All right, the other study that gives us some control, a comparison about what happens with African people is the NAMSAL study. This one was done in Cameroon, which is a francophone country and is part of the ANRS, French International Clinical Trials Network. Again, randomized open trial. And in this study, they compared as first-line therapy, so again, antiretroviral naive participants who were randomized to either get dolutegravir and TDF, so disoproxil fumarate version of tenofovir and 3TC, versus efavirenz given at the 400 milligram dose, which was proven to be as efficacious as 600 in the Kirby Institute-sponsored ENCORE study, and is now part of guidelines as a possible regimen. So they gave it against this was actually shown to be more tolerable in the randomized controlled trial of ENCORE. So they compared these two to see which might be the best regimen to give for people naive, to make a distinction between these two. Was there any benefit to dolutegravir, or was this efavirenz, was it good enough? Again, I'm not going to talk about the primary endpoints. I'm going to look at weight. Notice that the weight expressed here is slightly different to how it was expressed in advance. That's just one of the problems, I think, of different people to different things to select. But nevertheless, what you can see is if you look into people that had a greater than 10% change from their baseline weight in the study at week 48, not at week 96, week 48, you can see that the people receiving the dolutegravir, bearing in mind again that they were getting TDF and not TAF as part of their backbone, put on more weight than did people with efavirenz. Okay, and that was the same if you looked at the treatment emergent obesity. So those people that went from a BMI that was less than 30 to a BMI that was greater than or equal to 30, again, you're much more likely for that to happen to you if you're in the dolutegravir containing arm. All right, so that's the three. I think that's the juice of what I understand is going on in terms of randomized controlled data that holds up to sort of close analysis. But what about some other data and insights that might inform us around that? And the first thing to talk about, I think, is this business of where the TAF is the problem, or where the TDF was the problem in the past, and now we're using TAF. It's not called. It's stopping people from not putting on sufficient weight. And this is really something that still hangs around. It's about, is it TAF? Is it the integrases? What is it? And that's what I mean by this mess about, is there a simple explanation that might explain all this phenomenon, rather than hypothesizing that two agents in different classes, so for instance, dolutegravir or bictegravir and TAF are all putting on weight, which to me is jarring and seems highly unlikely because it's a messy explanation, just doesn't make sense. All right. So what's interesting, I think the most interesting observations is that with tenofovir disoproxil fumarate and with TAF, you can actually look at what it does to people who are not HIV infected, which again is a confounder because of the return to health phenomenon. People who are HIV, who are receiving tenofovir as either DF or TAF have been given the drug in large numbers as pre-exposure prophylaxis, of course. And what we saw in the first one, which is IPREX, it's a Bob Grant study that was, I don't know, must be 7 or 8 years old now, published in New England Journal of Medicine. What you saw in that is when people were randomized, and they were to placebo or TAF, so neither the doctor nor the subject knew what they were getting. People who got the placebo put on that sort of expected 1 kilo that I said that most people at least over the age of 30, put on per year. What was interesting is in the TDF group, they lost weight. So this suggests that TDF actually inhibits weight gain. In fact, it even makes people who are otherwise well, and these people were otherwise fairly well, they're fairly young, sexually active people, they lost weight. If you go to Discover, which was done more recently by, you'll see a similar thing. The people that were randomised, again, this was placebo-controlled, randomised to TDF, lost weight. Admittedly, in this example, only over 24 weeks. But they did lose it. They returned to baseline at about 12 months. But the people who were receiving TAF didn't. They put on quite a bit of weight. They put on slightly more than a kilo and a bit. Again, that's consistent more with no inhibition to weight gain rather than TAF making them terribly fat. This 1 kilo, same as with the placebo here, is about what one would expect in these people. Just looking at HPT and 077, which was, of course, the big news out of the last World AIDS Conference last year, which was virtual, of course, shows that the cabotegravir was again associated with a similar degree of weight that you would expect, weight gain you'd expect. And in fact, in this case, the placebo, which was in fact tenofovir FTC, it was Truvada, also, this is over 18 months, so a little longer, they gained about 1 kilo. And if you look at the tenofovir phenomenon here, you could sort of hypothesize that that's probably what you'd expect if you followed people up for longer than 48 weeks. As I say, this was stopped, but it was stopped after a median follow-up. A person you follow up about 1.5 years. So I think this is really interesting. Tenofovir is associated with weight loss in PrEP studies. The other thing is to look at switch, of course. You could say that switch studies would be the natural studies to do to look for weight gain, because again, you get rid of that phenomenon of return to health and the natural sort of increase of anything from maybe 3 to 5 kilos, depending on where you start and depending on your degree of immunodeficiency, if you're antiretroviral naive. What this shows, this is from Opera, and this was presented, I think, again, by Paddy Malan last year at the World AIDS Conference. What this showed, if you look overall, this is people switching from TDF, a TDF-containing regimen in this part of the panel. At this point, which is marked as 0.0, they switched to TAF. And what you can see, no matter what other drugs you were taking, after you switched to TAF, there was this increase in weight. And again, the question becomes, is that because TAF promotes weight, or is that because they've come off things like TDF and AZT and they've lost that inhibition of the old drug? If you split that out by class of anchor agent, you can see that the people taking integrases and non-nukes had a very similar kind of curve. They gain weight, say, for the first 12 months, and then it tends to plateau. People interested with a boosted protease inhibitor gained a little bit, but then by the end of 48 weeks, actually were sort of almost back to their baseline. All right. What about pharmacokinetics? Can that help us at all? Other disciplines that might shed some light on this confusion. This was an interesting study I thought presented again earlier, middle of last year, I should say. I'm recording this on the 6th, so Happy New Year to everyone. This was an interesting study, again, looking in advance. They took 171 of those, over 1,000 patients, and they were taking who were taking the efavirenz FTC TDF, so the sort of A-triple arm, the one that put on least weight, as you recall, in the green line. And they stratified the people and their weight gain according to whether they were extensive metabolized. In other words, they were more likely to have a lower level because they had an SMP, a SNP, single nucleotide polymorphism, to give it its full name, or a SNP that would extensively metabolize the drug, intermediates, and then people that were slow to metabolize. And the hypothesis is, and the phenomenon is, the more you metabolize the drug, the lower your level is likely to be, whereas the people who are slow tend to have higher levels. And we know with efavirenz, it's not 100%, but the people with the higher levels tend to have worse adverse experiences and tend to feel worse, particularly the neuropsych phenomena that we're all very familiar with efavirenz, although not so much in my part of the world because we really don't use it anymore. We haven't used it really since we've had integrases. So but it's certainly, none of us can forget the people who had very, very odd and quite disturbing sometimes neuropsychiatric adverse effects from efavirenz. And what you see here is that the people that were extensive metabolizers of efavirenz tended to have the sort of weight change that we saw with the dolutegravir FTC and TDF. They haven't looked at the TAF yet, but they haven't expressed TAF there. But what you can see is that the more likely you were to have a higher efavirenz level and therefore more adverse effects, the more likely you were to not put on weight. In other words, again, maybe the people with higher levels, the slow metabolisms, had more inhibition to putting on weight, i.e. not being nauseous, not having a good appetite, etc. Will probably be the main things. That's probably what we're seeing here in this analysis. What about weight gain after pregnancy? This is another thing I think that's very interesting. Again, it came out of last year's, actually this came out of CROI at the beginning of last year. And this was from the IMPACT study, which was a very good study, perhaps a little underreported. And it was a study looking at the use of either dolutegravir 3-TC-TAF versus other regimens, and in particular ATRIPLA, efavirenz, which is still standard of care, or tends to be. It's changing now, but was the standard of care for women who are pregnant. And what this shows is that, in fact, in terms of the recommended weight gain for women in the second and third trimesters of pregnancy, the dolutegravir FTC and TAF arm, which is in orange, got the closest to actually the recommended weight gain for those women. And it was less so with people taking the TDF with dolutegravir, and again, it was less so with the efavirenz with the TDF. So again, a suggestion there's a hierarchy here, there's something going on. But this didn't actually put on, the problem with this was they didn't put on a lot of weight. The problem is that they put on almost the weight that's recommended, suggesting again that actually this perhaps isn't a bad regimen at all. Perhaps this is a recommended regimen, at least in this population. What about weight and perceptions of weight? So one thing, I think I alluded to this at the beginning of the talk, is that weight is a socially determined, it's a cultural phenomenon. So in the West, we tend to, particularly with women, we tend to idealise women who are normal weight or perhaps even a little underweight, sadly. There's been a lot of criticism of that because of the pressure it puts on women to really try and attain and maintain unreasonable, even unhealthy degrees of weight. And it's always been my feeling that the explanation from Advance was that in Africa, that's different. In Africa, women who are overweight are actually, that's the cultural norm. People like that. Women like that. The men like that. That's not criticised and stigmatised. So I was very pleased to see this analysis that was presented only a few months ago at the Glasgow Drug Therapy Conference. And what this shows is here on the first four bars are the weights for baseline and for the three arms in men and in women. And what you see is they've compared it to the National Nutrition and Health prevalence data that South Africa have been doing for the last few years. And what you see is that while, let's go to women because that was the most important one. In women, even though the women after week 144, I should say, at that stage, I think the women had put on an extra 5 kilos. So the median was something like 13 kilos. I think when I showed you it was 10. It was like 13, 14 kilos. When you compare them to HIV uninfected women just selected in the community, it's actually very similar to what you'd expect. So the South African women, on average, for this particular age and around this age, is close to being obese. In other words, close to a BMI of 30. It was 29. It was slightly higher in the people receiving the dolutegravir F-TAF, but not greatly so. It was just one point different. So these were nearly obese. These were just obese. And again, when you look down, in fact, the women on the tenofovir dolutegravir and the women on the efavirenz tenofovir TDF were actually underweight compared to that. So this, I think, is very important to say that it's actually what they're returning to on those people in Advance wasn't becoming, grossly obese. It was actually returning to what other women looked like them in the community, which is what is expected. So this is a terrific, I think, incredibly important study that sort of blows away a lot of the notion that this is some sort of toxicity. This suggests that it's actually people now on a good regimen, which is well tolerated, returning to normal, returning to health and a normal weight according to the people around them. Okay, so let's go back to this advanced thing with advanced study with men and women according to weight. And I'm going to put you to an hypothesis drawn from those last slides, that one, people didn't put on weight in the efavirenz arm because it's the least tolerable regimen. Efavirenz is associated with adverse effects that probably inhibit weight gain, as is TDF. The TDF, dolutegravir arm, was the intermediate in terms of weight gain because they still had TDF, right? They didn't have efavirenz, they had dolutegravir, but they had TDF, and that's probably intermediate tolerable. And when you get to the one that had TAF, which is well tolerated and associated with weight gain, even in healthy volunteers, as we've seen on, not healthy volunteers, I'm sorry, people who are HIV negative about to go on PrEP. They had dolutegravir. That is a very tolerable regimen. We've actually got to the point now, I would argue, that we've got such good treatment that these people are now just as prone to getting fat like me and 80% of my peers at my age as people who are HIV negative. I think that's what's going on, and I think that's a simple Occam's razor type explanation which blows away, I think, a lot of the confused and confounded data. So I'm going to use a slide here that came from Andrew Hill, put up a couple of years ago when he talked about drivers of weight gain and loss. He said, and I showed you this, that low CD4 and high viral load, you tend to put on weight. If you're getting dolutegravir or bictegravir, you tend to put on weight. PI as well, I didn't show you that data, but we know that, although not to an extent that you get it with these drugs. Women and black people. And the things that push your weight down are poorly tolerated drugs with known adverse effects, including nausea, which are the drugs of tenofovir and efavirenz. But I think we need to add more to that. I would suggest that we also need to think about the obesogenic environment, the fact that, as I showed you in America, people have managed 40% more people are fatter and obese compared to they were 30 years ago. That's not your genes. That's something going on in our surroundings. And that the parts of that are, could be the theme of an entire conference. Improved ART tolerability. I'm arguing that the reason people put on weight with dolutegravir, FTC and TAF is because we've actually reached the point that we've created drugs that actually are really well tolerated, such to the extent there's no inhibition to them putting on weight and eating normally and normal gut function, etc. The other thing is social norms. So the reason that people in South Africa got so big, and particularly the women, is because their peers are big by our standards, and that's a good thing. They're big and they're healthy. There's all sorts of mythology probably around why they're about sexuality, about fertility. And also you must remember, in places where people have actually starved, putting on weight means you're healthy and you can afford to eat. And that's an important thing in countries like Africa. Also, I should say India, where you see some quite big women. The women who are really big are often well off, and it just shows that they are well off and can afford to eat well. What about metabolic changes? I actually am nearly out of time, and to be honest, I think this metabolic stuff is pretty boring. The first thing is that being obese has all sorts of implications, not just cardiovascular disease. So I think we need to think very carefully about that, including Alzheimer's. It's pretty clear now that the reason we've got so much Alzheimer's disease is because we're overweight. Being overweight does actually have some implications for your life expectancy, so it is important. But really, from the point of view of why people become dyslipidemic and develop metabolic syndrome, whatever you like, is that if you get bigger, that's what happens, and that's really the end of the story. So I think that being sort of obsessed with LDL cholesterol, etc., is really pretty dull. I won't go into I've left some data on the slides, and you can read it in this article about what happened in the pool analysis. You can also look at it online, even with the slideshow from Andrew Hill from Croy last year about what happened in advance. Basically, yes, if you get bigger, you're likely to have dyslipidemia, and some of you will develop insulin resistance, and some of you will even develop diabetes. But I think that's so obvious as to be really, it's the weight that's the issue, not the metabolics. That's secondary. So let me just draw some conclusions. I'm probably over time. I'm sorry about that. I hope you haven't all switched off or gone to sleep. So in summary, I think we should say that weight gain in people living with HIV is very controversial. We understand the early weight gain over the first year, let's say, is expected. But after that, there's confusion and concern about the degree of weight people are putting on. But my interpretation is the increased weight is nothing to do with toxicity. In fact, it's the absolute opposite. It's actually got to do with ART now being so tolerable, and for instance, dolutegravir or bictegravir with TAF and FTC, incredibly tolerable, really no adverse events to speak of, very few, which is a fantastic victory. We should see this as, unfortunately, we should see this as a victory. People are putting on weight because the treatment doesn't affect them anymore. And they're putting on weight like everybody else is putting on weight. That's my feeling. So, look, I mean, everyone puts further research is needed, but the point about the future research needed for this phenomenon is that we need research to tell us how to change that obesogenic environment for everyone, not just for people with HIV, for everyone, because all of us are at risk unless we're really very disciplined, which I'm sure, I know some of you are, many of you are. I'm not. And so in this sense, the research we require is not regarding how particularly to get people to maintain a healthy weight in HIV. It's the same as it is in the general population. All right, so thank you very much for your attention. I hope that at least give you something to think about. Perhaps I'm completely wrong. Very happy to discuss that over email. And I'll leave you this, this final cartoon about Occam's razor. And thank you very much for your attention.
Our last speaker in this session is Dr. Nagalinsawa Kumarsamy. Dr. Kumar is the Chief of Infectious Disease Medical Center at Voluntary Health Service Hospital in Chennai and Director and Site Leader for Chennai Antiviral Research and Treatment Clinical Research Site. He is a clinician and researcher in infectious disease with more than 25 years of experience. He has conducted several landmark antiretroviral clinical trials which have impact treatment guidelines and lead to upscale the antiretroviral program in developing countries. He also advisor an expert panel in WHO ARV Treatment Guideline Committee and clinical advisor to Clinton Health Access Initiative. His topic today is TLD transition into our region. Please welcome Dr. Kumar.
Hi everyone. Today I'm going to speak to you on TLD transition in our region. That is a combination of tenofovir, lamivudine, dolutegravir as an universal ERT regimen. At the outset, I'd like to thank the organizers of this Bangkok Symposium for inviting me to do this presentation. So we all know that these are the various antiretroviral drugs approved by US FDA for therapeutic use in managing people living with HIV. And also, most of these medications have been available in our region and we have been using in our clinical practice. These two landmark clinical trials called HPT and 052 and START really completely changed the treatment and prevention paradigm in HIV. So today, based on the outcome of these two studies, today everyone who has been HIV positive, irrespective of the CD4, be initiated on antiretroviral treatment. To do this, we need the best antiretroviral combination, which is convenient, less toxic, and safer to our people living with HIV. Also, the treatment guidelines went ahead in recommending two different ways of initiating treatment. One is rapid ART initiation, that is someone who is HIV positive, if they have any comorbidities, initiating ART within 7 days, and people who have been totally asymptomatic and prepared to initiate ART treatment, you can even initiate treatment on the same day. Again, to do this, you need the best drug, which is tolerable and convenient to our people living with HIV. So this is an actual history of HIV treatment guidelines developed by WHO and subsequently been adapted by various regional guidelines, where you can see this in the year 2016, a combination of tenofovir, lamivudine, and efavirenz was preferred, and the alternate being a combination with tenofovir, lamivudine, dolutegravir. Why in 2016 this alternate regimen was brought in, to cover up, efavirenz containing regimen is based on the retrospective review of these 4 different NIH-supported ACTG clinical trials. So what are those trials? You can see all those numbers: ACTG 5142, ACTG 5175, which was predominantly done in resource-limited settings. Here again, in our region, India and Thailand participated, and also a couple of other studies where the study participants used efavirenz and they were being compared with other non-efavirenz containing regimens. So in these particular retrospective review, what's been found in that is patients who have been enrolled in these clinical trials, they have 2.6-fold higher risk of attempted or completed suicide among those who are assigned to efavirenz. And again, today we are talking about starting treatment for everybody, irrespective of the CD4, who are totally asymptomatic. Even on the same day of HIV diagnosis, you need the best regimen, which has been tolerable and less toxic to people living with HIV. Again, this is the data from WHO following various surveillance among different countries where they have been initiating, treatment where they have used NNRT-containing therapy in the past. But if you see this graph, where you can see these, the baseline prevalence of NNRTI is being increasing to more than 10% in many of those countries in sub-Saharan Africa, and as well as it's been going up even in our region. And if you see this in our region, in India, it's anything from 5 to 10%, in Thailand around 8%, and in Indonesia 4%, and Philippines almost 9%. Again, in our region, the baseline NNRT resistance is catching up, is almost touching 10%, where again, a combination with tenofovir, lemivudine, efavirenz may not be applicable. Following these surveillance data, WHO developed a guidelines of using non-NNRT containing therapy, that is with the dolutegravir containing therapy, especially in regions where they have more than 10% baseline NNRT resistance, where most countries will belong to. And why these dolutegravir being used? Again, it's based on evidence from the different clinical trials, starting from SINGLE, FLAMINGO, SPRING, and SAILINGS. But again, if you see this one particular study of SINGLE, where they compared efavirenz containing therapy versus dolutegravir containing antiretroviral therapy with 2 NRTIs among patients who are initiating therapy, where it very clearly shows that a combination of 2 NRTIs with the dolutegravir is superior to efavirenz containing therapy. Also, all these different clinical trials have shown superior efficacy of dolutegravir with 2 NRTIs as compared to raltegravir or darunavir or any other 2 NRTIs containing therapy. Also, these studies have very clearly shown that a combination of 2 NRTIs and dolutegravir is having a high genetic barrier in terms of resistance. And also when they looked into the tolerability, particularly when they compared efavirenz versus dolutegravir, and participants who are on efavirenz containing therapy, they tend to discontinue regimen because of various CNS toxicities like dizziness, abnormal dreams, and insomnia, as compared to dolutegravir containing therapy. Again, a combination of 2 NRTIs and dolutegravir is being generally well tolerated as compared to other regimens, which have been used in these clinical trials. And again, when we talk about a combination antiretroviral drug in a resource-limited setting, this should fit into all population: adults, adolescents, children, pregnant women, as well as patients who have comorbidities. And again, tuberculosis is one of the most common opportunistic infections in resource-limited settings, again, particularly in our region. Again, the combination of TLD should also fit well with the anti-TB medications. Here again, this was well proved in a study called INSPIRING, where they have shown that doubling the dose of dolutegravir when they have been given along with the rifampicin-containing therapy will achieve this therapeutic level to suppress this virus. And following this, the recommendation came, when you have been initiating someone who having TB, when they have been initiating rifampicin-containing therapy, along with a combination of TLD, you also have to give another dose of dolutegravir 50 milligram, that is double the dose of dolutegravir to achieve this therapeutic level. And following this, the treatment guidelines started recommending a combination of tenofovir, lemivudine, and dolutegravir, that is TLD, as a preferred therapy. Only in certain population, and particularly in children, particularly in women of reproductive potential, where at that time it was preferred to use TLE 600, because the data from Botswana have shown neural tube defects, especially in women who have initiated on the first trimester pregnancy. So this same group subsequently have shown very recently that when they compared the data of women who are initiated dolutegravir containing therapy, and when it's been compared with the non-DTG containing therapy, where there is not much difference in terms of any other neural tube defects. And following this, now it has been safer dolutegravir-containing therapy even in pregnant women, and hence it become like a universal active regimen among adults, adolescents, and even in pregnant women. And why dolutegravir-containing 2-NRTI therapy has been preferred? That is because, as compared to other integrase inhibitors, as you see in this particular slide on the advantages and disadvantages, where again, dolutegravir is been much superior as compared to other integrase inhibitors because it has been once daily and it's got a high genetic barrier to resistance, fewer drug interactions. You can combine with rifampicin, but you have to double the dose of dolutegravir. And so also can be co-formulated with other 2-NRTIs and currently being available even as generics, both as a tenofovir lamivudine and dolutegravir, as well as a bacavir lamivudine and dolutegravir. Also, you can give among women of childbearing potential. Thereby, today, a combination of tenofovir lamivudine and dolutegravir is a universal ART regimen. Can we give this in same combination in second-line ART? Where again, patients who have been failing first-line NRTI-containing therapy in this particular study called Dawning study, they were randomized to 2 different groups. One group received 2 NRTIs and dolutegravir. Another group, which is a comparative group, they received the standard 2 NRTIs and a protease-containing therapy. Again, in this particular trial, it's very clearly shown that a combination of 2 NRTIs with dolutegravir is been superior as compared to 2 NRTIs and a protease inhibitor-containing therapy among patients who have been failing NRTI-containing therapy and subsequently been randomized to this particular regimen. Again, in this study, they optimize NRTIs. If they have used azacitidine first line, they used tenofovir, then they used azacitidine second line. So again, can we change from TLE, that is tenofovir lamivudine efavirenz, someone failing, to TLD? Today, the answer is, not been available. There are trials undergoing, but we can extrapolate based on this observational study called TNORS study, where it is a large observational study where patients who have been failing tenofovir-containing therapy, where their resistant testing was done and been documented in this TNORS database, where it's been found that in sub-Saharan Africa, almost 57% of the patients who are failing tenofovir-containing first-line therapy, they have K65 resistance mutation, which is a signature mutation for tenofovir. In our region of Asia, where it is around 39%. So that means someone who has been failing on tenofovir lamivudine and efavirenz, where you may have to optimize a second-line NRTIs to AZT-containing therapy, but you cannot change from TLE to TLD. That is because of these resistance following, tenofovir, which is already seen 57% in sub-Saharan Africa and 39% in our region of Asia. But on the other hand, someone who has already have a suppressed viral load on TLE, then you can substitute them to TLD so that they'll be on this universal ART regimen. If you don't have a viral load, can you change them to TLD? Right now, we do not have an answer. But there is a very nice randomized clinical trial which some of you have been involved called DEP study, where this particular trial is randomizing people who have been failing NRTI-containing therapy into 3 different regimens, and one of the regimen is TLD. Even if they're on TLE on first line, they'll be randomized to TLD, where this particular trial will answer whether you can do that type of switch. Also, there is another ACTG study called TLD-UPSO, which will also answer this critical question. So today, as part of the WHO guidelines, which has been adapted in most of our region, where we do have TLD as a first line, as a preferred choice, even on the part of the second line, TLD is being present. So that means TLD is a universal antiretroviral regimen in our region. And what about this prevention effect following initiation of dolutegravir-containing therapy? Again, I'm going back to the same study on single trial, which compared efavirenz versus dolutegravir. If you look into the viral load suppression, you can see very early viral load suppression before even 8 weeks among participants who have received dolutegravir-containing therapy, which is again the study on HPT and 052, where we have shown that someone who has got a undetectable viral load, the less chance of HIV transmission to the partners. Again, in our region, where introducing a combination of tenofovir, lamivudine, dolutegravir, and then we are achieving viral load suppression much earlier, will also have enormous prevention effect. So our group, in collaboration with the Harvard CPEC group, also did a cost-effective analysis on this combination of TLD, that is a combination of generic tenofovir, lamivudine, dolutegravir, whether it will increase survival and decrease proportion of patients switching to more costly second-line ART, and whether it will be cost-effective. And when we did this analysis almost like 3 years back and shown that in GIAS, where we showed that at a cost of $102 per patient per year, a DTG containing regimen will be very cost-effective, and its implementation would be at no additional cost to the national programs in 5 years. And we did this modeling for India. But now again, the cost has been further come down to almost like $70 per year. So, and also we concluded in that particular study stating that once this regimen is available generically, this should become the standard of care. So now it's been available through generic market as a TLD fixed dose combination. You can see this. We have got 4 or 5 different manufacturers been developing this, and it's been started launching from the year of 2017. Our clinic in Chennai, Voluntary Health Services, has an opportunity to initiate this combination very early in 2017 when it was launched. This is one of our earlier study and got published from our Chennai cohort, where patients who have been initiating antiretroviral drugs, almost 137 who initiated on TLD combination. Also among patients of 145 individuals who are on stable efavirenz containing therapy were moved to TLD, and patients who failed TLE were moved to TLD on 40 individuals. And also patients who are on second-line therapy with protease inhibitors with tenofovir, lamivudine, boosted darolutamide, 100 patients been moved to TLD. And also patients who are on alternate second lines with dolutegravir and lopinavir, and also among third line with darunavir and DTG, with 64 patients who are also being studied. Also, there was a subgroup among patients who are initiating antiretroviral drug who have had tuberculosis, where we doubled the dose of dolutegravir along with TLD in 56 individuals. And in all these individuals at 6 months of follow-up, they all had suppressed viral load, and it was been well tolerable, no one discontinued treatment. And we showed this finding, and we provided support for a large-scale transition to dolutegravir containing therapy as first-line regimens for resource-limited settings. So following this, there are several scale-up programs happened, and WHO implemented their guidelines. So this is the data where you can see, this is a much earlier slide from 2017 to 2018, where you can see this progress in transition to dolutegravir as a preferred first-line therapy. Some of those African countries and as well as Latin American countries among LMIC have been moved. And in our region at that time, it was being discussed as part of the guidelines. And subsequently in 2018, it started getting implemented. And almost 50% of those countries in LMIC by the year 2018, they moved a switch to DTG containing regimen as a preferred. And now by the end of 2019, treat all is being implemented entirely in our region. And also in our region, all the countries have implemented, introduced TLD in the guidelines, but it to be implemented. There are a few countries, particularly in my country of India, where very recently TLD is being introduced through the national programs. So we have a way to go to implement these potent TLD as a preferred therapy, and also among people who are already on TLE, move them to TLD so that it will be an universal ART regimen, in our regions. So we do have a WHO treatment guidelines update, where again, the current one very clearly states that TLD is an universal ART regimen to initiate among adults, adolescents, and even among women who have potential to become pregnant, intended to become pregnant, where TLD is a preferred therapy, and also among people who have got tuberculosis. Also, It can also be used in second line based on the pattern of the first line treatment failure. But what we are seeing now of late is the new era of weight gain following integrase inhibitors. So ADVANCE is a study which was carried out in South Africa, where they randomized patients who are initiating treatment in 3 different groups. One group received a combination of tenofovir, FTC, and efavirenz. Another group, tenofovir, FTC, and dolutegravir. And another group, combination of TAF, emtricitabine, and dolutegravir. Almost equal numbers of 351 has been included in this group, and this study showed that it's almost comparable efficacy among different arms. But when they did a sub-analysis, particularly about the weight gain and different groups, and it has been found in that, and you can see these on the left panel of the slide is among men, where again you can see these 3 different line graphs, where the green one is among participants who received efavirenz containing therapy along with tenofovir FTC, and the red one is on tenofovir FTC and dolutegravir, and the blue curve is among participants who received a combination of TAF, emtricitabine, and dolutegravir. If you see this, a combination of with the dolutegravir, with the tenofovir FTC or TAF FTC had a higher weight gain as compared to efavirenz. Again, if you see on the right side panel, among women, again, you'll continue to see this, and particularly with the regimen of TAF FTC and dolutegravir. So we looked into this in our cohort here in Chennai among patients who have been initiating treatment, where you can see this TLD on 348 patients, and also among we compared this among patients, this weight gain who were on TLE containing therapy, where we found that weight gain in both arms been seen, both among patients who are initiating TLD as well as patients who are among TLE. And when we looked into the BMI, where again BMI gain was been statistically significant among patients who received TLD as compared to TLE among the first 6 months, and subsequently it was not statistically significant. Again, a very nice review has been published by Paul Sachs in Clinical Infectious Disease, where he have very clearly have shown this particular weight gain among ART, it can be race and sex specific. Hence, we need to do specific studies in the context of TLD in our Asia Pacific region among patients who are initiating therapy or switching to this combination, particularly in the context of weight gain, how it leads to any other comorbidities. And now we are in this pandemic of COVID. I'm sure you all been managing patients who are living with HIV even with COVID. And our group, published this a review on the impact of COVID-19 among people living with HIV. And also, we also been involved in a study in Chennai among our people living with HIV and who had been diagnosed with COVID, whether any particular antiretroviral drugs, and particularly a combination of tenofovir, lemivir, and dolutegravir has got any protective effect against COVID. So we studied 80 persons who had COVID among 4,300 patients who came to our clinic or been called over the phone between March 2020 at the start of pandemic till November 30th, 2020. So among them, the 80 persons who have been diagnosed with COVID and HIV, 74 persons were receiving antiretroviral therapy, and among them, 81% were on the combination of tenofovir, lemivir, and dolutegravir, that is TLD. And so it very clearly shows that a combination of TLD has got no protective effect against COVID. 4 persons died of COVID in our cohort, and also we observed there is no difference in terms of disease progression as compared to non-HIV infected persons in our hospital. And this has also been well supported by other evidence from North America as well as from Europe. In summary, today TLD may achieve a goal of pill burden, high barrier to resistance, and activity against prior NNRT resistance to HIV. So thereby, TLD is an universal ERT regimen. It's time to transit in our region to this more potent, better tolerable regimen. Also, people who are doing well with other therapies, particularly with the TLD in our region, should move forward to TLD because they have been less toxic, more convenient, and offer greater flexibility and result in less stigma, which is being caused by efavirenz-containing therapy. Also in our region, we need implementation studies. Particularly, we need to document the safety during pregnancy. Most of this data come from sub-Saharan Africa. We also need to study about this weight gain among these TLD in our region in Asia and Asia Pacific, and also about this long-term safety of TLD, particularly in the context of other comorbidities, and as well as whether this leads to any other comorbidities like diabetes and hypertension, or worsening of any other comorbidities. With this, I'll stop my presentation. Thank you again for this opportunity. Thank you very much.
HIV-NAT stands for the HIV Netherlands Australia Thailand Research Corporation. It is Asia's first HIV clinical trial center established in Bangkok in 1996. It started from the burning need of having life-saving medications for thousands of infected Thai patients at that time. AIDS came to Thailand in mid-1980. By mid-1990, several thousands of Thais have been infected. Most of them were untreated, mainly because of the high cost of medications. In early 1990, I had the chance to meet Professor David Cooper from Sydney and Professor Jup Lange from Amsterdam. Both of them were famous HIV/AIDS clinicians. They also had their own HIV clinical trials unit in their own countries. So I asked both professors to help me setting up a similar trials unit in Bangkok so that Thai patients can benefit from the free AIDS drugs by clinical trial settings. Fortunately, both Professor Cooper and Professor Lange were able to convince the drug companies at that time to invest setting up a similar trials unit in Bangkok. HIV-NAT opened its door in July 1996 at the King Chulalongkorn Hospital of Thai Red Cross Society. At that time, there were only 3 staff, including one doctor, Dr. Eugene Kroon from Amsterdam. Right now, HIV-NAT is an organization with 120 personnel with 5 doctors. At the beginning, HIV-NAT performed a post-marketing drug trials by comparing the safety and tolerability and efficacy of various combinations of antiretrovirals. Later on, it gradually gained recognition to the point that HIV-NAT can join international new drug studies, including the strategic trials like a when to start trial. HIV-NAT started by doing post-marketing drug trials by comparing various combinations and various dosing regimens of many antiretroviral drugs. It gradually gained recognition to the point that HIV-NAT can be involved in new drug trials, as well as some new strategic clinical trials like when to start trial. For the last 7 years, HIV-NAT has been a part of the NIH-sponsored Clinical Trial Unit or CTU, together with University of Chiang Mai. During the last quarter of century, HIV-NAT with the HIV clinical trials, tuberculosis trials, hepatitis B, comorbidity trials, more than 200 studies involving more than 4,000 patients have been involved. With all of this, the following achievements have been done. First of all, lives of several thousands of Thai infected people have been saved. From 1996 to 2006, when antiretroviral drugs were included in the Thai Universal Health Coverage Program. In fact, the Universal Health Coverage Program in Thailand was fueled by or influenced by the Thai network of people living with HIV, as well as by the clinical benefit of patients from HIV-NAT studies. Secondly, HIV-NAT has helped in building up the competency and infrastructure of HIV clinical trials in several hospitals, including several medical schools in Thailand, as well as 2 units in Phnom Penh, Cambodia. The results of several HIV-NAT studies have been used as a guidelines in Thailand as well as international guidelines. But most importantly, HIV-NAT has established the Bangkok International Symposium of HIV Medicines for the last 23 years, including the one this year, which is the first time in a virtual conference. One and a half years after the establishment of HIV-NAT, the first Bangkok International Symposium of HIV Medicine was held in January 1998. The rationale of holding such conference because the 3 co-directors were scheduled to meet annually for the HIV-NAT retreat. It would not be difficult for Professor Jup Lange and Professor David Cooper to invite a few more of their friends to join them in Bangkok, and also to hold lectures for Thai healthcare professionals when they were here. This is why the first Bangkok Symposium was started and has been continuing on for the last 23 years, including this one, which is the first virtual conference. Starting from local audience, it gradually gained the recognition from clinicians from the region as well as from the world. In fact, out of these 500, 600 participants every year, half of them are non-Thais. The unique feature of the Bangkok Symposium was the educational nature. Speakers, both from Thailand, the regions, as well as from Australia, Netherlands, and USA, were asked to review the recent development for the last 1 or 2 years, so that audience don't have to go to all over the world for the meetings. I hope you enjoy this year's conference. HIV-NAT stands for the HIV Netherlands Australia Thailand Research Corporation. It is Asia's first HIV clinical trial center established in Bangkok in 1996. It started from the burning need of having life-saving medications for thousands of infected Thai patients at that time. AIDS came to Thailand in mid-1980. By mid-1990, several thousands of Thais have been infected. Most of them were untreated, mainly because of the high cost of medications. In early 1990, I had the chance to meet Professor David Cooper from Sydney and Professor Jup Lange from Amsterdam. Both of them were famous HIV/AIDS clinicians. They also had their own HIV clinical trials unit in their own countries. So I asked both professors to help me setting up a similar trials unit in Bangkok so that Thai patients can benefit from the free AIDS drugs by clinical trial settings. Fortunately, both Professor Cooper and Professor Lange were able to convince the drug companies at that time to invest setting up a similar trial unit in Bangkok. HIV-NAT opened its door in July 1996 at the King Chulalongkorn Hospital of the Thai Red Cross Society. At that time, there were only 3 staff, including one doctor, Dr. Eugene Kroon from Amsterdam. Right now, HIV-NAT is an organization with 120 personnel with 5 doctors. At the beginning, HIV-NAT performed post-marketing drug trials by comparing the safety and tolerability and efficacy of various combinations of antiretrovirals. Later on, it gradually gained recognition to the point that HIV-NAT can join international new drug studies, including the strategic trials like a when to start trial. HIV-NAT started by doing post-marketing drug trials by comparing various combinations and various dosing regimens of many antiretroviral drugs. It gradually gained recognition to the point that HIV-NAT can be involved in new drug trials, as well as some new strategic clinical trials like when to start trial. For the last 7 years, HIV-NAT has been a part of the NIH-sponsored Clinical Trial Unit or CTU, together with University of Chiang Mai. During the last quarter of century, HIV-NAT with the HIV clinical trials, tuberculosis trials, hepatitis B, comorbidity trials, more than 200 studies involving more than 4,000 patients have been involved. With all of this, the following achievements have been done. First of all, lives of several thousands of Thai infected people have been saved. From 1996 to 2006, when antiretroviral drugs were included in the Thai Universal Health Coverage Program. In fact, the Universal Health Coverage Program in Thailand was fueled by or influenced by the Thai network of people living with HIV, as well as by the clinical benefit of patients from HIV-NAT studies. Secondly, HIV-NAT has helped in building up the competency and infrastructure of HIV clinical trials in several hospitals, including several medical schools in Thailand, as well as 2 units in Phnom Penh, Cambodia. The results of several HIV-NAT studies have been used as a guidelines in Thailand as well as international guidelines. But most importantly, HIV-NAT has established the Bangkok International Symposium of HIV Medicines for the last 23 years, including the one this year, which is the first time in a virtual conference. One and a half years after the establishment of HIV-NAT, the first Bangkok International Symposium of HIV Medicine was held in January 1998. The rationale of holding such conference because the 3 co-directors were scheduled to meet annually for the HIV-NAT retreat. It would not be difficult for Professor Yup Lang and Professor David Cooper to invite a few more of their friends to join them in Bangkok, and also to hold lectures for Thai healthcare professionals when they were here. This is why the first Bangkok Symposium was started and has been continuing on for the last 23 years, including this one, which is the first virtual conference. Starting from local audience, it gradually gained the recognition from clinicians from the region as well as from the world. In fact, out of these 500, 600 participants every year, half of them are non-Thais. The unique feature of the Bangkok Symposium was the educational nature. Speakers, both from Thailand, the regions, as well as from Australia, Netherlands, and USA, were asked to review the recent development for the last 1 or 2 years, so that audience don't have to go to all over the world for the meetings. I hope you enjoy this year's conference. HIV-NAT stands for the HIV Netherlands Australia Thailand Research Corporation. It is Asia's first HIV clinical trial center established in Bangkok in 1996. It started from the burning need of having life-saving medications for thousands of infected Thai patients at that time. AIDS came to Thailand in mid-1980. By mid-1990, several thousands of Thais have been infected. Most of them were untreated, mainly because of the high cost of medications. In early 1990, I had the chance to meet Professor David Cooper from Sydney and Professor Jup Lange from Amsterdam. Both of them were famous HIV/AIDS clinicians. They also had their own HIV clinical trials unit in their own countries. So I asked both professors to help me setting up a similar trials unit in Bangkok so that Thai patients can benefit from the free AIDS drugs by clinical trial settings. Fortunately, both Professor Cooper and Professor Lange were able to convince the drug companies at that time to invest setting up a similar trials unit in Bangkok. HIV-NAT opened its door in July 1996 at the King Chulalongkorn Hospital of Thai Red Cross Society. At that time, there were only 3 staff, including one doctor, Dr. Eugene Kroon from Amsterdam. Right now, HIV-NAT is an organization with 120 personnel with 5 doctors. At the beginning, HIV-NAT performed a post-marketing drug trials by comparing the safety and tolerability and efficacy of various combinations of antiretrovirals. Later on, it gradually gained recognition to the point that HIV-NAT can join international new drug studies, including the strategic trials like a when to start trial. HIV-NAT started by doing post-marketing drug trials by comparing various combinations and various dosing regimens of many antiretroviral drugs. It gradually gained recognition to the point that HIV-NAT can be involved in new drug trials, as well as some new strategic clinical trials like when to start trial. For the last 7 years, HIV-NAT has been a part of the NIH-sponsored Clinical Trial Unit or CTU, together with University of Chiang Mai. During the last quarter of century, HIV-NAT with the HIV clinical trials, tuberculosis trials, hepatitis B, comorbidity trials, more than 200 studies involving more than 4,000 patients have been involved. With all of this, the following achievements have been done. First of all, lives of several thousands of Thai infected people have been saved. From 1996 to 2006, when antiretroviral drugs were included in the Thai Universal Health Coverage Program. In fact, the Universal Health Coverage Program in Thailand was fueled by or influenced by the Thai network of people living with HIV, as well as by the clinical benefit of patients from HIV-NAT studies. Secondly, HIV-NAT has helped in building up the competency and infrastructure of HIV clinical trials in several hospitals, including several medical schools in Thailand, as well as 2 units in Phnom Penh, Cambodia. The results of several HIV-NAT studies have been used as a guidelines in Thailand as well as international guidelines. But most importantly, HIV-NAT has established the Bangkok International Symposium of HIV Medicines for the last 23 years, including the one this year, which is the first time in a virtual conference. One and a half years after the establishment of HIV-NAT, the first Bangkok International Symposium on HIV Medicine was held in January 1998. The rationale of holding such conference because the 3 co-directors were scheduled to meet annually for the HIV-NAT retreat. It would not be difficult for Professor Jup Lange and Professor David Cooper to invite a few more of their friends to join them in Bangkok and also to hold lectures for Thai healthcare professionals when they were here. This is why the first Bangkok Symposium was started and has been continuing on for the last 23 years, including this one, which is the first virtual conference, starting from local audience. It gradually gained the recognition from clinicians from the region as well as from the world. In fact, out of these 500, 600 participants every year, half of them are non-Thais. The unique feature of the Bangkok Symposium was the educational nature. Speakers, both from Thailand, the regions, as well as from Australia, Netherlands, and USA, were asked to review the recent development for the last 1 or 2 years, so that audience don't have to go to all over the world for the meetings. I hope you enjoy this year's conference. HIV-NAT stands for the HIV Netherlands Australia Thailand Research Corporation. It is Asia's first HIV clinical trial center established in Bangkok in 1996. It started from the burning need of having life-saving medications for thousands of infected Thai patients at that time. AIDS came to Thailand in mid-1980. By mid-1990, several thousands of Thais have been infected. Most of them were untreated, mainly because of the high cost of medications. In early 1990, I had the chance to meet Professor David Cooper from Sydney and Professor Jup Lange from Amsterdam. Both of them were famous HIV/AIDS clinicians. They also had their own HIV clinical trials unit in their own countries. So I asked both professors to help me setting up a similar trials unit in Bangkok so that Thai patients can benefit from the free AIDS drugs by clinical trial settings. Fortunately, both Professor Cooper and Professor Lange were able to convince the drug companies at that time to invest setting up a similar trial unit in Bangkok. HIV-NAT opened its door in July 1996 at the King Chulalongkorn Hospital of the Thai Red Cross Society. At that time, there were only 3 staff, including one doctor, Dr. Eugene Kroon from Amsterdam. Right now, HIV-NAT is an organization with 120 personnel with 5 doctors. At the beginning, HIV-NAT performed a post-marketing drug trials by comparing the safety and tolerability and efficacy of various combinations of antiretrovirals. Later on, it gradually gained recognition to the point that HIV-NAT can join international new drug studies, including the strategic trials like a when to start trial. HIV-NAT started by doing post-marketing drug trials by comparing various combinations and various dosing regimens of many antiretroviral drugs. It gradually gained recognition to the point that HIV-NAT can be involved in new drug trials, as well as some new strategic clinical trials like when to start trial. For the last 7 years, HIV-NAT has been a part of the NIH-sponsored Clinical Trial Unit or CTU, together with University of Chiang Mai. During the last quarter of century, HIV-NAT with the HIV clinical trials, tuberculosis trials, hepatitis B, comorbidity trials, more than 200 studies involving more than 4,000 patients have been involved. With all of this, the following achievements have been done. First of all, lives of several thousands of Thai infected people have been saved. From 1996 to 2006, when antiretroviral drugs were included in the Thai Universal Health Coverage Program. In fact, the Universal Health Coverage Program in Thailand was fueled by or influenced by the Thai network of people living with HIV, as well as by the clinical benefit of patients from HIV-NAT studies. Secondly, HIV-NAT has helped in building up the competency and infrastructure of HIV clinical trials in several hospitals, including several medical schools in Thailand, as well as 2 units in Phnom Penh, Cambodia. The results of several HIV-NAT studies have been used as a guidelines in Thailand as well as international guidelines. But most importantly, HIV-NAT has established the Bangkok International Symposium of HIV Medicines for the last 23 years, including the one this year, which is the first time in a virtual conference. One and a half years after the establishment of HIV-NAT, the first Bangkok International Symposium of HIV Medicine was held in January 1998. The rationale of holding such conference because the 3 co-directors were scheduled to meet annually for the HIV-NAT retreat. It would not be difficult for Professor Yup Lang and Professor David Cooper to invite a few more of their friends to join them in Bangkok, and also to hold lectures for Thai healthcare professionals when they were here. This is why the first Bangkok Symposium was started and has been continuing on for the last 23 years, including this one, which is the first virtual conference. Starting from local audience, it gradually gained the recognition from clinicians from the region as well as from the world. In fact, out of these 500, 600 participants every year, half of them are non-Thais. The unique feature of the Bangkok Symposium was the educational nature. Speakers, both from Thailand, the regions, as well as from Australia, Netherlands, and USA, were asked to review the recent development for the last 1 or 2 years, so that audience don't have to go to all over the world for the meetings. I hope you enjoy this year's conference. HIV-NAT stands for the HIV Netherlands Australia Thailand Research Corporation. It is Asia's first HIV clinical trial center established in Bangkok in 1996. It started from the burning need of having life-saving medications for thousands of infected Thai patients at that time. AIDS came to Thailand in mid-1980. By mid-1990, several thousands of Thais have been infected. Most of them were untreated, mainly because of the high cost of medications. In early 1990, I had the chance to meet Professor David Cooper from Sydney and Professor Jup Lange from Amsterdam. Both of them were famous HIV/AIDS clinicians. They also had their own HIV clinical trials unit in their own countries. So I asked both professors to help me setting up a similar trials unit in Bangkok so that Thai patients can benefit from the free AIDS drugs by clinical trial settings. Fortunately, both Professor Cooper and Professor Lange were able to convince the drug companies at that time to invest setting up a similar trials unit in Bangkok. HIV-NAT opened its door in July 1996 at the King Chulalongkorn Hospital of the Thai Red Cross Society. At that time, there were only 3 staff, including one doctor, Dr. Eugene Kroon from Amsterdam. Right now, HIV-NAT is an organization with 120 personnel with 5 doctors. At the beginning, HIV-NAT performed a post-marketing drug trials by comparing the safety and tolerability and efficacy of various combinations of antiretrovirals. Later on, it gradually gained recognition to the point that HIV-NAT can join international new drug studies, including the strategic trials like a when to start trial. HIV-NAT started by doing post-marketing drug trials by comparing various combinations and various dosing regimens of many antiretroviral drugs. It gradually gained recognition to the point that HIV-NAT can be involved in new drug trials, as well as some new strategic clinical trials like when to start trial. For the last 7 years, HIV-NAT has been a part of the NIH-sponsored Clinical Trial Unit or CTU, together with University of Chiang Mai. During the last quarter of century, HIV-NAT with the HIV clinical trials, tuberculosis trials, hepatitis B, comorbidity trials, more than 200 studies involving more than 4,000 patients have been involved. With all of this, the following achievements have been done. First of all, lives of several thousands of Thai infected people have been saved. From 1996 to 2006, when antiretroviral drugs were included in the Thai Universal Health Coverage Program. In fact, the Universal Health Coverage Program in Thailand was fueled by or influenced by the Thai network of people living with HIV, as well as by the clinical benefit of patients from HIV-NAT studies. Secondly, HIV-NAT has helped in building up the competency and infrastructure of HIV clinical trials in several hospitals, including several medical schools in Thailand, as well as 2 units in Phnom Penh, Cambodia. The results of several HIV-NAT studies have been used as a guidelines in Thailand as well as international guidelines. But most importantly, HIV-NAT has established the Bangkok International Symposium of HIV Medicines for the last 23 years, including the one this year, which is the first time in a virtual conference. One and a half years after the establishment of HIV-NAT, the first Bangkok International Symposium on HIV Medicine was held in January 1998. The rationale of holding such conference because the 3 co-directors were scheduled to meet annually for the HIV-NAT retreat. It would not be difficult for Professor Jup Lange and Professor David Cooper to invite a few more of their friends to join them in Bangkok and also to hold lectures for Thai healthcare professionals when they were here. This is why the first Bangkok Symposium was started and has been continuing on for the last 23 years, including this one, which is the first virtual conference, starting from local audience. It gradually gained the recognition from clinicians from the region as well as from the world. In fact, out of these 500, 600 participants every year, half of them are non-Thais. The unique feature of the Bangkok Symposium was the educational nature. Speakers, both from Thailand, the regions, as well as from Australia, Netherlands, and USA, were asked to review the recent development for the last 1 or 2 years, so that audience don't have to go to all over the world for the meetings. I hope you enjoy this year's conference. HIV-NAT stands for the HIV Netherlands Australia Thailand Research Corporation. It is Asia's first HIV clinical trial center established in Bangkok in 1996. It started from the burning need of having life-saving medications for thousands of infected Thai patients at that time. AIDS came to Thailand in mid-1980. By mid-1990, several thousands of Thais have been infected. Most of them were untreated, mainly because of the high cost of medications. In early 1990, I had the chance to meet Professor David Cooper from Sydney and Professor Joep Lange from Amsterdam. Both of them were famous HIV/AIDS clinicians. They also had their own HIV clinical trials unit in their own countries. So I asked both professors to help me setting up a similar trials unit in Bangkok so that Thai patients can benefit from the free AIDS drugs by clinical trial settings. Fortunately, both Professor Cooper and Professor Lange were able to convince the drug companies at that time to invest setting up a similar trial unit in Bangkok. HIV-NAT.
Good afternoon, all mentor speakers and participants. Welcome from session 3 for today. For this session, our speakers are talking about mental health psychosocial support. Our first speaker is Dr. Paul Tisakon. He is a psychiatrist from King Chulalongkorn Memorial Hospitals. He got his Master of Science on the Psychiatry in 2008 from the Chulalongkorn University and working as a consultant psychiatrist since 2008. He completed fellowship on the consultation liaison psychiatry psychosomatic medicine from Cleveland Clinic Foundation on 2015. He's been spending more than 10 years on psychiatric medicine, and today he is going to sharing his expertise on managing mental health condition in people living with HIV. So let's welcome Dr. Paul.
สวัสดีครับ Hello, my name is Paul Tisayakon. I'm the consultant psychiatrist at Chulalongkorn Hospital, Bangkok, Thailand. And today is my pleasure to be participated in the lecture about depression and HIV. So there are well studied and well documented evidence regarding the interaction between HIV and depression. And the literature conclude that there are the bidirectional relationship between HIV and depression. For example, the direct infection of HIV virus into the CNS, the disturbance of the inflammatory process, immunological impairment, the effect of some of the antiretroviral drugs can cause the depression. Moreover, the impact of the psycho and social process of HIV, such as stigma, can also be the contributory factors for developing the depression. On the contrary, the depression itself also has the impact on the HIV. Depression also carries the inflammatory process that worsen the both mood part of the brain and the part of the behavior and symptoms of HIV. Biopsychosocial part of depression, several factors worsening the cause, the outcome of the HIV. And further from the study, we also find that the relationship between HIV and depression eventually lead to the worsening poorer outcomes from both sides. For example, poorer control of the CD4, viral load, more morbidity, mortality of this population, worsening compliance, worsening social support, worsening quality of life. And here is the most recent meta-analysis that study about the global prevalence of depression in people living with HIV. The sample size is quite big, 50,000 people, and they found that the people who suffered from clinical depression was around 14,000 people, calculated into the prevalent rates of depression in people living with HIV is about 31%. Higher prevalence was noted in the people who live in the underdeveloped country or developed rather than the developed countries. And interestingly, the Southeast Asia, the region of the world where I'm living in right now, has the highest prevalent rates of depression in HIV at 40%. The data from last year, 2019, show that even though the prevalence of the HIV in Thailand is gradually slowing down, but the number of the HIV cases last year is still as high as 470,000 people. With the total population in Thailand, about like 66 million people, it is around like 0.71% of the people who has HIV living in Thailand. And if we use the lowest number, prevalence number of depression in HIV from the previous slide, we can roughly calculating that the Thai people who live with HIV who also suffer from depression is about like 130,000 people. I further calculate the data from Medical Council of Thailand show that last year there are around like 1,000 psychiatrists in the country. This means that if we think ratio between one psychiatrist and the HIV people who suffered from depression is about 1 to 115 patients. Not that bad, huh? But in reality, the ratio must be much, much higher because not all the psychiatrists can take care of this special population. And the psychiatrists also need to take care of like several type of patients like major psychiatric disorder or the patient who suffer from mental health from other medical areas. So there are the shortage of the psychiatrists. There are the big number of the people living with HIV who suffer from depression. And that comes to the talk that I will present today, 1, 2, 3 to 10 depression and HIV, that I try to think about what I have learned, what I have worked with the whole team to improve the steps of care in the people living with HIV who suffer with depression. The first step is to buy in the psychiatrist. And I literally said that you just need to buy in the psychiatrist, buy them the coffee, buy them the snacks, invite them to join the social activities, buy them the t-shirt, like the shirt that I wear today is also from the infectious disease team. Invite them to the academic activity like lectures, conference, interdepartment academic activities, and perhaps invite them to join the research that would make the participation, the relationship between both teams to be stronger and get the commitment from the psychiatrist. Once you have psychiatrists, it is worthwhile to find a case manager who is maybe the key of the whole team, not the psychiatrist, not the infectious doctor, but the case manager, which can be the registered nurse, social worker, medical assistant, volunteer, expert patient, can also take the role of the case manager. They work along the patient, they work along and get the supervision from the psychiatrist. Their role is to combine, to communicate between the whole sections of the system. Implementation, facilitation, coordination, assistance. The intervention they provide quite a lot, but it is like well studied and can be implemented not too difficult to our patients. Screening, diagnosis, monitoring, education, provide the counseling, provide the care, improve the adherence, and also the emergency management. Once you have psychiatrists, you get the case manager. Before you start to do something with this population, think about the emergency plan, because it must be like super confusing and difficult if you screen positive for the severe depressive patients with the active high suicidal risk and you have no plan in your hand. Think about the emergency plan ahead, safety in everything, plan, protocol, contact, assessment, intervention, or the plan to admit the patient into the psychiatric hospital. Then when we have the plan ahead in hand, we start to screen the patients. There are several screening tools that can screen for the depression and are well studied in the HIV population. We recommend the PHQ-9, which is like which was studied in several studies, several HIV populations, and it is the easy to use 3 to 5 minutes pen and paper screening tool, self-rate. It can use as the screening tool to diagnosis of the depression. It can use as the monitoring tool to see the improvement or worsening of the depressive symptoms. 2019, the European AIDS Clinical Society guideline recommend that we screen PHQ-2, the first 2 items of the PHQ-9, anhedonia, lack of interest, and the depressed mood in every HIV patients in every 1 or 2 years. If the patient screen PHQ-2 positive, they may further be screened by PHQ-9. And with After we calculate the sum of PHQ-9 scoring, we connect it with the step care. Step care determine the severity of the depression and connect it with the level of appropriate psychiatric care. For example, 0 to 9, no or mild depression. We just need to wait and see and repeat the PHQ-9 annually. Moderate depression, this is in the range of clinical depression, 10 to 14 score. We can provide the counseling and or pharmacotherapy. Moderately severe depression, 15 to 19, the whole team need to become more active in terms of providing the psychiatric medications or psychotherapy. The severe depression above 20 scoring, immediate attention need to be given. Talk about starting the antidepressant, talk about sending the patient to see the psychotherapist or even the urgent psychiatric visit. Referral. Screening tool is not enough. You just also need to diagnose the major depressive disorder with the clinical interview. It can be done by primary doctor, infectious doctor, nurse, social worker, case manager. You may not be familiar with talking about mood, talking about emotion, but you start with the routine physical care of the HIV patient. Then you ask about the common physical symptoms that can occur in both HIV and depression, such as weight loss, slowing down of the movement, or the sense of fatigue, lack of energy. Then you go to the middle part of the diagnostic criteria, that is in between the emotional part and the physical part. Ask about how they sleep, asks about the lack of concentration, the worsening of the brain capacity, memory, attention. Then you move into the more emotional part that you may not be familiar, but once you go step by step, it is easier and the patient would likely open to discuss about. Are you depressed over the past 2 weeks? Do you lose interest? Can you enjoy things around as usual? Do you feel worthless, helpless, hopeless, or guilt inside? Do you feel like some days in the past 2 weeks, you feel like life is not worth living? Do you have suicidal ideation? Do you have plan or intention to do it soon? So after you ask through this list of criteria, you are likely be able to diagnose the major depressive disorder. But yes, some of the HIV patients has the overlap symptoms of the depression. For example, weight loss or insomnia or fatigue. Sometimes we use the supplementative criteria, the substitutive criteria to give us a clue for depression diagnosis. Are the patient irritable, tearful in front of us, look depressed, withdraw from the society, just like have a lot of the negative thoughts, rumination inside all the time? This may give us a clue to be more confident with diagnosing the major depressive disorder. 6. Counseling and psychotherapy. Once we diagnose, the first step is not pharmacotherapy. The first step is to provide the communication, provide the interaction, counseling. It can be provided by you, the doctor, the social worker, the nurse, or the people who work in the HIV setting. Just use the basic counseling concepts, supportive psychotherapy. But if you have the team, like case manager, you may send them to learn more about the cognitive behavioral model, interpersonal model, or learn how to run the group therapy, because all of this model are well studied in the HIV population and prove that it improved the depressive symptoms. But if you have no time, just use the common basic counseling interaction skill that we all the medical personnel all have, like empathic listening, support and hope providing, education, motivation for the good physical activities, etc. Counseling in the moderately severe or severe depression, you may need to prescribe the antidepressant. Not only psychiatrists, but all physicians can prescribe the antidepressant. There are like 10 medications which are studied in the HIV population, but I just picked these 3 medications because it is widely used and easy to use in HIV people. First one is sertraline. 1 tablet 50 milligram. You start at 25, 1 week, go up to 50, continue at 50 for 6 to 8 weeks. If the symptoms persist or if the patient hasn't reached the remission, clear of symptoms yet, consider to go up 1 step to 100, 1 or 2 months to 150 or 200. No effect on antiretroviral drugs, but protease inhibitor may inhibit the metabolism of sertraline, therefore increase the level of sertraline. Nevirapine and efavirenz induce the metabolism of this medicine and lower the dose, the level of sertraline. Escitalopram is another safe medication that can be used in the people living with HIV. 1 tablet 10 milligrams, start at 5, 1 week, go up to 10, wait for 6 to 8 weeks, then you can go up to 15 and 20, no drug interaction at all. Fluoxetine, very first SSRI, serotonin reuptake inhibitor that we use for up to 30 years. 1 tablet 20 mg, start at 10, go up to 20 in a week. Then you may go to the step of 40 or 60, but need to check for the drug interaction because fluoxetine can increase the ritonavir level and protease inhibitor can greatly increase the fluoxetine level to the point that there are some case series of fluoxetine plus protease inhibitor causing the serotonin syndrome. Nevirapine, similar to sertraline, can reduce the dose level of the fluoxetine. The common side effects are annoying but not life-threatening. Sertraline, fluoxetine, 10 to 30% can develop GI symptoms like nausea, vomiting, diarrhea, abdominal discomfort, neuro side effects like dizziness, headache, anxiety, and insomnia. Escitalopram is a bit less, like 20% that develop these side effects. You just need to tell the patients that it causes about 20-30%. It occurs over the first week. Try to be with it, tolerate it, and then within the next few days, most of the side effects subsides. No serious side effects at all. The rule that we always tell other clinicians that is not the psychiatrist is to start low, go slow, but go. Titrate dose up every 6 to 8 weeks to reach the clinical response, which means no symptoms at all. Side effects, I talk about it. Nighttime dosing with the antiretroviral drugs may enhance the compliance because it's more convenient for some clients. The first 2 or 3 months, you may also prescribe the low dose of benzodiazepine like lorazepam 0.5 to 1 mg at nighttime to help sleep, anxiety, and cover some side effects of these medications. When we start, we monitor, we have the goal in our mind, we have the limit duration of prescribing. People hit the bottom and start the antidepressant. 2 or 3 months, we like to see the response, which is the 50% improvement of the symptoms from PHQ-9. In 3 or 4 months, we like to see the remission, which is the clear depressive symptoms of PHQ less than 5. Once we reach the great response or remission, we just need to continue the medicine at the same dose for 6 to 12 months to prevent the relapse. And once the patient maintains on antidepressant and hasn't had any depressive symptoms for 6 to 12 months, you may consider to decrease and stop the antidepressant. We don't like the patients to have the antidepressant on board forever. In some cases, with severe depressive symptoms, despite adequate treatments, time, dose, intervention, you may need to consider for psychiatric referral. Complex psychiatric diagnosis or comorbidities like HIV/AIDS plus depression plus psychosis or bipolar depression, PTSD, substance use, neurocognitive disorder, or organic psychiatric disorders. For example, you are thinking about some psychiatric presentations of the brain mass, cryptococcal meningitis, delirium, or efavirenz-induced psychiatric symptoms, you may need the psychiatric referral. Patient is in great acute danger to self or others. Psychiatrists may help you to work on with these more difficult patients. Once you walk through those 9 steps, your team, yourself will have more confidence, more experience to think about how we can improve the whole system to the next step. Starting from the different sector, different hospital, HIV, mental health sector, we try to integrate the whole care under the same roof, like one-stop clinic that has the infectious disease doctor sitting next to the mental health doctor, but it's time and resource consuming. We try to put everything in the same hospital and just consult to different departments, but it's still separated. So at one point, maybe the highest level of mental health care in the HIV setting that are evidence enough is the collaborative care model of caring the patient with HIV and depression. Again, the case manager is the key that facilitate and communicate with the whole team, but we implement and we monitor and we make it to be the systematic care model to improve the depression and HIV. You can read more about the collaborative care in several articles. And this is all I like to talk today. Depression is common, lead to the worsening outcome. And we try to implement the screening tool, monitoring tool, management plan to help our patients. And by working, learning together, slowly the whole team get more confidence, experience, ability to help with our patients more. Thank you.
I would like to introduce our next speaker is Dr. Brian Custer. He is the Director of Epidemiology and Policy Science, also a Vice President of Research and the Scientific Program by Vitalet Research Institute, and also the Professor of Department of Laboratory Medicine at University of South California. After he held his PhD on health outcome research from the Universities of Washington in 2003, he has worked in the transfusion medicine research as a part of his graduate study and continually thereafter. His research programs are addressing on epidemiology, health policy, and health economic of blood supply and transfusion medicine interventions. Completed projects are study of donors who are infected with HIV, hepatitis B, HTLV, Zika virus, West Nile virus, and dengue virus, and other bacterial contamination of blood components, and the resource transmission of these pathogens. He is also the lead investigator on several US, NIH, and the FDA-funded national and international research studies. He has been author and the co-author over 150 publications on blood safety and transfusion medicine research. His talk is about broadening the donor base, inclusion of LGBT population in blood donations. Professor Brian, could you start your talk, please?
Good afternoon. I'd like to thank the Congress organizers of HIV-NAT and you, the audience, for joining me to talk today about broadening the blood donor base, inclusion of LGBT populations in blood donations. My name is Brian Custer. I'm an epidemiologist. I work at Vitalet Research Institute in San Francisco, California, and hold a joint appointment in the Department of Laboratory Medicine at UCSF. I do want to cover my outline for the topics I'll be sharing with you today. I want to provide a conceptual framework. Many of you may not be familiar with blood donation or blood donation rules, so I want to give you at least a small background to cover that. That helps then define what I'll talk about specifically with respect to LGBT donors. I do want to discuss changing approaches to donor deferral, the use of shorter deferral periods, and current considerations and possible concerns. And finally, I will, toward the end of the talk, discuss new directions, actually, quite honestly, exciting new directions in how decisions are being made with respect to expanding the donor base to LGBT donors. So to begin with, I want to give a brief overview of what is called the Blood Donor History Questionnaire or interview. This is a series of questions about a donor's potential health exposures and behavioral history. These questions are asked to understand if there's a risk to the donor in donating and if there's a potential risk to recipients who might receive the donor's blood. Because there are specific risks to recipients associated with history of pregnancy, females are asked female-specific questions. Because there are specific risks to recipients associated with sexual histories, different questions are asked of males and females. These questions are primarily focused on whether you are a man who has sex with other men or a sex partner of a man who has sex with other men. But it's actually for these reasons that there are different questions that males and females are asked in most contexts related to blood donation. This creates complexity in expanding the donor base. I'm also going to give this through the background of the US FDA policy. It's obviously only one example, one country that has a series of policies, but that policy on particularly men who have sex with men has really changed quite dramatically over time. In 1983 through 1985, men who have sex with men or gay and bisexual men were asked not to donate blood along with other groups that were identified as higher risk for HIV infection at the time. Starting though in 1985, this changed to be a permanent deferral or indefinite deferral for any man who had sex with other men and reported that having occurred anytime after 1970. And so from that period of 1985 to January of 2015, any man who had sex with men was indefinitely deferred if they disclosed that at the time of donation. However, really, these policies have started to change. They've started to change globally. In the US, in the period from 2015 to April of 2020, there was a 1-year deferral since last MSM sex. More recently, as early as April of 2020 this year, that changed from a 3-month deferral since last sex with another man. All of these successively lower time periods for deferral are linked with our ability to detect and identify HIV infection in a donated unit of blood. This topic, while you might not be familiar with it, is actually not new. It goes all the way back to 1968, or over 50 years now, a steadily increasing body of published literature on this topic. And so again, this graphic is just intended to give you an overview that there has been research done going all the way back into the 60s, but as you would expect, not until really the formal identification of HIV in the early 80s, and then the period thereafter where we started to see progressive changes in policy, have the number of publications increased dramatically over time. So I do want to describe what may be evident to some of you, but is very important. Really, different sexual and gender identities lead to different rules for blood donors. For somebody who is a lesbian or a female who has sex with other females, generally the deferrals or the eligibility to donate is the same as it would be for heterosexual donors, unless the same sex behaviors are not accepted in the broader society. So of course it is context or country specific. For gay and bisexual men, the focus is on HIV risk, and generally it's a behavior-based deferral in most settings, meaning if people are highly sexually active, so have many sexual partners or have recent exposures, they may not be allowed to donate. For bisexual women, it's different. It really would do the same as it is for lesbians or heterosexual women, unless they happen to be a sexual partner of a man who has sex with men, in which case they would actually have MSM-style questions asked of them. And for transgender individuals, this is the most complex topic where really there's quite a bit of variability in rules. Really, we don't have a strong evidence base at this time. So for the rest of this talk, I'm really going to focus just on gay and bisexual men and also cover a little bit about the current status with trans persons and their eligibility to donate. Give a little more background, there really is no consensus on international policy at this time. There's factors that influence policy, and these are different in different contexts. So really, there may be 6 main things to be cognizant of. One is the epidemiology of HIV and what it is in the specific country or local setting. Clearly, if it's a primarily heterosexually spread epidemic, then there will be different rules than if it's a primarily homosexually spread or spread by men who have sex with men. So that epidemiology of HIV is very important. In addition to that are the actual blood donor screening methods that are available and in use in any given jurisdiction. Most developed countries screen both for nucleic acids, for direct detection of the virome of HIV, and also for antibodies, so antibody screening. So these dual strategies allow us to really be confident that we've identified HIV if it is present in a blood donation. Local regulatory requirements, so the policies such as the FDA makes drive what will be allowed or not. But in addition, there are political or government decree aspects to this. So policy can change if governments change or if legal rules change in a given context. Risk analysis and modeling to project what the risk might be under different policy scenarios has been used successfully to really understand how might policy impact risk. And then the history of response to threats to blood safety is a critical aspect of how a given jurisdiction may handle blood safety policy. This is because really the tragic history of transfusion-transmitted HIV and other infections, hepatitis C in particular, during the period of the 80s and the 90s. So broader contextual considerations are also important to keep in mind. There is a high level of controversy around what constitutes evidence or science-based policy in this domain, and it makes it very difficult for everybody to reach consensus understanding. The current testing approaches, however, really in developed countries do not justify an indefinite deferral for any LGBT donors. And the reason for this is very clear. The primary concern continues to be HIV infection and other known infections. If you were thinking about emerging infectious diseases as a primary reason to not change policy, that's really not justified by the patterns of emerging infectious diseases that we've seen over the last 20 years in terms of infections that are relevant to blood safety. Those infections have primarily been vector-borne infections, and so they really are not going to be human-to-human spread infections. It is true that analyses of changes in donor deferral periods for MSM show that gains to the quantity of blood in supply are marginal, meaning even if policies become very open and allow gay and bisexual men and trans donors to donate, this isn't going to lead to a huge increase in the number of donations coming into the supply because these members tend to be a relatively small proportion of any population. But there are some bigger consequences. It really is the issues and the implications related to how, as societies, we view equity that really do impact this and have a negative impact that's larger than you might expect, because if policies for blood donation are not considered equitable for everybody, then this may have a negative impact even on people who are otherwise eligible to donate. And so it has this overall impact of reducing the willingness of people to participate in donating blood. So the next couple of slides are just going to speak to what is the current status related to transgender or trans donors. This is a similar graph to the one I showed with respect to men who have sex with men, but you can see it doesn't start in 1968, it starts in actually 2014. So published studies thinking about and commenting on transgenders, population and blood donation is a new phenomenon, and very few studies have been published. So the data are limited, and there definitely is more variability in policies than for gay or bisexual male donors. What really is known is summarized very nicely in a recent publication from Canada. There are different approaches that can be used for selecting to determine if a donor is eligible if they're trans. One of them is a medical inquiry process, or basically individual risk assessment. So using a guided conversation with a medical professional to determine if a person has risks or not. Another approach would be the donor history questionnaire, but the donor history questionnaire is not well suited for trans donors, particularly, as I said, because you may want to ask questions that are applicable to both males and females, and that's a difficult thing in this context. So one approach might be to ask persons to complete both male and female questions on the donor history questionnaire. However, this approach has not been studied, so we don't really know if it's considered acceptable or not to trans donors. Another approach might be to ask questions on your sex assigned at birth and then gender-specific questions. This approach also might be viable, but again, it hasn't really been studied for its acceptability to trans donors. So where does this leave us? Really, the greatest impediment to facilitating blood donation in a way that is fair and safe for trans donors and recipients of blood is the lack of relevant and specific research. We need more studies on the epidemiologic study of sexual risk factors in trans persons, and we need to assess optimal approaches to donor screening questions specific to gender diversity. These studies are starting to be done at this time, but the data really have not yet impacted policy in a substantive way. So the rest of the talk is really going to focus on how the policy for men who have sex with men is changing in different contexts. And to do that, really, there are different ways of thinking about how you would defer or not an individual who might have a risk behavior related to being a sexually active men who have sex with men. You can have a time-based deferral. That might be an indefinite deferral, like I said earlier on. It could be a 5-year deferral, a 1-year deferral, or a 3 or 4 month deferral. Any specific amount of time it can be. So in this case, it could be if you reported that you had sex with another man at within that time period, whatever it is. And if you did, then you'd be given a deferral for up to that time period as a way of reducing the risk of HIV infection. Another approach for eligibility assessment would be to ask about specific activities. These are gender neutral policies and certainly preferred from a broader perspective. So regardless of whether somebody defines themselves as gay or bisexual, you might ask questions, or heterosexual, you might ask questions about sexual behaviors that are considered high risk, regardless of whether the partner is the same or opposite sex. And these could be in a specified time period preceding the donation, and then a deferral would be given. But it would be applied to everybody. So that's why it's called gender neutral policies. A similar approach is the individual risk assessment. Again, that structured dialogue with a medical professional. This is maybe the most equitable way of selecting donors, but it actually is quite complex and is not used in many settings because of how expensive it is and the time required to appropriately understand the individual risks that a person may have. And then another approach for eligibility is to have alternate policies. So these are unique policies that permit men who have sex with men or transgender donors to donate either a specific type of blood component, in this case plasma, or potentially platelets. And then those are actually treated in a manner that we're confident that there's a low risk of infection in those. And so this is one possible way of expanding the eligibility for LGBT donors. So I do want to give you a appreciation for how complex this topic is by briefly reviewing the variability in how policies are established, particularly for sex between men. In the countries listed here on the left, you can see that there's no specific risk that is defined unless it's a high risk. So this is countries that don't have a risk that has a time-based deferral for men who have sex with men. And instead it's based on if some type of risk is reported through that individual discussion that puts them at risk. So countries as variable as Argentina, Hungary, Spain, South Africa, and Brazil have some form of this. Now, how exactly it's implemented and how the rules are applied is going to be as variable as the countries themselves. By far, the most common approach is some form of these time-limited deferrals. And so, as you can see, currently in the UK, it's a 3-month deferral. In Canada, it's a 3-month deferral. In the USA, it's a 3-month deferral. In France, Denmark, and Netherlands, it's currently a 4-month deferral. Japan has a 6-month deferral since last sex. Australia has a 12-month deferral, although that is expected to change to 3 months very soon. And Germany currently has a 12-month deferral. So again, these are policies that are time limited in the 3 to 12 month range. But there's still other countries that maintain a permanent deferral or an indefinite deferral for men who have sex with men. That includes Austria, although that's under review at this time, and other countries such as Belgium, China, Croatia. So the rest of the talk is really going to talk about how the policy has changed and the kinds of data sources that have been used to implement policy change in different contexts. I'll begin with the United States, the country that I know the best. I'm a part of one of the investigators that participates in what's called the TIMS program, or the Transfusion Transmissible Infections Monitoring Program. In that program, we are collecting blood donor data from approximately 60% of the US blood supply. That's about $6 to $7 million, 6 to 7 million donations per year represented in the databases. We use that to actually track prevalence and incidence in donors. We also use this structure to do other studies, and I'm going to mention two of those. One is related to HIV testing and antiretroviral use in blood donors, and then also studies of PrEP testing or PrEP in blood donors. So when the policy changed from an indefinite deferral to a 12-month deferral for men who have sex with men, we needed some time to pass for us to then be able to assess, has the incidence of HIV in the blood supply, in the donors who are donating the blood supply, changed in any way since the implementation of that 12-month deferral. And so we recently reported results comparing that period from 2015 to 2016 of an indefinite deferral to the period from 2016 to 2018 where the 12-month deferral was in place in the United States. And what we saw when we look at either female and male donors or male donors alone as first-time donors, we saw no statistical evidence that there was an increase in incidence when the policy was reduced to the 12-month deferral. That actually translates into no evidence of an increase in the residual risk that HIV would be in the blood supply in the United States after the change to the 12-month deferral. So that's very reassuring. And I do have to say that all of the studies that have been reported for countries like Canada, for France, for the United Kingdom, when those policies have been reduced in terms of the deferral has been reduced in time, we have not seen an increase in incidence. So nothing that suggests that going from indefinite to 12 months to 3 months has so far shown an increase in risk of HIV to recipients of blood. But we have a changing scenario now, and that is related to the much wider spread use and availability of antiretroviral therapies, of course, to treat HIV, an incredible advancement in our ability to control the epidemic, and even more so, the availability of PrEP to prevent HIV acquisition altogether. These have potential implications for our ability to detect HIV in the blood supply, which is why we're concerned about them. So, pharmaceutical success in HIV control and prevention may not directly translate to blood safety. So there are a couple of commentaries that have been published thinking about this particular topic, but it can be summarized in this way. There is a potential conflicting message between undetectable equals untransmittable in public health or for sexual contact, where if somebody has an undetectable HIV infection, to the best of our understanding, it's untransmittable. That may not be the circumstance for blood components and blood units. And that's just simply because the amount of blood exposure, the amount of blood actually transfused intravenously is so much greater that even if a very small viral load is present, you still potentially could have a transfusion-transmitted HIV infection. So we're concerned, and we need to understand how much antiretroviral therapy use and also PrEP use may impact our ability to detect HIV infection in blood donors. So this is also linked to the testing that we do. As I said, typically most countries do nucleic acid testing for RNA and also antibody screening. And so these are data from South Africa and exhibiting what seemed to be a very disturbing or difficult to understand trend, which is elite controllers, so people who are antibody positive but RNA negative, seem to be increasing over time. But actually, ultimately, this was not the case. The explanation was that donors were coming in to donate, and they were taking antiretroviral therapy and donating blood. So this is a surprise and unexpected, because if you're HIV positive or if you're taking antiretroviral therapy, these are the kinds of questions that you're asked on the donor health history questionnaire. So this phenomenon is stating that there are clearly individuals donating who are not disclosing HIV infection or antiretroviral therapy. We asked a similar question in the US, would we see that same pattern? And the answer is we did see evidence that people who are HIV positive are coming in to donate, and they are on antiretroviral therapy at that time. So we did a much smaller study, but in that study of around 299 HIV positive donors, when tested for antiretroviral drugs using pretty sensitive, highly quantitative assays, 15% of those HIV positive donors had evidence of antiretroviral drugs in their system at the time of donation. Comparison group of HIV negative donors had no antiretrovirals in their system. We then specifically looked at first-time male donors who came in to donate but were infection negative. And it's, again, a relatively small study, only 1,500 individuals. But of those 1,500 individuals, 0.6%, or 9 individuals in total, had PrEP in their systems at the time that they were donating blood. That's actually a good thing. That means that there's low risk of HIV infection, but what we're worried about is a potential PrEP breakthrough infection in the donor population. So I'm going to touch on really, I think, the most interesting and dramatic country in the sense of making really major inroads into trying to increase the eligibility and the opportunity for donors to donate. So currently in the UK, there is a 3-month deferral. That 3-month deferral has been in place since 2017 in England, Scotland, and Wales, and since June of 2020 in Northern Ireland. That policy of the 3-month deferral since last sexual contact for men who have sex with men also applied to commercial sex workers and sex partners of groups known to have a high risk of having a sexually transmissible infection, so any kind of high-risk partner. And all of those individuals were treated the same way in that it was a 3-month deferral applied for any of those potential risk exposures. But there's still been a lot of pressure in the UK, as in other countries, to make further changes to try to move away from a time-based deferral. And indeed, the UK, if you're aware of recent news from just December of last year, just indicated a major shift. So that shift is based on, for the assessment of individualized risk, or FAIR. FAIR was a series of studies that I will describe in just a moment. But I think that the punchline, what's happened, is actually the most important thing. So I'll give you that summary first. So just about a month ago now, the National Health Service removes the 3-month barrier for men who have sex with men and others, and says that gay and bisexual men who have had the same sexual encounter for more than 3 months will be allowed to donate if there's no known exposure to a sexually transmitted infection and they are not using drugs to stop the spread of HIV, the virus that causes AIDS. These new rules are going to apply across England, Wales, Scotland, and Northern Ireland. So FAIR, for the assessment of individualized risk, is really based on a series of studies that started in February 2019, culminating in a final report issued in October of 2020, in which really studies of the epidemiology of infections in donors, studies of behavior, and studies of psychosocial impacts of different approaches to asking questions on the blood donor questionnaire were analyzed and assessed for a path forward to be able to implement those. Now, it does say, as you can see, in March of 2020, COVID-19 certainly shifted the timeline a little bit. And so FAIR, this policy change, has been adopted, but it won't really be implemented until sometime in 2021 now. It's based on a large body of work to try to understand, again, bloodborne infections, donor behaviors based on survey, and thinking about both through focus groups and test-retest studies, what questions might be appropriate to ask donors. So how will this actually work? It's planned to implement in mid-2021, as I indicated. Under the new changes, all donors who have ever had sex will soon be asked to also consider their recent sexual activities before giving blood, and this will be on the donor history questionnaire. The donor history questionnaire will be a cascading or hierarchical set of questions. So to really understand risk, they're going to ask increasingly detailed questions, and a combination of those are then going to be used to determine whether a man who has sex with men is eligible to donate or not. Deferrals will still be made for individuals if they report any of the following. Anyone who has had anal sex in the last 3 months with a new or multiple partners, regardless of whether they report condom use, will not be allowed to donate. They'll have the 3-month deferral. Anyone who has reported chemsex, so having sex under the influence of illicit drugs in the last 3 months, will also not be allowed to donate. If an individual has received recent treatment for gonorrhea, they will not be allowed to donate, or if they received treatment for syphilis, they also will maintain that they'll not be allowed to donate. Linked to the concern about PrEP, a 3-month deferral for anybody who is taking PrEP will remain in place, although they are currently reviewing their PrEP guidelines to try to understand if that could also be modified. And the screening of donors for syphilis, even though syphilis is not considered a transfusion transmissible infection of high concern because of the treatment procedures that we use, it still will be maintained as a useful safety measure to monitor donors for evidence of increased sexual risk behaviors. I'm going to shift just briefly to say, so that's the way that the UK approached making modifications and really expanding the donor base as much as possible with that structured approach. Different jurisdictions have different considerations. Here in Brazil, the Supreme Court made a decision. The court ruled that all blood collectors in the country must change the pre-donation interview, including not allowing blood centers to ask blood donors whether their sexual partners are the same or opposite sex, or inquiring about other aspects of the donor's sexual partners. So it's a very different process, but it ultimately leads to the same result, which is having to modify to create a much more inclusive approach for blood donation. So blood centers are still in the country of Brazil are still working through how to implement appropriate questions. Most will rely on the number of sexual partners as what they use to define the risks. Quarantine plasma for men who have sex with men has been a policy that's been in place since 2016 in the country of France. So this is actually a situation where all donors are treated exactly the same, whether they're heterosexual or homosexual. And it's based on the approaches that the overall system uses to have a quarantine system for plasma. This is where somebody donates a unit of plasma, and that plasma is held until that individual returns a few months later and either donates again or provides a sample for testing. That test sample is then tested, and if it tests negative for all of the infections, then that plasma that was previously collected can be released for transfusion. So they just allow men who have sex with men, if they've only had one sexual partner in the last 4 months, to participate in that same program in exactly the same way as applied to heterosexual donors in the country. The last topic I want to touch on is a new study being done in the US that is really intended to provide information that may be similar and lead to a similar outcome to the FAIR initiative in the UK. And that's the ADVANCE study, or Assessing Donor Variability and New Concepts in Eligibility. So this is a study that's being conducted to provide FDA with evidence to which to consider potential changes to MSM donor deferral policy while maintaining the safety of the blood supply. The objective is to conduct a pilot assessment of the discriminant function of revised donor history questions for predicting recent infection with HIV in men who have sex with men who wish to donate blood. So again, the study that we'll conduct will actually assess questions. If those questions are shown to differentiate different risk groups among the men who have sex with men population, those will then be potential candidates for inclusion on the donor history questionnaire in the United States. So I do want to summarize my presentation today. Thank you very much for your time. But I will say that blood donation policy for men who have sex with men is evolving rapidly in several countries. And I would say now also donor policies related to trans donors are also evolving rapidly in several countries. Ever shorter time-limited deferrals are increasingly being adopted. The UK continues to be the leader and has announced a breakthrough. This cascade of behavior-based questions in a non-gendered manner is the really important breakthrough in that inclusion of a broad group of donors in the donor base. Other countries have or are considering special programs to allow MSM to donate specific components. The local epidemiology and public health considerations are even more relevant now. You really have to understand the local epidemiology to be able to understand what kind of policy might be appropriate. But I do want to end with one note of caution. It really is the local studies have to be done. You cannot rely on data or information from another setting and apply that to your own setting. The work has to be done to understand the local epidemiology and what that might mean specifically for LGBT blood donors. I do just want to conclude by acknowledging all of the study participants and blood donors who have taken part in research to inform blood donation policy in different countries, all of the research and blood center operations staff who have conducted these studies, and then specifically name Mindy Goldman, Sheila O'Brien, Katie Davison, Pierre de Bergen, and also Tassila Solomon, who provided specific information from the countries that I presented information on today. I also would like to thank you again for listening. And if you're interested in speaking to me or following up with me, you can see my email address here at the bottom of the page. It is bcuster@vitalant.org. I'd be more than happy to talk to you about the issue of expanding the donor base to LGBT population. Thank you again.
Our last speaker for this session is Dr. Nidhya Panupa. She is the Executive Director of the Institute of HIV Research and Innovation, IHRN, Bangkok, Thailand. She started her career in the HIV-free in 2002 to lead a countrywide PMTCT operational study, which led Thai guidelines to allow the use of 3-drug antiretroviral regimen for the pregnant woman in 2010. Dr. Nidhya has deeply interested in the key population-led health services, KPLHS. This approach empowers two lead providers who are members of key population community to perform HIV STI testing and dispense PrEP and PrEP, and antiretroviral treatment and the STI treatment to their peers. She currently working toward the establishment of national accreditation and domestic financing system for key population-led providers to ensure these health services sustainability. Dr. Nidhya also oversees the key population-led Princess PrEP program, HPTN 083, and the HIV self-testing and PrEP project for the MSM and transgender women in Thailand. Dr. Nidhya has served as the Asia Pacific representative in the IES Governing Council since 2018. Let's welcome to Dr. Nidhya Panupa.
My name is Nithya Panupat, and I'm the Executive Director of the Institute of HIV Research and Innovation, or IHRI, based in Bangkok, Thailand. It is my great pleasure to talk to you all today about overcoming HIV stigma. In this talk, I'm going to introduce you briefly to the status-neutral approach to HIV, and then to discuss HIV-related stigma and how it could affect HIV testing, PrEP, ART services. And then I will propose some strategies to overcome HIV-related stigma, as well as providing some good practical examples. In order to end the HIV epidemic in the next 10 years, we need to shift the paradigm of HIV prevention and HIV treatment programs by using this status-neutral approach in which we actively engage anyone who come into HIV services through HIV testing, regardless of their HIV status, and then to try to support them in order to have them achieving the final common goal of having negligible risk of either transmitting HIV because of U equals U, or of acquiring HIV because of the use of PrEP and PrEP. But in order to do so, we need to seriously address stigma. Stigma is classically defined as a personal attribute or characteristic that is socially discrediting, that confers a negative judgment or value onto the individual. And the UNAIDS defined HIV stigma as a process of devaluation of people either living with or associated with HIV. And HIV stigma is commonly linked to socially unacceptable behaviors such as promiscuity or substance use. And it is also commonly linked to pre-existing and overlapping stigma among key populations, such as gender identity, poverty, and race. According to the HIV stigma conceptual framework, the inequalities in social, political, and economic power are the foundation of HIV stigma, potentiated by the structural violence and pre-existing stigma. And stigma becomes existing when labeling, stereotyping, separating, and status loss and discrimination all come together in the setting of this power imbalance. Now let's go a bit deeper into PrEP stigma. PrEP is associated with HIV and its socially discrediting behaviors. So PrEP stigma is basically sexual stigma, and it is stipulated by conscious or unconscious discomfort with the idea of sexual expression now unfettered by the threat of HIV infection. Because before PrEP, limiting sexual activity, number of partners, and consistent condom use are two behavioral restraint measures for HIV prevention. But now with PrEP, especially the PrEP is more effective in HIV prevention than those restraint measures. People are threatened and try to downplay PrEP as a less honorable prevention measure. What about U equals U stigma? U equals U stigma is also sexual stigma because with U equals U, condoms are not required to prevent HIV transmission. And there are concerns, especially among healthcare providers, about sexual risk compensation, together with stigmatizing attitudes towards people living with HIV stereotypes related to sexual irresponsibility. HIV-related stigma can be very obvious, and it is commonly related to sexual orientation. As described by this young gentleman from Kenya, MSM is seen as something bad. They take it as a curse. You are a male prostitute. Stigma can also be related to perceived social irresponsibility among people living with HIV. As described by an HIV peer educator, my friend did not get the assistance she needed, but was blamed for getting pregnant again and again. Stigma can also be related to gender identity and gender expression, as described by this Thai transgender woman. I went to the hospital for a shot. The nurse saw that I didn't wear bras and asked if she could see my breasts. Would she do that to a woman? Now, let me take you through a case study of U equals U stigma in Thailand, which just occurred at the beginning of 2020, when an online social influencer who is living with HIV tried to promote U equals U, saying that there is zero transmission risk even if you are not using condom. Of course, when that HIV positive partner has undetectable viral load. And then a large public outrage sparked, condemning him and blaming him for destroying country's HIV prevention effort. Researchers from the Thai Red Cross AIDS Research Center, which is a respected HIV institute and also was one of the study sites for the landmark Opposites Attract study, supported U equals U fact and instantly received intensely negative feedback from the public as well as from their fellow doctors. Several other doctors criticized the evidence generated by Partner 2 and Opposites Attract study, calling it inapplicable to Thailand setting. And subsequently, statements endorsing U equals U were issued by the IAS, by UNAIDS, by Prevention Access Campaign together with APCOM, and by the principal investigators of the Partner 2 and Opposites Attract study, which sadly generated no interest in Thailand, but a simple, although incorrect, message. U equals condom please, made by university-based infectious disease doctor, was praised. So I believe that all of us can see that there are consequences, bad consequences of HIV-related stigma on the uptake and retention of HIV testing, PrEP and other HIV prevention, as well as ART services. HIV-related stigma can negatively impact individuals' perception of their own risk and influence decision-making to take HIV testing. It can affect PrEP and other HIV prevention activities at the same level. And HIV-related stigma is a critical factor in PrEP adherence and persistence, which has hugely slowed down PrEP uptake. And for ART services, the common implicit stigma among healthcare providers towards U equals U, causing the healthcare providers to not communicate U equals U message or to modify U equals U language from no transmission risk to low transmission risk, as well as to incorrectly qualify U equals U as applicable only in the context of condom use, as we have just seen in an example from Thailand. So how we can overcome HIV-related stigma? We surely need multidimensional and multi-level approaches. Approaches which are not only addressing knowledge, but also cognitive and emotional aspects. Approaches which address both individual and structural levels. We need to address fear of transmission awareness of stigma and attitudes among individuals. And especially among healthcare providers, education, clinical guidelines, and hospital policy have proved to work. Public stakeholders also need continuous sensitization through social marketing and mass media to overcome social prejudices towards HIV and other socially unacceptable behaviors. And we need to stop the social structures, change the practices that reinforce HIV stigma. And we can create innovative service delivery models, ones that are of higher quality, destigmatizing, affirming, and more effective. The Key Population-Led Health Services, or KPLHS, was established in Thailand in 2015 in order to address this HIV-related stigma, which has caused low uptake of HIV services among key populations. KPLHS is a set of services designed by members of key population communities in order to ensure that services are needs-based, demand-driven, and client-centered. And the services are delivered by KP-led providers who are trained and certified. KPLHS does not only bring HIV services to accessibility, availability, and of high quality, but more importantly, it has made HIV services become acceptable because staff are members of KP communities who truly understand key populations' lifestyle. Services are gender-oriented and free from stigma and discrimination. And up until now, KPLHS has contributed to more than half of HIV testing and PrEP services among men who have sex with men and transgender women in our country. The Tangerine Clinic is also another good example of key population-led health services. The clinic is the first transgender-led clinics that integrate the gender-affirming care with sexual health care in our region. And it has been successful in demonstrating the otherwise invisible number of transgender women and transgender men who need access to health care. Over the past 5 years, almost 4,000 transgender clients have visited Tangerine Clinic, and the uptake of HIV testing among transgender women clients was high at 95%, with a high HIV positive testing yield at 10%. Although we still see quite a low acceptance of PrEP, only at 13%. So now let's talk about how we can overcome PrEP stigma. We can certainly change PrEP campaigns and PrEP guidelines from emphasizing that PrEP is for high-risk, very high-risk individuals to something that emphasizing that PrEP is for people who want to reduce the anxiety about the HIV infection and who take greater responsibility for their sexual health. Because no one wants to be linked with high-risk behaviors, especially that if those behaviors are socially unacceptable. Therefore, creating positive social association with PrEP users who want to feel better and stay healthy will likely increase acceptability and interest. We can also replace traditional risk assessment, which usually will label people as having high risk, very high risk, very suitable for PrEP, with questions that emphasize clients' sexual health concerns and sexual health goals. This will help individuals feel that providers are truly trying to give them what they need rather than trying to evaluate and judge them. Let me use the PrEP in the City campaign as an example here. PrEP in the City campaign is the first PrEP campaign for transgender women in Asia. It was designed, produced, and delivered by transgender women. The campaign portrays lives of ordinary transgender women who integrate PrEP use into their routines. And it highlights the gain framing messages rather than the risk reduction messages. And the campaign also aimed to enhance the visibility of transgender women in the Thai healthcare systems. So far, this campaign has received positive feedback and is very welcome in public in Thailand, although with small caveat that at the beginning phase of the campaign launch, the campaign was not allowed to be put on one LED screen in front of one of the large shopping malls in the country, because that shopping mall was concerned that there are too many youths walking around this area. So this again demonstrates pervasive stigma in our society. We don't know if it's stigma towards HIV or PrEP or transgender women. And the key population-led health services has contributed to the majority, almost 60% of PrEP uptake in our country as of now. While the PrEP services in the public hospitals only contributed to less than 1/5 of the uptake in the country. And this clear difference of low PrEP uptake in public hospitals and very high PrEP uptake in the key population-led clinics has made a few infectious disease doctors to start to advocate for the inclusion of key population-led health services into the main public health system in our country through the domestic financing mechanism, which will allow key population-led clinics to directly reimburse the cost of their services from the government. Now, let's talk a bit about overcoming U=U stigma. We certainly need to establish universal U=U patient education in normative guidelines, which would dictate clinical practice. This is in order to avoid U=U message being communicated in a discretionary fashion. And we need to incorporate U=U into clinical education for all HIV service providers, as well as to have concrete tools to facilitate patient-provider conversations about the correct U=U message. And lastly, public awareness campaign, such as ones that have been made by the Prevention Access Campaign together with its allies, will need to be continued and broadened. So to conclude, we all know that HIV stigma, PrEP stigma, and U=U stigma affect uptake and retention in HIV testing, PrEP, and ART services. And the implicit HIV stigma, which is not always correlated with explicit stigma, needs to be more seriously explored and addressed, especially among healthcare providers and policymakers, to avoid systematic discrimination. And the social structures and practices which perpetuate HIV stigma must be disrupted. Good examples are available and must be scaled up. Restricting access to or restricting knowledge about PrEP and U=U because of fears associated with condomless sex and STIs is not sensible, and it is not an ethical practice. It is time to overcome HIV-related stigma, which has delayed full integration of PrEP and U=U into our clinical practices for the benefit of individual people living with HIV or who are affected by HIV and the societies. I would like to thank you all for listening to this talk.
I, as a person living with HIV, will try to advocate to the public that if you are people living with HIV, you have nothing different to the others. For community members, I would like to praise you, whatever you are, whatever you be. That if you are people living with HIV, you get treatment, you spread the viral load until undetectable. You have to dare. You have to dare to overcome your self-stigma. You have to dare to dating app. You have to dare to having sex. You have to dare to having boyfriend, girlfriend, or you having plan to get married with someone, or you have to dare to plan to having a child. So if you truly understand and truly believe about use equal you, that people living with HIV on effective medication suppress the viral load. They cannot transmit the HIV to your partner any way at all. So if you believe that, you have to overcome this self-stigma by yourself. And after that, next lesson learn about how to deal with the external stigma from outside, from other people. So I think I cannot tell you about what is the best way to deal with stigmatization. You have to try to deal with it. You have to dare to try to deal which way is suit for you, which way is comfortable for you, which way is work for you. You have to try, because I and you, we are different. I cannot use my own way to represent to you that my own way is work, but it doesn't mean it will work for you. You have to try to deal with stigma and discrimination by yourself. So nothing scary. So just try to be yourself. Just try to proud to be yourself. Just try to proud to living with HIV, and proud as much as possible as you can. So, and others will touch you that whatever I am, whatever you are, we are human beings. Everyone deserves to be respected as a human being. Thank you.
Good afternoon, ladies and gentlemen. First of all, I'd like to thank the organizing committee, Gilead, and the SC Orica for invitation to give a talk on Industrial Symposium today. And the title of my talk is Legacy of ART from Old to New in HIV Treatment. This is my disclosure. I have two parts to talk today. The first part will be talking about the ART regimen. Will be focusing on British-Korea and the other recommendation from the guidelines. And the other part will be in the next session. I will be talking about choosing the backbone for HIV treatment. In the first part, I will give you the overview of current recommendation from the guidelines, and then I will specifically look at and then followed by how to choose triple ART regimen versus dual ART regimen, or 3 drugs versus 2 drug regimens for clinical practice. And then we'll end up by conclusion. This is the progress in HIV treatment and preventions. We have known HIV for 30 or 40 years, and we do have the treatment in the past. But after we have the triple therapy in 1996, we start having the potent ART regimen that can reduce the viral load and achieve the CD4 into the normal level. So after we have the triple therapy, you can see that we have the declining the rate of new infections, and together with the other treatment, for example, OI prophylaxis and OI treatment, we start seeing the AIDS-related death globally after 2000s. Meanwhile, after we have the potent ART regimen, we now have we have seen that the life expectancy of people living with HIV has increased from the past. You can see on the right side of the graph, the death rate per 100,000 person years of people living with HIV has declined. after we have the potent therapy. Right now, we can see that we can say that our patients have very similar life expectancy comparable to uninfected individual because we have the potent treatment, we have the potent antiviral treatment, we have the potent treatment for opportunistic infections, and we have the opportunistic prophylaxis for people who have very low CD4 T cells count. This is a progress in HIV treatment and prevention. In the past, at the beginning of the treatment, we have known very few agents that can reduce the virus. These agents that we used in the past are less potent, short-acting, and has high toxicity that leads to very short-term tolerability and leads to discontinuation of AR2 treatment and failure. In 2006, we start having the single tablet regimen that combine 3 agents in one pill, or we call single tablet regimens. We have Atipla, which is the combination of TDF, FTC, and efavirenz for our HIV patients. This is the advance of HIV treatment because after we have STR regimen or single tablet regimen, we can use the agent with potent viral activity in this single tablet regimen and leads to long-term tolerabilities and long-term adherence for our patients. In 2007, we have found that we had ralticovir, which is the first integrase inhibitors in for HIV treatments. And after 2007, we enter the integrase inhibitor era. Right now, we do have many single tablet regimen that combines many potent antiretroviral agents for our patients. When we select an optimal ART regimen for our patients, the goal of ART regimen or ART therapy is to provide potent, safe, tolerable, and easy to adhere to the regimen in order to achieve sustained virology control. Right now, we have regimens that have high viral suppression rate, low pill burden, less toxicity, better tolerabilities, low drug-drug interactions, convenient to take, and has high genetic resistance to high genetic barrier to resistance. When we look at the guideline, this is the DHS guideline from the US. In the US guideline, now recommend integrase inhibitor-based regimen for treatment-naive patients. All of these integrase inhibitor list in alphabetically. For example, you can see that in the guideline recommend using bictegravir, dolutegravir, and ralticovir for treatment-naive patient in combination with 2 NRTI. For example, bictegravir can be combined with TAF FTC in one tablet regimen. Dolutegravir can be combined with abacavir 3TC in one single tablet regimen. And dolutegravir can be combined with 2 NRTI in split backbone TDF FTC or TAF FTC. You can see in the list that there is one other integrase inhibitor, which is in the first generation integrase inhibitor that recommended in the DHS guideline, ralticovir. Ralticovir can be used in combination with TAF FTC or TDF FTC for HIV treatment-naive patients. So these are the list from the DHS guideline. They do recommend to use integrase-based regimen for initial therapy for treatment-naive patients. However, there has been emerging data for dual therapy. You can see in the list that DHS guidelines still is recommending DTG plus 3TC for initial therapy. This is a dual therapy or 2 drug regimens. Some of dual antiretroviral regimens are safe and efficacious for both initiation and maintenance therapy. At this time, combination of dolutegravir plus TTC represent the best dual regimen. However, longer follow-up and larger study population are needed before supporting DTG plus TTC widely. You can see that in the table, if you want to start DTG plus TTC, there must be some considerations because this regimen should be used in patients with baseline virus or viral load less than 500 copies per ml, no hepatitis B co-infections, and if possible, before initiation of DTG plus TTC, genotypic resistance should be done in order to avoid giving DTG plus TTC in patients with pre-existing lamivudine or TTC resistance, which may cause suboptimal response to this dual therapy. This is the recommendation in AIS guideline. In AIS guideline, still recommend integrase-based regimen for the first-line therapy for HIV treatment-naive patients. It recommends to use big TAF, dolutegravir plus 2-NRTI, TDF, FTC, TDF, FTC, TAF, FTC, or TDF can be combined with lamivudine for the backbone. And the dolutegravir plus lamivudine is recommended in IAS guideline, but with some caveats. Right now, we have a second and first generation integrase inhibitor for clinical practice. However, in most of the guidelines recommend use of the second generation integrase inhibitor for initial HIV therapy because the first generation integrase inhibitors still have some limitations. For example, lower genetic barrier for raltegravir and abacavir. This is the slide showing efficacy of phase 3 study of integrase inhibitor-based regimen. You can see that there are data support that integrase-based regimen is safe and have durable efficacy. For example, in START study that used raltegravir has been shown that the efficacy of raltegravir-based regimen could be maintained through week 240. And in single study that used DCG plus abacavir with TTC, the efficacy of this regimen is very high through week 144. DTG plus FCC and TAF in study 1490 has a high efficacy through week 144, and Big TAF in study 1489, 1480 has high efficacy through week 144 as well. In this slide show the potency of second generation integrase-based triple therapy. You can see that there are the study support that in second generation integrase-based triple therapy are safe and have long-term tolerabilities. In this slide show that efficacy of Big TAF, DTG plus abacavir and TTC, DTG plus TAF FCC has high efficacy. In the graph show that of this regimen have efficacy greater than 80%, and the rate of allergic failure is very low in all the studies. Now I will look through the data of bictegravir. Bictegravir is used in combination with TAF FTC. This slide shows the comparisons of the pill size. You know that one of the factors that determine effectiveness of the treatment is the pill burden and frequency of dosing. When you look at the picture, Big TAF has the smallest size when compared to the other single tablet regimens. And the patient compliance with the medications regimens may be influenced by the size and shape of the tablet or capsule. So this is the slide confirmed that Big Tab has smallest 3 dots integrates containing single tablet regimens that can be used for both treatment naive and virologically suppressed patients. When we look at pharmacology and administration of Bictegravir, Bictegravir is an agent that can be dosed once daily because it has very long plasma half-life for 18 hours and has few drug interactions. This agent has no CYP3A4 PK booster and not a CYPA inhibitor or inducer, and not a UGT inhibitor or inducer. Has minimal inhibition of renal OCT2 and MATE1. And this is very important because this agent has no clinically meaningful alteration in metformin level in patients with diabetes. And this agent can be used in patients with renal impairments. In patients with mild to moderate hepatic impairment, this agent can be used. However, in patients with impaired GFR, this agent must be used in patients with eGFR greater than 30 or equal 30 ml per minute. And this agent has favorable resistance profile based on in vitro analysis compared to DTG-RAL and Elvitegravir. And this agent has very simple form of administrations. Bictegravir in combination with TAF FTC has knowledge integrase-based 1 pill once daily single tablet regimen and can be dosed with or without food. No PK boosting via CYP3A4 inhibition, plus there is no drug-drug interaction. And this agent can be initiated without waiting for baseline lab result, for example, HLA-B star 1701, 5701, CD4 or viral load hepatitis profile. So this agent can be used in patients with rapid initiation of ART or in patients with acute HIV infections. In vitro data, it has been shown that these agents have very long dissociation half-life. So what is dissociation half-life? Dissociation half-life is the time before the integrase inhibitor that bind with integrase dissociate from each other. The potency of ART agents can be determined by the half-life of dissociation. When you look at the graph, you can see that dissociation half-life of Bictegravir from integrase complex is longer than the other integrase inhibitors for wild-type virus and longer than dolutegravir. Bictegravir also has long half-life in dissociation half-life with virus that develop resistance to the other integrase inhibitors. And in vitro study from phenotypic resistance profile, it has been shown that this agent retains activity against the mutant that has resistance to first generation integrase inhibitors, Bictegravir and Elvitegravir. So this is an in vitro study that suggests that Bictegravir has very potent activity against wild type and resistant strain. When we look at the clinical study of Bictegravir for treatment naive and treatment experienced patients, This slide shows the data of the efficacy of Big TAF in treatment naive in study 1489 and 1490. And in treatment experienced patients in study 1844 and 1878. In treatment naive patients in study 1489, it used Big TAF compared with DTG plus abacavir plus TTC. And the study conducted in treatment naive patients through 144 weeks. It has been shown from this study that the efficacy of Big TAF is comparable to DTG plus abacavir and TTC through week 144, 82 and 84% respectively. And in another study, 1490, it used Big TAF compared with DTG plus TAF FTC in treatment naive patients, and study is look at the efficacy of 144 weeks after initiations. You can see that the efficacy of Big TAF was 82 and DTG plus TAF and FTC was 84%. So these numbers are comparable. And then we look at switching study. In study 144 and 1844 and 1878, it's conducted in treatment experienced patient with biologic suppression and then switch to Big TAF. It has been shown that after switching of the other regimen to Big TAF, this regimen can maintain biologic suppression through week 48 in both studies. And the rate of achievement is very high, greater than 90% in both studies. So in summary, from this full study demonstrate that Big TAF demonstrate non-inferior efficacy with few discontinuations and no emergent resistance. And treatment outcome in Big TAF were similar across age, sex, race, and geographic distribution in all studies. And treatment outcome were similar in all baseline wild alert CD4 cell count in treatment naive study. When we look at the data of Big TAF in various populations, there are so many studies that conduct that look at the efficacy of Big TAF in many populations. For example, one study 1961 looked at the efficacy of Big TAF in women in comparison with TAF FTC plus elviticovir, or in comparison with TDF FTC plus boosted atazavir in women participants. This study look at the efficacy through week 48. You can see that this study has been shown that Big TAF has efficacy similar to comparator at week 48. And there are some studies suggest that Big TAF can be used in children and adults greater than 65 years old. And some studies look at the efficacy of Big TAF in patients with pre-existing resistance, and it has been shown that efficacy and safety of switching and initiation of Big TAF is high in a broad range of patient type. This is a study of Big TAF in HIV treatment naive patients, study 1489 and 1490. These two studies look at the efficacy of Big TAF in comparison with DTG plus abacavir plus TTC and DTG plus TDF FTC. So these two studies have shown that Big TAF was not inferior to dolutegravir-based triple therapy regimens, and Big TAF is well tolerated with no emergent resistance for treatment-naive patients through week 144. You can see that the efficacy of Big TAF and comparator are similar through week 144, and with very low rate of discontinuation due to adverse events and no emergent resistant mutants from both studies. In these two studies, also look at the change in body weight and fasting lipid through week 144. As you know that some of the ART regimen may cause weight gain and metabolic derangements, especially in some data has been shown that integrase-based regimen is correlated with weight gains. In study 1489 and 1490, also look at the rate of weight gain comparing between Big TAF and DGG-based regimen. You can see that from the first graph, you can see that in the study 1480, 1489 and 1490, the median weight of the weight gain are similar between Big TAF and comparator, in this case dolutegravir. And for the metabolic derangements, there was no difference in change in the level of total cholesterol, LDL, HDL, triglyceride, and the ratio of the lipids. So in summary from these two studies, there is no difference change in body weight between Big TAF and DTG containing triple therapy arms, and there's no clinically significant difference in the change of from the baseline fasting lipids. When we look at the real-world evidence of Big TAF for treatment-naive and treatment-experienced patients, this is data from Big STAR study which is ongoing multi-country study and real-world observational cohort in patients with HIV, and they are treatment-naive and treatment-experienced patients. Some of the participants in this study start with Big TAF, and some of the participants in this study has been on the other ART regimen and then switched to Big TAF. So this slide shows the demographic data of the participants in Big STAR study. When we look at the treatment-naive patients, you can see that 50% of the patients in treatment-naive population in this study have comorbidities. For example, approximately 20% of participants in this study have neuropsychiatric disorder, 6% has hypertension, and 8% has hyperlipidemia. Again, when we look at the treatment-naive populations, this study enrolled pretty sick patients. For example, approximately 20% of participants has CD4 less than 200, and 37% of participants in this study has baseline viral load greater than 100,000 copies per ml. In the graph, show the previous regimen before switching in treatment-experienced patients. You can see that some of the participants in this study has been on the other ART regimen before switching to Big TAF. Most of the ART regimen that used before switching is integrase-based regimen, which include dolutegravir, elvitegravir, and raltegravir. And 17% of patients used NNRTI before switching, and 10% of participants used PI before switch to Big TAF. And when we look at the results, this is the result from Big STAR study. When we look at the efficacy of the treatment for treatment-naive patients, all participants can achieve viral load less than 50 copies, at 12 months after initiations, and the rate of adverse events was very low, 4.8% for treatment-naive patients. And then we look at treatment-experienced patients at 12 months. 95% of participants can achieve the viral load less than 50 copies per ml after switching from the other regimen to Big TAF regimen. And the rate of discontinuation from adverse event was 7.7%, which is very low. And these two studies has no emerging resistance to Big TAF. So in summary, Big STAR study has been shown that real-world evidence demonstrates the effectiveness of Big TAF with no treatment emergent resistance. Now I'm going to discuss about using 3 drugs versus 2 drug regimen, because in most of the guidelines still recommend triple therapy for treatment-naive patients, but some part of the guideline mentioned using 2 drug regimen for treatment-naive patients. For example, this is the DHS guideline that recommend DTG plus 3cc for treatment-naive patients. However, in this guideline mentioned about the limitation of using DTG plus 3cc. It should be used in patients with baseline HIV viral load less than 500 copies per ml, no hepatitis B co-infection, and no pre-existing lamivudine resistance. As you know, that baseline resistance may affect the outcome or virologic suppressions. This is the data of the study that used 2 drugs versus 3 drugs for treatment-naive patients. In Gemini study 1 and 2, before the patient assigned to the treatment arm, genotypic resistance must be tested. And from Gemini 1 and 2 study, it has been shown that the rate of pre-existing lamivudine resistance was very high, about 12%. And in a similar study, ACTG 5353 study, they used DTG plus 3cc for treatment-naive patients, and they exclude the patient with pre-existing lamivudine resistance. And from ACTG study, found that the rate of lamivudine resistance was 6.7%. So this is the factor that you need to consider before using dual therapy for treatment-naive patient. One of the key things that we need to consider is baseline resistance, and some of the setting, genotypic resistance cannot be done or cannot be sent immediately. For example, in patient with acute HIV infection or in patient who need rapid initiation. So this is there might be limitation of using 2 drug regimen in these populations. So when we looked at the characteristic of the people who fail dual therapy DTG plus 3cc in the clinical trials, in the slide show the characteristic of 2 patients who fail DTG plus 3cc in ACTG 5353 and Gemini study. The first patient was treatment-naive patient with baseline viral load was 40,000 copies per ml and CD4 greater than 200 cells per ml. And in the second patient was the patient with baseline viral load 90,000 copies per ml and CD4 was of 390 cells per ml. So these 2 patients were eligible to get DG plus 3cc arms. And when these 2 patients had virologic failure, you can see that both patients have resistance to lamivudine by having M84V, and also integrase resistant mutations are 263 or K in both patients. So indicating that when these two patients fail dual therapy, the virus may develop resistance to lamivudine and DTG. And these two patients report that they have low adherence to the treatments. So in summary, treatment failure in dual therapy may occur, but when it will occur in patients with poor adherence to the regimens. And when they fail this to dual therapy, the virus may develop resistance to integrase inhibitor and lamivudine. So this is the data that need to consider before initiation of dual therapy for treatment-naive patient. You need to talk to the patient about the high adherence to the regimens. And this is the other study has been shown the rate of discontinuation and allergic failure comparison between 2 drugs and 3 drug therapies. This study called WAC cohort that conducted in Spain. WAC cohort is retrospective analysis of a last Spanish cohort with a total number of 9,000 participants. This study aimed to compare the real-world persistence and efficacy of DTG-containing triple therapy versus DTG-containing 2 drugs combinations. You can see from the graph that the rate of persistency of triple therapy is higher than dual therapy. And on the right side of the graph, show that the efficacy, long-term efficacy of triple therapy is higher than dual therapy. So in summary, significantly higher risk of discontinuation and allergic failure with DTG-based 2-drug combination versus 3-drug triple therapy in treatment-experienced patients. In summary, the clinical study with Big TAF has been shown high efficacy with no treatment-emergent resistance in a broad range of patient types, with very few discontinuation due to adverse events. And in the clinical trials, also demonstrate the non-inferiority of 2-drug regimen versus 3-drug regimens. However, there are 2 cases of treatment emergence to class resistance have been reported. Additional real-world and longer-term data with dual therapy, either using DTG plus 3TC or DTG plus 3TC in single combination are needed. So it is good to see you again in the second part of my talk. This is a symposium that's sponsored by Gilead and the CH Orica industry. And the second part of my talk, we'll be talking about the backbone in HIV therapy. And the title of the talk is Legacy of ART, a New Backbone in ART Therapy. This is my disclosure. And this talk, I will focus on the backbone for ART regimen that recommended in international guidelines. And I'm trying to focus on TAF-FTC that will be used in clinical practice. And we will look at the clinical data, efficacy, and long-term tolerability of TAF-FTC in comparison with the other comparators as a backbone. This is a statement in the DHHS guideline to 2020. It is recommended that an ARV regimen for treatment-naive patients, it should consist of 3 drugs. 2 drugs are an NRTI or backbone, backbone should be combined with the third agent. Third agent could be integrase strand transfer inhibitors or integrase inhibitors, or the third agent can be non-nucleoside reverse transcriptase inhibitor or NNRTI, or the third agent can be a protease inhibitor with a pharmacologic enhancer or boosted PI. The potency of ART regimen is depending on the composition in the regimen, not only the third agent, but also the backbone. This slide shows the recommended ART regimen in the HHS 2020s. In the guidelines, recommend integrase-based regimen is a preferred regimen for treatment-naive patients. The third agent can be combined with the backbone that should be 2-NRTI. When you look at the slide, integrase-based regimen that mentioned in DHS guideline are Bictegravir, dolutegravir, or raltegravir in combination with 2-NRTI. For example, Bictegravir is used in combination with TAF-FTC in one single tablet regimen. Dolutegravir can be combined with abacavir plus TTC in single tablet regimen, or DTC can be used together with TAF or TDF plus FTC in split pill regimen, and raltegravir can be combined with TDF FTC or TAF FTC as a potent ART therapy. However, in the same guidelines also mention the role of two-drug regimen for treatment-naive patients, in this case DTG plus 3TC. There has been emerging data that suggests that two-drug regimen might be used or can be used in some specific setting for treatment-naive patients. However, there are some limitations when using two-drug regimen for treatment-naive patients. It is recommended that if you want to use two-drug regimen, DTG plus TTC, the patient should have baseline HIV RNA or baseline viral load less than 500 copies per ml, 1,000 copies per ml, no hepatitis B co-infections, and genotypic resistance should be done before initiation of two-drug regimen, because sometimes some patients may have primary resistance which already acquire lamivudine resistance that may compromise the efficacy of two-drug regimen. And this slide, I would like to focus specifically in each backbone. First, I will talk about abacavir plus TTC. Abacavir 3TC is a combination of two drugs. It could be used as a single pill in combination with the other third agents, or it can be used as a single tablet regimen when combined with dolutegravir. In this case, dolutegravir, abacavir, and 3TC as a single tablet regimen. Abacavir plus TTC is once daily dosing. It is very convenient for administration. However, there are some adverse effects of abacavir. For example, hypersensitivity reaction that require genetic testing HLA-B*5701 before initiation of abacavir. And in some study suggests that abacavir might increase risk for cardiovascular events. So when we want to use abacavir, we need to assess the risk or cardiovascular risk of the patient. If the patient has high cardiovascular risk, abacavir should be avoided. And this combination should not be used as a treatment in hepatitis B co-infection because the patient might develop resistance to lamivudine if we use lamivudine for hepatitis B treatment as a monotherapy for hepatitis B treatments. And in some studies suggest that abacavir plus TTC may cause suboptimal response in patients with baseline HIV-RNA greater than 100,000 copies per ml. For example, ACTG 5202 suggests that when used abacavir plus TTC in combination with efavirenz or boosted atazanavir in patients with high baseline viral load greater than 100 copies per ml might have inferior virologic response comparing to the other regimen. However, this difference was not seen when abacavir and TTC was used in combination with dolutegravir. Next, we will look at TAF-FTC. TAF-FTC is once daily dosing regimen that can be used with the other third agent as a split pill regimen or single tablet regimen. You can see that there are so many combinations of TAF-FTC with the other drugs as a single tablet regimen. For example, bictegravir, bictegravir, TAF-FTC, or TAF-FTC can be combined with darunavir and cobicistat in one single tablet regimen. TAF-FTC can be combined with elvitegravir cobicistat as a single tablet regimen. The adverse effects of TAF-FTC are renal and bone toxicity. TAF also increases the lipid level, and some studies suggest that using TAF may cause weight gain in some specific populations. FTC may cause skin discolorations in some patients. When considering using TAF, TAF-containing regimen are approved for use in patients with eGFR greater than or equal 30 ml per minute. It is safe in patients with renal insufficiency. However, eGFR should be greater than 30 ml per minute. For next, we will look at TTC as a backbone. TTC as a backbone is usually combined with DTG as a two drugs regimen. TTC has very minimal adverse effects. However, when using this regimen, it cannot be used with patients with hepatitis B co-infection due to development of resistance, as when we use lamivudine as monotherapy for hepatitis B co-infections. This slide summarizes some clinical scenarios that we commonly see in clinical practice and considerations. This is the scenario that mentioned in DHHS guideline 2020. When we use abacavir plus TTC, HLA-B star 5701 should be tested before. And in some specific setting that we need to initiate ART immediately, or in patients with acute HIV infection, we don't have time to wait for HLA-B star 5701. So TAF-FTC is preferred backbone for this specific setting. In patients with chronic kidney disease, defined by creatinine clearance less than 60 ml per minute, in general, it is recommended to avoid TDF, but TAF may be used. However, if creatinine clearance is less than 30 ml per minute, TAF should be avoided. In addition, in patients with chronic hemodialysis, TAF-FTC plus elvitegravir cobicistat can be used. Next, I will talk about the clinical profile of TAF-FTC as the combination for ART for treatment-naive patients. This slide shows the activity of TAF monotherapy in treatment-naive patients after giving TAF monotherapy for 2 weeks, and we look at the response by looking at the level of HIV RNA or the rate of declining of HIV RNA. You can see that after 1 week, various doses of TAF cause significant reduction of HIV RNA, and the optimal dose for using TAF is 20 milligrams per day. This slide shows the comparison of TDF and TAF. Usually, when we give the drugs for HIV treatment, drug should enter the lymphocyte, and within the lymphocyte, drug will act as the inhibitor for HIV replications. When we give tenofovir is not well absorbed in GI tract. Tenofovir should be given as a product. For example, TDF is a product of tenofovir. TDF, when digested or dissolved in the GI tract, will give amounts of tenofovir in the plasma. The large proportion of tenofovir from TDF will go to renal cells, and small proportion of tenofovir in the plasma go to the lymphocyte and act as HIV replication inhibitors. But when we give TAF is a product of tenofovir, and this compound gives very minimal exposure of tenofovir in the plasma, and large proportion of tenofovir from TAF direct to lymphocyte, which is a target for HIV replications, and minimal amount of tenofovir from TAF go to renal tubular cells and bone. So this is the reason why TAF has lower toxicity to bone and kidney comparing to TDF. This slide shows the level of tenofovir comparing TAF and TDF. You can see that the level of tenofovir in the plasma in people who receive TDF is greater than TAF, both in combination with various third agents. Next part, I will talk about the efficacy of TAF from the clinical study. Most of the clinical study that suggest the efficacy of TAF derive from the switching study and the study that conducted in treatment-naive patients. For example, study 1089. This study used TAF in comparison with TDF. And study 1717. This is a switching study that compared the efficacy of TDF-FTC versus abacavir plus TTC. And the other study, 1269 study, this is the use of TAF plus FTC in adolescent populations. This slide shows the clinical study of TAF-FTC and look at the efficacy of this combination in comparison with the other backbone. Like most of this study compare TAF-FTC versus TDF plus TTC. There are two studies in this slide that conducted in treatment-naive patients, and the other study were conducted in treatment-experienced patients with virologic suppressions. You can see that the efficacy of TAF-FTC versus TDF-FTC are comparable in both treatment-naive and treatment-experienced patients with virologic suppressions. In study 1069, this is a switching study that compared the efficacy of TDF-FTC plus TAF-FTC as a backbone in combination with the other third agents. In this study, they selected patients who already received ART regimen, and these patients were HIV-infected individual with virologic suppressions and has been on TDF plus FTC, and then switched to TDF-FTC. The primary endpoint were measured at 48 weeks, and the secondary endpoint were measured at 96 weeks. And this study enrolled a total of approximately 600 patients. And when we look at the data on the right side of the slide, the graph, we can see that at 48 weeks and at 96 weeks, the clinical efficacy of TDF-FTC versus TDF plus FTC were comparable. 84% for TAF-FTC, 94% in TAF-FTC, 93% in TDF plus FTC at 48 weeks, and approximately 60% in both, 90% in both arms at 96 weeks. So the response rate of TDF-FTC were comparable in this study. And then we look at the renal parameters of this study, comparing the people who were on or continue using TDF plus FTC versus people who switched from TDF-FTC to TAF plus FTC. You can see that there was an improvement of some creatinine, and there are improvements of some renal parameter that are associated with proximal tubulopathy in a patient who switched from TDF plus FTC to TAF plus FTC. There were improvement of urine protein, creatinine, or retinol binding protein, and beta-2 microglobulins. These are the markers of proximal tubulopathy. So after switching, there is improvement of all renal markers that correlated with proximal tubulopathy. And look at the bone. After switching from TDF-FTC to TAF-FTC, there's improvement of the bone density at spine and active in TAF-FTC group. For the lipid, it is known that TAF may cause hyperlipidemia, but data from this study suggests that the level of the lipid change in both arms were comparable, and only small proportion of people who switch from TAF-FTC, from TDF plus TTC to TAF plus FTC initiate lipid-lowering therapy. So in summary, proteinuria, albuminuria, and proximal renal tubular function and renal and bone mineral density improved after switching to TAF from TDF-containing regimens. So these long-term data support that TAF-FTC is safe, well-tolerated, and durable in an RTI backbone. Study 1717, this is another switching study that enrolled patients with virologic suppression from abacavir plus TTC and then switched to TAF FTC and look at the clinical efficacy or virologic suppression at 48 weeks. The study enrolled approximately 500 individuals who are already suppressed by bacteria plus TCC and then switched to TEF plus FTC. At 48 weeks, you can see that the rate of response were comparable between each arm, 90% in TEF FTC and 93% in bacteria plus TCC arms. And we look at the bone and renal parameters. This slide suggests that there were no difference between bone markers, bone density, and renal marker for renal tubulopathy. So in summary, TAF FTC was not inferior to abacavir plus TTC in maintaining virologic suppression in combination with a variety of third agents, and no difference in renal and bone biomarker in TAF FTC versus abacavir plus TTC. And there, in this study also suggests that there's no significant difference in the lipid level when switched from abacavir plus TTC to TAF plus FTC. The other thing that I would like to show you in this slide is the impact of switching from abacavir plus TTC to TAF FTC on the platelet functions. This study called SWIFT-TIE. It looked at the level of soluble glycoprotein 6, which is correlated with platelet aggregation. When you look at the cartoon, you can see that on the platelet, there are some glycoprotein 6 on the surface of the platelet. And this glycoprotein 6, it could be in the on the membrane of the platelets, or it could be in soluble form. If the density of glycoprotein 6 on the platelet is very high, it will correlate with higher chance of having thrombosis or platelet aggregations. If the level of soluble glycoprotein 6 is very high, it correlated with less thrombosis or less platelet aggregations. In the graph, you can see that when compare the level of soluble glycoprotein 6 in patients who received bacavir plus TTC versus TDF plus FTC, you can see that the level of soluble glycoprotein 6 is higher in patients who receive TDF plus FTC. So this may explain why some patients may have cardiovascular events in case who were on abacavir plus TCC. And on the right side, on the right graph, it is shown that the comparison of the level of soluble glycoprotein 6 in patients who were on TDF FTC versus abacavir plus TCC. So this graph may explain why abacavir plus TCC may associated with platelet aggregation and may cause some adverse effect on the clinical events of cardiovascular. There are some studies that suggest that TAF can be used in patients with severe proximal tubulopathy. There are some reported cases that describe the people who or the patient who had the problem of proximal tubulopathy from TDF, and they switch from TDF to TAF in patients with severe proximal tubulopathy or Fanconi syndrome. And this slide summarizes the clinical data of the patients who switched from TDF FTC to TAF FTC. And some of them or many of them have improvement of the Fanconi syndrome after switching from TDF FTC to TAF. So It suggests that TAF can be used even in patients with severe proximal tubulopathy due to lesser effect on proximal tubular cells comparing to TDF. So in summary, TAF FTC is a new backbone which 90% lower plasma xenophobia comparing to TDF, and lower xenophobia level result in significantly lower off-target effects, including renal and bone toxicity. And this agent can be used in people with impaired renal function, but the level of creatinine clearance should be greater than or equal 30 ml per minute. And these combinations can be combined with the third agent in many populations, for example, treatment-naive patients, treatment-experienced patients, and hepatitis B co-infections. I would like to end here. Thank you very much.
HIV-NAT stands for the HIV Netherlands Australia Thailand Research Corporation. It is Asia's first HIV clinical trial center established in Bangkok in 1996. It started from the burning need of having life-saving medications for thousands of infected Thai patients at that time. AIDS came to Thailand in mid-1980. By mid-1990, several thousands of Thais have been infected. Most of them were untreated, mainly because of the high cost of medications. In early 1990, I had the chance to meet Professor David Cooper from Sydney and Professor Joop Lange from Amsterdam. Both of them were famous HIV/AIDS clinicians. They also had their own HIV clinical trials unit in their own countries. So I asked both professors to help me setting up a similar trials unit in Bangkok so that Thai patients can benefit from the free AIDS drugs by clinical trial settings. Fortunately, both Professor Cooper and Professor Lange were able to convince the drug companies at that time to invest setting up a similar trial unit in Bangkok. HIV-NAT opened its door in July 1996 at the King Chulalongkorn Hospital of the Thai Red Cross Society. At that time, there were only 3 staff, including one doctor, Dr. Eugene Kroon from Amsterdam. Right now, HIV-NAT is an organization with 120 personnel with 5 doctors. At the beginning, HIV-NAT performed a post-marketing drug trials by comparing the safety and tolerability and efficacy of various combinations of antiretrovirals. Later on, it gradually gained recognition to the point that HIV-NAT can join international new drug studies, including the strategic trials like a when to start trial. HIV-NAT started by doing post-marketing drug trials by comparing various combinations and various dosing regimens of many antiretroviral drugs. It gradually gained recognition to the point that HIV-NAT can be involved in new drug trials, as well as some new strategic clinical trials like when to start trial. For the last 7 years, HIV-NAT has been a part of the NIH-sponsored Clinical Trial Unit or CTU, together with University of Chiang Mai. During the last quarter of century, HIV-NAT with the HIV clinical trials, tuberculosis trials, hepatitis B, comorbidity trials, more than 200 studies involving more than 4,000 patients have been involved. With all of this, the following achievements have been done. First of all, lives of several thousands of Thai infected people have been saved. From 1996 to 2006, when antiretroviral drugs were included in the Thai Universal Health Coverage Program. In fact, the Universal Health Coverage Program in Thailand was fueled by or influenced by the Thai network of people living with HIV, as well as by the clinical benefit of patients from HIV-NAT studies. Secondly, HIV-NAT has helped in building up the competency and infrastructure of HIV clinical trials in several hospitals, including several medical schools in Thailand, as well as 2 units in Phnom Penh, Cambodia. The results of several HIV-NAT studies have been used as a guidelines in Thailand as well as international guidelines. But most importantly, HIV-NAT has established the Bangkok International Symposium of HIV Medicines for the last 23 years, including the one this year, which is the first time in a virtual conference. One and a half years after the establishment of HIV-NAT, the first Bangkok International Symposium of HIV Medicine was held in January 1998. The rationale of holding such conference because the 3 co-directors were scheduled to meet annually for the HIV-NAT retreat. It would not be difficult for Professor Yup Lange and Professor David Cooper to invite a few more of their friends to join them in Bangkok, and also to hold lectures for Thai healthcare professionals when they were here. This is why the first Bangkok Symposium was started and has been continuing on for the last 23 years, including this one, which is the first virtual conference. Starting from local audience, it gradually gained the recognition from clinicians from the region as well as from the world. In fact, out of these 500, 600 participants every year, half of them are non-Thais. The unique feature of the Bangkok Symposium was the educational nature. Speakers, both from Thailand, the regions, as well as from Australia, Netherlands, and USA, were asked to review the recent development for the last 1 or 2 years so that audience don't have to go to all over the world for the meetings. I hope you enjoy this year's conference. HIV-NAT stands for the HIV Netherlands Australia Thailand Research Corporation. It is Asia's first HIV clinical trial center established in Bangkok in 1996. It started from the burning need of having life-saving medications for thousands of infected Thai patients at that time. AIDS came to Thailand in mid-1980. By mid-1990, several thousands of Thais have been infected. Most of them were untreated, mainly because of the high cost of medications. In early 1990, I had the chance to meet Professor David Cooper from Sydney and Professor Jup Lange from Amsterdam. Both of them were famous HIV/AIDS clinicians. They also had their own HIV clinical trials unit in their own countries. So I asked both professors to help me setting up a similar trials unit in Bangkok so that Thai patients can benefit from the free AIDS drugs by clinical trial settings. Fortunately, both Professor Cooper and Professor Lange were able to convince the drug companies at that time to invest setting up a similar trial unit in Bangkok. HIV-NAT opened its door in July 1996 at the King Chulalongkorn Hospital of Thai Red Cross Society. At that time, there were only 3 staff, including one doctor, Dr. Eugene Kroon from Amsterdam. Right now, HIV-NAT is an organization with 120 personnel with 5 doctors. At the beginning, HIV-NAT performed post-marketing drug trials by comparing the safety and tolerability and efficacy of various combinations of antiretrovirals. Later on, it gradually gained recognition to the point that HIV-NAT can join international new drug studies, including the strategic trials like a when to start trial. HIV-NAT started by doing post-marketing drug trials by comparing various combinations and various dosing regimens of many antiretroviral drugs. It gradually gained recognition to the point that HIV-NAT can be involved in new drug trials, as well as some new strategic clinical trials like when to start trial. For the last 7 years, HIV-NAT has been a part of the NIH-sponsored Clinical Trial Unit or CTU, together with University of Chiang Mai. During the last quarter of century, HIV-NAT with the HIV clinical trials, tuberculosis trials, hepatitis B, comorbidity trials, more than 200 studies involving more than 4,000 patients have been involved. With all of this, the following achievements have been done. First of all, lives of several thousands of Thai infected people have been saved. From 1996 to 2006, when antiretroviral drugs were included in the Thai Universal Health Coverage Program. In fact, the Universal Health Coverage Program in Thailand was fueled by or influenced by the Thai network of people living with HIV, as well as by the clinical benefit of patients from HIV-NAT studies. Secondly, HIV-NAT has helped in building up the competency and infrastructure of HIV clinical trials in several hospitals, including several medical schools in Thailand, as well as 2 units in Phnom Penh, Cambodia. The results of several HIV-NAT studies have been used as a guidelines in Thailand as well as international guidelines. But the most importantly, HIV-NAT has established the Bangkok International Symposium of HIV Medicines for the last 23 years, including the one this year, which is the first time in a virtual conference. One and a half years after the establishment of HIV-NAT, the first Bangkok International Symposium of HIV Medicine was held in January 1998. The rationale of holding such conference because the 3 co-directors were scheduled to meet annually for the HIV-NAT retreat. It would not be difficult for Professor Yup Lang and Professor David Cooper to invite a few more of their friends to join them in Bangkok, and also to hold lectures for Thai healthcare professionals when they were here. This is why the first Bangkok Symposium was started and has been continuing on for the last 23 years, including this one, which is the first virtual conference, starting from local audience. It gradually gained the recognition from clinicians from the region as well as from the world. In fact, out of these 500, 600 participants every year, half of them are non-Thais. The unique feature of the Bangkok Symposium was the educational nature. Speakers, both from Thailand, the regions, as well as from Australia, Netherlands, and USA, were asked to review the recent development for the last 1 or 2 years, so that audience don't have to go to all over the world for the meetings. I hope you enjoy this year's conference.
Welcome back, and we're going to move on session 4, which is about innovative model for integrating HIV care and delivery. I would like to welcome our first speaker for this session is Dr. Mukha Sharma. She is a regional advisor for HIV/AIDS, hepatitis, and tuberculosis, WHO Southeast Asian Regional Office, supporting 11 countries with WHO Southeast Asian region for development and implementation of policy and intervention for ending HIV, hepatitis, and tuberculosis. She is a strategic thinker dedicated to the public health with a strong analytical and communication skills, with over 2 decades of experience and technical and leadership role. She is specifically expert in the supporting large programs in the public sector, including the development and costing of national strategic plan, developing investment cases, and supporting sustainable financing approach, including universal health coverage and the development of HIV/TB concept known for the GFATM. Technically experienced in substance use, HIV and AIDS prevention and treatment, hepatitis C, sexually transmitted infection, maternal and child health, and tuberculosis in vulnerable and high-risk group. She's been working with the UNAIDS, UNICEF, and WHO over 15 years, got in-depth understanding with UN agency and donors such as the Global Fund, and highly skilled in working in the partnership with the Ministry of Health, law enforcement, community partner, and the sub-national stakeholder. For today, she is giving a workshop on the topic of WHO guidelines and the recommendation for integrated service delivery. Please welcome her talk.
Good morning, Sawadee-ka. Thank you very much to the organizers for giving me this opportunity to speak to you about WHO's guidance and recommendations for integrated service delivery in the context of HIV. The outline of my presentation is very simple. I'm going to give you a few pointers in the introduction about what we mean by ISD, why it's necessary, and then go on to talk about some of the broader considerations and recommendations when we talk about integration. Integration science is not something which is very clear, but certainly we should be aware of what some of the principles are around integration, and I'd like to discuss those with you. And finally, I will summarize and discuss some of the ways forward in terms of how we can integrate. So when we think about a patient, I would like you to think of an HIV positive woman who is pregnant, who is also somebody who has a history of using substances and uses opioid substitution therapy. Think about all the various aspects of her needs in terms of health. And let's think, do current HIV programs, does the current model of service delivery, does the current model of care help us to address the needs, the multiple needs of people living with HIV? So what is integrated service delivery? What do we mean by that? We need some sort of definition, and I propose a working definition to you. And the definition is the management and delivery of health services so that clients receive a continuum of preventive and curative services. I highlight here preventive, not just curative, but the need to offer preventive services according to their needs, not based on the convenience of our clinics, not based on the convenience of our doctors and nurses, but their needs over time. That means we have to take a life cycle approach and with the different levels of the health system. What that means is that we're not just thinking about services at the level of hospitals or tertiary care facilities, but also at the level of primary health systems and healthcare at the lowest level. What are some of the unique reasons for considering integrated service delivery in the context of HIV? I think one of the most important things is that with the increasing coverage of ART amongst people living with HIV, We've got so much increase in longevity. People are living longer and longer. And mostly what we're seeing is our population of people living with HIV who are on ART are aging. Globally, this percentage of people over the age of 50 is about 17%. But if one was to look at the figures in Thailand, for example, I would not be surprised if more than 25% of people on ART are actually over the age of 50. And as we age as a region, we will continue to see aging of people living with HIV. With aging comes the entire burden of non-communicable diseases. And in people living with HIV, we have a double burden, not just of non-communicable diseases, but also mental health. We've also seen that in our region, where most of the HIV is not generalized, people who have HIV are often people who either come from a key population, they have a background in injecting drug use or in sex work, or men who have sex with men, or maybe from the transgender communities, or maybe from their partners. So you could very easily have people living with HIV who have multiple health needs. And I give you the example of a PLHIV with TB who's also using methadone, or a transgender person living with HIV who is on hormonal treatment. Integrated service delivery enables holistic, patient-centric services. We, as a region, are pushing forward for universal health services, for universal health coverage. And the fundamental principle of universal health coverage is client convenience and making sure that we reduce out-of-pocket expenses. When we have services which are co-located, that are integrated, the first benefit is from the client's perspective, because it helps them to reduce transportation, lost earnings by having to go to multiple appointments. From the perspective of health outcomes, we also see reduced loss to follow-up, minimization of drug-drug interactions, and side effects. The other really important reason to think about integrated services is that HIV services have built up a real infrastructure and social capital over time. And it is unfair that this should not be used to support other ways of being healthy, including in terms of prevention, in terms of non-communicable diseases. So really, the utilization of this infrastructure is a very, very key consideration in terms of why integrated services should be thought about. Now, when we think about a health system perspective, we go beyond the patient, we go beyond the provider. If we look at it from a service perspective, what are the benefits of integrated service delivery? The first is that you leverage different service entry points. People can enter services in various ways. A person with TB could present at a pediatric clinic. Similarly, a person with TB could present in inpatient services when they have been diagnosed with pneumonia. The same applies for HIV. Different service entry points allow us to connect across various disease issues and not just focus on structural silos. This enables efficiencies. It enables efficiencies in terms of time, human resources, but as I mentioned earlier, also in terms of allowing patients to have more convenience and to reduce their costs. When we think about integrated services, we can also think about it from a continuum perspective, going all the way from prevention to care. And from a health system perspective, prevention is much more cost effective than just care. We have to think about how we maximize health promotion, how we maximize prevention, and take our eyes just off the disease treatment perspective, which has been very, very important in reducing morbidity But in the future, it cannot be very sustainable if we only focus on treating with pills for ARVs or something else. We need to be thinking about PrEP. We need to be thinking about other preventive services that will become very important for HIV going forward. I already mentioned that, from a health system perspective, integrated service delivery has big gains big implications for reducing patient costs and out-of-pocket expenses, but it also supports people, supports clients with multiple health needs. So that is why, in this context, if you think about how HIV services were developed first, we had a very, very vertical approach. And this was needed because in the early years of HIV programming, you needed rapid innovation, you needed rapid response. And there were several unique aspects of people living with HIV, which had sociocultural implications, had health policy implications. And all of this led to AIDS exceptionalism. And while that was a necessity in the past, and some of that still needs to continue in the current setting in some contexts, overall, the epidemic has evolved and the response cannot be as it was 20 years ago. We have to think about HIV now as something which has to be delivered, HIV care has to be delivered as a sustainable solution within an integrated, resilient health system. So integration is not a new concept, certainly, but we need to think about what does that mean going forward. So let's think through some of the conceptual issues around integration and what have been some of the challenges when different health systems think about it. When WHO developed the Global Health Sector Strategy on HIV in 2016 to 2021, for the first time, we said that it's clear that if you link HIV with other services, such as TB, with hepatitis, and other issues which are very, very important, STIs, mental health, then we're seeing reduced morbidity and mortality. And therefore, a chronic care model for HIV treatment and care offers opportunities for addressing broader health issues as well, particularly non-communicable diseases, mental health, and substance use disorders. And with that in mind, the strategy says that we really have to focus on improving the linkages with other areas, and this will have a much larger impact on the benefits that we have. But then there is no clear way of saying there is only one way of delivering integration. We have to think about different models and how integration can work best in different contexts. And it's a thematic area which is also sensitive among stakeholders. People feel that, if we generalize too much and we bring in too many issues, then the focus on HIV and the push for integration may actually move away from the focus on elimination. So overall, it's important to think through some of the principles around guiding that integration. Now, according to WHO, there was in the 69th World Health Assembly, there was something which was agreed, and that is the Integrated People-Centered Health Services Framework. And as you can see, this framework that was adopted by all member states in the 69th World Health Assembly has 5 key pillars. And these key pillars are around empowering and engaging people. This is not a concept which is unfamiliar to those of us who work in HIV. We've always talked about key population-led health services. We've always talked about community engagement. But this is a concept which is relatively new in many other areas and diseases. For HIV, we understand it very well. The other pillar of this integrated people health services is strengthening governance and accountability, reorienting the model of care, coordinating services within and across sectors. And for all of this, we need an enabling environment. So this framework is calling for reforms to reorient health services where we are putting individuals, families, carers, and communities at the center. And these are supported by responsive services that better meet the needs of people, rather than focusing much more on what is convenient for the health system to deliver. As part of these five pillars and strategies that I mentioned earlier, there are some key strategic approaches. And because in the audience, most of you are clinicians and people who work on HIV programs, I really wanted to focus on strategy 3, which is reorienting the model of care, and also strategy 5, which is focusing on the enabling environment aspects of this. So if we go to the reorientation of the model of care, there are 5 or 6 key areas to think about. The first is, if we are going to reorient the model of care, what is very important is that there are national health policies and strategies which promote integrated people-centered health services. And we have to define service priorities based on life course needs. Obviously, the social preferences have to be thought about, but the big principle here is the model of care has to assess life course needs. The other thing about the model of care is it has to revalue promotion and prevention and public health, and not just focus on individual clinical requirements, not just the individual patient and the curative aspect, but the broader issues around health promotion, around prevention, as well as public health. It's very important to do this in the context of a local health needs assessment, and that will be needed if you're going to be thinking about responding to people at the local level through primary healthcare systems. This is also important to think through in the development of primary healthcare systems. All across the region currently, there is a big push for primary care systems. And when we're thinking about the model of care, we have to think about what care can be offered for people living with HIV and their other health needs at the primary healthcare level. We also need to be thinking about doing much more in terms of decentralization more broadly to the local levels. And this is something which in many countries is talked about, but is not being pushed forward fully. A key issue around reorienting the model of care is innovation and incorporating new technology. Specifically here, I'd like to raise the issue of shared electronic medical records as well as digital health tools. This is something which is going to be really important if we are going to be able to provide comprehensive care to individuals. The other area that I wanted to focus on was the enabling environment aspects under strategy 5. And I think here one of the key issues is reorienting the health workforce, aligning the regulatory frameworks. Who can treat what is, for example, a really important discussion at the moment. Who can treat hepatitis in a person living with HIV? Should it be just a gastroenterologist, or could it be an infectious disease specialist? Who can treat TB? Can it only be a pulmonologist, or can it be somebody else who has broad infectious disease training? The training of health workforce to think about broad integration issues, as well as the leadership to push forward this agenda is going to be very important as well. I think while we are moving from vertical to integrated approaches, we have to understand that transition is going to be a big aspect of this planning. And change management, how we manage change while we go from vertical services, only ARV specific or treatment specific services, to broader services for PL-HIV, is going to be a key area to think through. So if I was to summarize, what are some of the priority practices to support the implementation of integrated people-centered health services? Then workforce capability is the first one. Training the workforce to think through integration. The second one I've already mentioned is transitional or intermediate care, as well as the entire change management aspect of this. The third important priority is continuity with a primary care professional. There has to be one primary care professional who provides some level of continuity and helps to coordinate all of the services that the person who needs, that the patient or the client needs. Co-location of services or a single point of access is another really key priority to think through. And comprehensive care along the entire life course of the patient to the client is another priority. At the moment, we are thinking about needs of aging and thinking about gerontology as a really, really important science and skill moving forward. But those are not the only areas that need consideration. Psychiatry, mental health, etc., are also really, really important. And this is important, particularly when we're thinking about case management of people with complex needs. Think about a substance using adolescent who is moving from pediatric treatment of HIV to adult treatment, as well as their sexual health needs, their emotional needs, and these sorts of issues require case management. They cannot be looked at through the lens of a vertical service program. The other really critical priority is that of technology. As I mentioned earlier, the use of digital technology, the use of virtual platforms to talk to clients, to talk to patients, to support adherence, as well as the use of digital records is going to be really, really important. And then lastly, having really clear frameworks and agreements and regulations that promote collaborative planning of care and shared decision making. So I want to now give you some examples within WHO in our different regions where some progress has been made towards integrated services. So we'll think a little bit about, what has happened in different regions of WHO. But before that, I just wanted to summarize a little bit where we were in the global health sector strategy for HIV, where we are very clear that we have to take HIV out of its isolation. HIV programs have to be linked to the broader health program, but there has to be coordination across all sectors relevant to HIV. What that means is that the specific issues of HIV are still maintained, but there is coordination across this. A key important issue is that of national health financing arrangements and how this includes HIV. In Thailand, this has been done very well. Thailand is a really good example of integration of HIV care packages into national health financing arrangements, but in many other countries, this is not the case, and HIV programs continue to be donor dependent. And unless there is coordination amongst donors, integration becomes very, very challenging. We have countries like, we have some countries where, I will not name the countries, but we have countries where we have 4 or 5 big donors and everybody is running HIV services in a very different way, providing a very different package. And this does not bode well for integration. So clarity on coordination across all of the donors, as well as the health financing arrangements, is a key issue when we're talking about integrated service delivery. So I wanted to talk a little bit about integration of HIV with sexual and reproductive health, and what are some of the common threads, common issues that are needed in order to do this. And this is based on the work that has been done by WHO, UNICEF, and UNFPA. They looked at 11 case studies of integrating HIV and sexual and reproductive health in mostly from Africa, but also some other settings. And what we saw here was that what is common across both programs in order to build the integration was sustained political commitment and coordination, clear, streamlined, documented strategies and policies. So really writing down clearly what the SOP for integration is, ensuring community engagement, making sure that everybody understands why these programs are being brought together, what is actually helpful to the community when programs are brought together, and learning from them in terms of how they can be the most effective for clients is something which was common to both. A common supply chain system is fundamental. You cannot have integration if you say, yes, as part of HIV, we will be looking at family planning needs of pregnant women, women who are not pregnant, or of postpartum women, and not be able to deliver any contraception to them. So the supply chain integration is very, very important. Integration of M&E systems is very important, because otherwise you still have two very, very separate systems that don't talk to each other. Decentralization is key, and co-location of services as well. I wanted to also raise for you some of the broader WHO frameworks for disease elimination. In PAHO, in the Pacific, in the Pan American Health Organization, what is now being pushed forward is an integrated disease elimination framework. And this is happening for two reasons. Member states, countries are saying, we cannot keep working with disease-specific issues. We have to work in an integrated system. And while elimination has focused only on stopping transmission, really what we have to think about is the negative health effects that go beyond the transmission of diseases alone, that really thinks about how people live their lives with diseases and how these are addressed over the life course. So therefore, in this elimination framework, a broader definition of WHO's definition of health has been brought in, not just around stopping transmission, and thinking about a people-centered integrated framework with a holistic health systems perspective. So that's in PAHO. And we are also seeing a similar approach come through in the WHO TB strategy. If I share with you the NTB strategy, you can see that there are very clear areas where we're talking about preventive therapy for people at high risk. That is giving TPT, TB preventive therapy for people living with HIV, as well as collaboration of HIV and TB services and the management of comorbidities. Let's talk a little bit about NCDs now. We have very clearly seen in our region that NCDs are a really, really big issue. Diabetes has a very, very high prevalence in the Southeast Asia region. We also know that mental health issues are really central to the way in which we've been thinking about ensuring adherence, as well as the well-being of people living with HIV. And that sits very clearly, mental health sits very clearly with non-communicable diseases in many countries. So we are really, really have no choice but to think about how NCDs and HIV and aging and mental health can come together. We know that HIV is also associated with increased risk of some NCDs, and we know that service integration in a chronic care model is something that is something that has been shown to be effective in low risk, in low resource settings. So the synergies that are needed around integrating this will of course extend to logistics, to supplies, to training, to supervision, as well as monitoring and evaluation. And evidence-based generation and to look at what innovation can happen in this area is something that is critical and we're pushing for in WHO. I want to talk a little bit about the discussion paper that we have in WHO for the potential synergies and share with you some areas where HIV and NCDs can work together in the areas of prevention, diagnosis, enrollment into care, as well as disease management. So if you look at this table, you can see under HIV, what do we do in the areas of prevention? And how can we bring in awareness for NCD risk factors, as well as health promotion and risk reduction when we talk about prevention in terms of specific HIV interventions, Similarly, for testing and counseling and referral systems contributing to diagnosis, in NCD areas, we could be talking about early detection and screening of NCD risk factors. For treatment, we could be talking about early treatment, behavior change counseling, and linking it to social support in the same way that we've pushed for early treatment for HIV, behavior change, counseling, and link with community care and support. Community care and support is going to be a really, really important area for aging. And in HIV, we've done quite a lot of work to bring this together. The next area of integration I want to talk about briefly is what we call triple elimination. This is something we're pushing for in the Western Pacific region, as well as the Southeast Asia region of WHO. And we are bringing together the approaches of eliminating mother-to-child transmission of HIV, congenital syphilis, as well as hepatitis B. And this has three pillars. The three pillars is, the first one is coordinating the national policy for hepatitis B, congenital syphilis, as well as HIV, coordinated monitoring and evaluation of the elimination, as well as the seamless quality of care for women, newborns, children, and families. The next potential area where we can have integrated service delivery platforms is harm reduction. As you know, in our region, substance use has been a big issue, and we have recently come up with guidance to say that HIV and STI programs can be implemented together as part of drug dependence, mental health, as well as hepatitis programming. So seamless services that range from HIV, hepatitis, STIs, TB, family planning, mental health, and drug dependence treatment can actually be offered on a harm reduction platform. And a single window of services which bring in an enabling environment approach that respects the rights and dignity of people who use drugs is really fundamental to being able to provide these services. We also have similar guidance in WHO for integrated services of sex workers, men who have sex with men, as well as transgender persons. Now, diagnostic innovations and opportunities also are very, very helpful at the moment in terms of being able to integrate. We've seen lots of point-of-care tests that allow multi-disease platforms for diagnosis of HIV, STIs, TB, hepatitis C, and HBV. We've seen that in the Gene Expert platforms. We've seen that there are self-testing approaches now which allow integration as well. We are talking about self-testing for hepatitis C as well as HIV. We have dual test kits for HIV and syphilis now, which can be used across programs. And we also have the use of dry blood spots, which allow us to now look at hepatitis B, C, and HIV, and look at really ensuring early diagnosis as well as integrated diagnosis for across diseases. So I'm just going to summarize now and talk about some of the challenges that you might see in implementing this and think through the issues around how this might be addressed going forward. The first thing is that integrated service delivery at the moment has very unclear expectations, and there are some apprehensions around this. So making sure that the expectations are clarified is fundamental. And secondly, we have to think through the infrastructure issues. Do we have to have specific changes to infrastructure? Is there adequate infrastructure? Is the infrastructure for bringing together a model of care which supports integrated services available? We need to be thinking about having discussions proactively around infrastructure design and engage with health systems to think about this. The other issue is that of financial and human resource constraints. At the moment, the funding is sitting very clearly with HIV, but there isn't a lot of funding for non-communicable diseases. There isn't a lot of funding for hepatitis. And where there are donor-driven services, it becomes important to think about how donors think about integrated service delivery. The other issues to think about are our human resources adequately trained? Is there enough discussion to really bring together training materials and modules to support integration? A key issue is that of HIV-related stigma and discrimination. Many services say, please don't integrate us with HIV because there is too much stigma. We don't want to stigmatize people even further by integrating them with HIV services. But the fact of the matter is that there are many diseases that are stigmatized: mental health, TB, as well as HIV. And what we need is an integrated approach to addressing stigma across all these areas. And finally, a key challenge in integrated service delivery that we need to think about is how do we ensure community participation across all areas, not just from HIV, but from hepatitis B, but from TB, but from mental health and non-communicable diseases. So what are the ways forward? I think we need to take a very practical approach to integrated service delivery. WHO has provided some guidance, but it's important that in every context we think about progressive integration, which emphasizes priorities for that location, for that country early on. We need low-hanging fruit to be addressed. For example, identifying and assessing depression as well as nutrition is something that we could be doing in HIV services, in TB services, in STI services. It is something which is it is something which can be done relatively early on, and this can really impact treatment outcomes. Nutrition is really important for both HIV and TB services. There is no reason for this to be done separately. Depression is a key issue for people living with HIV, but also we see mental health issues and suicides in TB. This is something that should be done very early on. Another key area where we have low-hanging fruit is the digital health records. We are living in a time where there is really a huge potential for digital health, and sharing records is an important area. As long as confidentiality is maintained, as long as patient confidentiality and privacy is protected, digital shared records is a way to go. Another really important area when we push forward for integration is engaging communities in planning and implementing ISD, as well as making sure that all healthcare providers are able to listen to communities. Integration is not a cure for inadequate resources. In some countries, everything is being bunched together without adequate resources, and we do need to be clear about making sure that money is available for integration. Implementation research is key to promote integration science. We do not know about the best ways forward for integration in every setting. That will be different in each location. Finally, integration does not mean that everything has to be integrated in one go into one package. In reality, there are many different possible permutations, and it is for each country, each location to think about what would be the best ways forward. So with that, I'd like to thank you very much for your attention and once more make a plea that integration is important, but how we do it will be really, really different in different contexts. A lot of thinking and assessment is needed, community engagement is needed, but there is no option to move out of AIDS exceptionalism. Thank you very much for listening, and happy to take any questions.
I would like to invite our next speaker, Dr. Manbuli. He is the consultant in charge HIV Clinical Service, Queen Elizabeth Hospital, Hong Kong. He is also a president of the Hong Kong Society of HIV Medicine and Clinical Associate Professor, Nicashin Faculty of Medicine at University of Hong Kong. He is the chairman of the Medical and Sports Service Subcommittee of the Council for the AIDS Trust Bank. He has been authored and co-authored more than 75 peer-reviewed articles. Dr. Lee is giving a talk on the integrating care for HIV and mental health and non-communicable disease in Hong Kong. Dr. Lee, please.
Good afternoon. Thanks for Chairman's kind introduction and having me in this conference. I have no conflict of interest to disclose. This is where our HIV center located in Queen Elizabeth Hospital is a regional hospital providing acute inpatient and ambulatory service. Also secondary and tertiary care. It is government funded. There are 3 HIV centers in Hong Kong, all provide free ART. As both HIV and non-communicable disease, that is NCD, are chronic illnesses. So existing HIV care model also works for NCD care, and it also facilitates care integration. We also provide chronic disease management, which improve treatment outcome. This picture shows you the tiered approach of NCD management in our service. So we will provide NCD and risk factor screening for all people living with HIV in our clinic. For patients, we also have integrated care for NCD in our service. We also provide chronic disease management, and also we empower patients for self-care. We also have share care of NCD in the same facility or off-site for those require specialist care, such as end-stage renal failure and cancers, etc. For complex cases, we will offer case management, and we also will strengthen community care for moderate to severe disease. This slide highlighted the important components of NCD management in our integrated model, namely supported self-care to empower patients through intensive training. We also offer integrated chronic disease management through a multidisciplinary team with structured assessment and risk stratification, care planning, and empowerment. We offer case management for complex cases. We also have interface with other services, such as to strengthen the community care with our partners. I would like to use diabetes mellitus, DM, as an example of the integrated model. We will provide regular DM and risk factor screening and offer general health education to all HIV patients. When early and mild disease is identified, then we provide education on diabetes self-management, chronic disease management, and also conduct regular DM complication screening. For moderate to severe DM, so we will offer case management for complex cases, refer specialist care if necessary, and also link to community care service if necessary. The extent of NCD care integration depends on many factors, such as the efficacy of the program, service capacity, and resources required. Very often, prioritization is needed. I would like to show you the results of our cervical cancer screening program. Cervical cancer is the second commonest cancer in women worldwide, and cervical cancer is also more aggressive in HIV-infected women. And efficacy of screening program is well proven. Our program was introduced about 10 years ago. Newly diagnosed HIV-infected women have Pap smear done half yearly in the first year, then yearly after. Patients with abnormal Pap smear will be referred to our gynecologist for colposcopy. All nursing staff receive proper training, and credentialing and quality assurance are also included in our program. This is the results of our program. About 287 women with HIV were screened between 2010 and 2018. A total of 1,600 Pap smear were performed during this period, and about a quarter of them were abnormal, including ascus, low seal, high seal, etc. And 88 colposcopy was performed by our gynecologist. There are 24 CIN1 and 9 patients have CIN2 and 3. And 10 interventions were performed, including lip and also hysterectomy. And luckily, we could not identify a single case of CA cervix. So the cervical cancer screening program is very effective in the prevention of CA cervix. So our center, similar to other services, face increase in workload. Apart from increased number of HIV active cases, we also have to manage NCD and mental health. So the workload is escalating. So we have set up integrated nurse clinic to sustain the quality care and also task shifting. Apart from HIV management, this nurse clinic will also support NCD screening and management, which include risk factors assessment and monitoring, NCD screening, education and counseling, disease monitoring, drug adherence monitoring, empowerment and counseling, and also refer to appropriate health disciplines if necessary. So this nurse clinic helps us doctors a lot. I will also use cases to illustrate our model. The first case is a 60 years old gentleman, chronic smoker. He is an electrician married with 1 son. He presented with PCP in 1994. After heart, the patient has sustained viral suppression. The patient also received care for NCD in our service, including hypertension, lipid, and mild chronic kidney disease. Blood pressure and lipid control was satisfactory. We also refer him for smoking cessation counseling. The patient was admitted to hospital in 2014 for acute stroke, presented with right hemiplegia and expressive aphasia. He underwent prolonged inpatient rehabilitation. Upon hospital discharge, he could walk with standby assistance. Activities of daily living are largely independent. He continued speech training for expressive dysphasia. He was put on congee diet with thickener, but still able to swallow medication. He developed biological failure in 2017 and put on boosted darunavir, atravirine, and raltegravir. And Valo was suppressed after ARV switching. We also noticed that the patient's wife had carer stress, especially when the domestic helper left Hong Kong. Patient was admitted to hospital again in 2018 due to acute on chronic renal failure. and also noticed further deterioration in cognitive function and mobility. And wife agreed to arrange nursing home care after hospital discharge, but she had difficulty to find one that accepted HIV patient. Finally, the patient was admitted to nursing home in August 2018. Due to yelling, patient yelling day and night and disturbing other residents, the patient was asked to leave by several nursing homes. And we also noticed that staff crushed the tablets to ease swallowing, including some medication they are not advised to, such as ritonavir and atrazine. So in summary, this is a patient with chronic HIV infection more than 20 years, stable on ART, have multiple comorbidities, carrying and placement problem. And there are also issues of ARV related to swallowing problem. So we remind nursing home staff not to crush the ritonavir tablet and also to monitor whether patient can swallow the tablet. And refer community geriatric assessment team to assess the patient in nursing home. I will give you more information about this service after the case presentation. We also advance psychiatric assessment who prescribe hypnotics to the patient. After treatment, the patient had reduced agitation and yelling. Due to swallowing difficulty, the patient was eventually put on tube feeding, which also requires some modification of treatment. We changed the boosted dovinavir to boosted lopinavir solution, and other ARVs could be crushed and continue. The patient had no drug intolerance after switching, and the viral load remained suppressed. So we due to the aging and premature aging among HIV patients, we can see that the demand of nursing home care is increasing. However, in Hong Kong and in many Western countries, there are poor acceptance of HIV patients by nursing homes. And there are also barriers to engage them to training. This is the survey conducted by our service last year, which involved about 74 nursing homes, most of which are private nursing homes. We asked them the question whether their nursing home accept HIV patients admissions. And 60% of nursing home say no, and they say not ready to admit. And 24% of nursing home could admit HIV patients, but with certain conditions, such as the limit the number of HIV patients to a very small number. And only 16% of nursing home agreed to ready to admit HIV patients. When we ask about the reasons of non-acceptance, the answers are as follows: because there are no previous training, risk of HIV transmission to staffs and other residents, require higher level of nursing care, and did not want to receive complaints from other residents and their families. Based on the response of the nursing homes, we realized that there are a gap in the training to the nursing home staffs. So we are trying to enhance the community support for patients who need nursing home care. So I would like to mention about the Community Geriatric Assessment Team, CGAT, which was established in Hong Kong since 1994, aiming at helping residents to stay at the community with good health. CGAT is a multidisciplinary team led by geriatricians. So we collaborate with CGAT team to strengthen the community support and also help us to organize training to the nursing home staffs. Because the CGAT provide regular training to nursing home staff. So we take this opportunity to organize training staff. We conducted several sections of training to nursing home staff to teach about various issues of taking care of people living with HIV. The response are very good, very positive, and after the teaching sections, we also receive requests of some nursing home to arrange more in-depth training to their staff. So now we move on to the second case, who is a 40-year-old gentleman, MSM, diagnosed HIV in 2012. He refused ART with frequent default and with repeated episodes of syphilis. He actually had depression before the HIV was diagnosis, but he also defaulted psyche follow-up. He lived alone, unemployed, and on disability allowance. He was transferred to our center in 2017. So counseling was offered by our nurse counselor and clinical psychologist. We also referred to our HIV psychiatric liaison clinic, which was located within our service. I will talk this service more after the case presentation. Regarding the mental health history of this patient, he had long-standing family conflicts and feeling depressed since 2009. He had marked mood swings, irritable, could not work in the past few years. The diagnosis of HIV led to his feelings of shame and hopelessness. He disliked items associated with HIV, including staff and the HIV clinic. He refused ART as he had no confidence in achieving optimal drug adherence. So this patient have a co-infection, refused ART, ongoing risky behavior leading to repeated episodes of syphilis, depression, failed retention in care, and also poor acceptance of HIV. So our psychiatrists resume citalopram and also add quetiapine for the patient, have close psychiatric follow-up in the beginning. Patients show some improvement in mood symptoms, and psychiatrists continue to titrate the medications. Patients still lack of confidence in drug adherence and worry about the emergence of drug resistance. So we continue counseling, and I also suggest the patient to try taking daily multivitamin for training to build up his confidence. He agreed, and we found that his drug adherence gradually improved. He finally agreed to start ART as a single tablet regimen in October 2018. That is 6 years after HIV was diagnosed and 18 months after the patient was transferred to our center. He tolerated ART well and missed dose only occasionally. And while low became undetectable 8 weeks after ART initiation and sustained till now. His mood disorder is also stabilized, and he was transferred back to his district psychiatric center for follow-up, and retention in care was remained. Actually, there are many literature already show the prioritization of mental health care utilization for HIV patients is justified. The results show that the results also show that it will associated with increased retention in HIV care, improved clinical outcomes such as detectable viral load, and also decreased mortality risk. However, HIV-related stigma and self-stigma is one of the barriers of engagement to mental health care, and there are also other factors. So we are looking for alternative care model to address the service gap. Regarding the conventional care model, so patients are referred to psychiatric clinic after detection of mental illness by HIV physicians or clinical psychologists. The limitations include segregated and limited care coordination, high dropout rate, and no expertise to address specific issues in HIV psychiatric comorbidities. So we established a HIV psychiatric liaison clinic in 2015. It is a multidisciplinary team approach led by our psychiatrists. Our psychiatrists come to our clinic about 1 to 2 times per month. So we only refer patients with moderate to severe depression and psychotic syndrome not yet engaged to mental health service to this clinic. The benefits of this clinic is better liaison with community stakeholders, expertise of HIV psychiatry, and also better accepted by our patients because the patients are having the same environment that he feel comfortable. The limitations are require additional resources and there's sustainability issue. This is the patient journey in our psychiatric liaison clinic model. After screening, the patient will be assessed by our psychiatrist in the liaison clinic, provide treatment and psychosocial management. After stabilization, the patient will refer back to district psychiatric clinics, or if the problems are in remission, then the patient will continue monitored by our HIV team. Apart from mental health, we also found that the substance use is another emerging issue in our service. We conducted a cross-sectional questionnaire survey in 2017, and we found that 31.4% participants reported drug use. 65% of them use crystal meth, and 51% use a combination of 2 or more drugs. Younger age, MSM, history of STIs, and smoking were independently associated with substance use. Coexisting mental illness are common, and most drug users had never received any form of drug addiction treatment service. This slide summarizes the integrated mental health service in our clinic. We have a multidisciplinary team, including the HIV physicians, case managers, clinical psychologists, social workers, addiction counselors, and also our community partners. We regularly screen for mood disorders, substance use, and cognitive function. Counseling was offered by our CP, nurse counselors, and social workers. We have a HIV psychiatric liaison clinic. We also strengthen community care with our partners in drug addiction counseling and also community support. We also organize staff training, including motivational interviewing skills. So to conclude, there are changing needs of people living with HIV related to normal and premature aging, increased prevalence of NCD and mental health problems. Integrated care for HIV, NCD, and mental health is feasible, could improve disease outcomes, and is accepted by our patients. Barriers and facilitators of integration should be addressed. Thank you.
This workshop is case study on integrating TB and HIV care in pediatric and the adult services in their hospitals. Our first speaker is Dr. Vidya Maeve. She is the director and the clinical research site leader of Baltimore, Washington Indian Clinical Trial Unit. Dr. Maeve has nearly 18 years of experience in clinical practice, education, and research in the infectious diseases. She is the lead investigator of a large observational cohort in Pune, investigating the epidemiology of the HIV in India. She serves as a member for ACTG TB Transformative Science Group and Cross-Network TB Vaccine Working Group, and is involved in the several TB HIV clinical trials. She serves as a chair of the Common Protocol for the Regional Prospective Observational Research in the Tuberculosis India Consortium, collaborate with the CIS Indian and US Research Teaching Institution that is a part of the international effort to identify and evaluate biomarkers that predict TB treatment outcome and progressing from latent infection to active disease. She is a professor in the Division of Infectious Disease of Johns Hopkins University School of Medicine. She is the author of more than 100 peer-reviewed publications. Let's welcome Dr. Maeve.
Good afternoon, and my name is Dr. Vidya Maeve, and I will be presenting HIV-TB integration in a research setting. I am a research director at Clinical Research Site at BJ Government Medical College and Johns Hopkins University Clinical Research Site. So we see on a routine basis TB cases as well as HIV cases who participate in our clinical research. So what is key for that is to manage the management of their flow so that they get prompt care as well as treatment, but then ensure that there is no risk of nosocomial transmission, and then infection control strategies then need to be implemented in research settings. So as a glimpse of our research studies, we have over the last several years, for last at least 5 years, enrolled about 6,500 TB cases, including the pregnant women, and then overall about 8,000 HIV positive participants in various studies, including being part of a Treat Asia consortium. So in this, as we know, the confirmed nosocomial TB transmission has been diagnosed or been known for over several years, where this case is talking about a contact investigation of 11 infants, where one mother was positive for TB and spread it to the other mothers as well as other infants while she was breastfeeding. So it is known for several years so far, and in our own setting, we have published 2 data, one suggesting that the incidence of TB infection is very high among medical trainees, including medical residents and nursing students, and that tuberculosis risk among medical trainees is almost 15 times higher than general population at 3,279 per 100,000 population. So what do? Our model basically follows what has been done in program settings, that including an HIV subjects who are enrolled in our study undergo symptom screening, or 4 symptom screening, which is a WHO questionnaire. If they have any symptoms suggestive of TB, will get TB diagnostics and will be referred to TB care. If you already know, if they are only TB patients, then HIV screening is mandatory in most of our research care. And once they are positive for HIV, they are then sent for ART center and ART care. So once we know both whether TB and HIV are positive, then we ensure that co-trimoxazole therapy are on, they are sent for DOT for TB and are placed on ART treatment. So in clinical setting, we have adopted FAST strategy, where we, as soon as we see a participant with the potential symptoms of TB or is coughing, they will immediately separate them from the rest of the participants, and then we fast track them to get their evaluations for TB. And we have also implemented the infection control strategy for TB, where we do have a policy which is in place. We also have a training of staff which is in place. And then we have adopted AIDS clinical trial group network standard operating procedures for the TB infection control procedures, where basically there are 3 levels of infection controls are followed. One is at personal level, environmental level, as well as administrative level. In administrative controls, we already have a FAST strategy implemented and separating and ensuring that they are started on TB care or at least TB diagnostics. While at the personal protection level, we ensure that if somebody is known case of TB, they are given a surgical mask. If possible, if they do not have any dyspnea, then N95 may be offered, but mostly we offer only surgical masks. And if they are visitors, we generally provide surgical masks, as N95 masks are almost always are in high demand, are not always available. But for healthcare workers, it is mandatory for them to use N95 respirators if they are taking care of a TB participants. So before employment, all of our research staff undergo a pre-employment evaluations and get a fit testing done. Symptom screening happens at least annually in our settings. And we encourage all of our study staff to undergo annual HIV testing as well as TB testing. And as I mentioned, fit testing is done by a dedicated infection control officer in our settings. We also have a separate sputum collection area for TB patients, where the healthcare workers must wear N95 mask, and the designated area, it has to be a well-ventilated area, and the healthcare personnel or research staff provides instruction to the participant on how to follow the hand hygiene and so on. So it's already known that in a research setting, in a laboratory setting, the risk of TB infection and disease are much higher if the TB cultures are manipulated by the research personnel. And so laboratory also follows similar infection control strategies where there are regular training of staff happens, and then there are already policies and SOPs are in place, and that they also undergo fit testing along with annual evaluations. Mechanical ventilation, including indigenous way of circulating air at least 6 to 12 times per hour, has been implemented in our research area where we see all of our TB patients. And then we also have ultraviolet germicidal irradiation, which is become a standard for all of our research areas. So in summary, HIV-TB integration actually in research setting also follow the same theme as program where both HIV and TB cares are provided, or at least the diagnostics are provided in a rapid manner. And access to diagnostics again are pretty fast because that is kind of mandated by the research protocols. And we also ensure infection control are in place so that patients and research personnel are not getting acquiring TB infections or disease. Specifically because reduction of TB exposure for HIV is a priority, and so ensuring that for the participants, at least for the HIV participants, it's become critical. Thank you.
Next speaker is Dr. Shashikala Senge. She is the professor and head of the Department of Medicine in Biramji Jijibwai Government Medicine College and the Sesame General Hospital in Pune, India. Her department is actively involved in the clinical research related to NIH-funded clinical trial of therapeutic drug intervention of HIV and comorbid infection, including tuberculosis in adults, including the pregnant women, adolescents, and children, as a part of the ECTG. She has played a role of principal investigator in many studies. She has supervised and stayed supervising several HIV-TB clinical trials as a site investigator and provide clinical care of current trial participants. She has published in several national or international peer-reviewed journals. In addition, she serves as the nodal officer of the National AIDS Control Organization, supports ART at BJGMC. She has been part of the ANFA as Asia Pacific Research Network since 2017. As a site principal investigator of the Treat Asia Observational Database Research Project and the other ongoing project too. Dr. Senge has more than 30 years of experience as a clinical educator and researcher in the field of the medicine. She is mentoring to the PhD student in the general medicine from Maharashtra University of Health Science. Please join me to welcome Professor Senge.
Good afternoon. Now, since Dr. Aarti has already given all the information about epidemiology and the magnitude of HIV-TB co-infection and how the two programs are integrated, so this HIV-TB integrated program, the main objectives of integrated program is to reduce the burden of HIV amongst TB and vice versa, that is to reduce the burden of tuberculosis in PL-HIV. There are 4 strategies which include preventive activities in the form of IPT prophylaxis, early detection, prompt treatment, and management of TB-HIV cases in special situations. Now, for this, the one-stop service model has been formulated and which mainly looks upon TB services for PL-HIV and HIV AIDS services for presumptive tuberculosis cases. What is this one-stop service model? It includes first is to diagnosis of tuberculosis by using CB-NAT after four symptom questionnaire. The CB-NAT within the same health facility. Initiation of daily anti-tubercular treatment at ART center. TB infection control measures and TB preventive therapy at ART centers. Not only this, but recording and reporting at the same center, that is ART center, which is followed in almost all ART centers in India. Now, how these TB services are given? It is clearly shown in the flow chart for PL-HIV. The symptom screening, that is 4 symptom screening, is done in ART center. 4 symptom screen, if it is positive, then diagnosis is done by CB-NAT. TB, if it is detected, then patient is simultaneously immediately started on anti-tubercular treatment followed by ART. If 4 symptom screen is negative, then they are provided with IPT prophylaxis. Now, if CB-NAT is negative for symptom screen, even they are also, if there is no CB-NAT is negative, they are also being given IPT. Now, what is this intensified case finding, which is very important? Now, integrated counseling and testing is done simultaneously in ART center. 4 symptom questionnaire is which is followed by which is following the pre-test and post-test counseling, HIV counseling. So patients, when they come, they are simultaneously counseled for 4 symptoms for tuberculosis. At ART centers, 93% patients were screened for tuberculosis at ART center. 6% had presumptive tuberculosis, and 12% were diagnosed to have tuberculosis with PL-HIV. This is in 2019 data. Now, tuberculosis preventive treatment, which forms a very important point in the integration for PL-HIV. There are the goals which are to be achieved. Only 36% of population has achieved this goal worldwide. However, India has reached the 43%. So India is ahead of other countries, especially from IPT point of view. Now, what is the progress of TB-HIV services, additional services? That is co-location of direct microscopy centers. 89% has been achieved. HIV-TB co-infected on co-triamcinolone preventive therapy, 93%, and TB-HIV co-infected on ART, 89%. Now, there are TB services are also required for vulnerable population who are PL-HIV, which includes female sex workers, MSM, IV drug abusers, transgenders, migrants, and truckers. Special mention is needed for prisons because in prison, the prisoners which are there, they have ventilation is not proper, and therefore they are vulnerable for tuberculosis. So the number of patients, prisoners which are screened and how many are positive shown in the slide clearly. I will not go into the details. The challenges now, very important point about, in spite of TB HIV integration, there are still challenges which we have to face. Since India is the first and the commonest or highest having capacity, highest number of tuberculosis in HIV, there is an increased workload which makes the intensified TB case finding a challenging job. There is a risk of tuberculosis transmission because most of the ART centers do not have cross ventilation, and since they are congested OPDs, the workload is more, so risk of TB transmission, so infection control becomes a challenge. And next important is INH stockouts. Now there is an impact for TB, scaling up of 3HP for tuberculosis prevention, which includes INH and rifampicin for 3 months, which is being started. The project is run in 13 countries and India is amongst them. Next. So to summarize, HIV tuberculosis infection continues to be a leading cause of morbidity and mortality. The one-step model is adopted by Indian program to strengthen the HIV-TB integration. Most important aspect of this program is intensified case finding, which is successfully implemented in India. Tuberculosis preventive therapy via IPT is currently exceeding the global uptake as compared to other countries. Co-location to strengthen the integration of organizational HIV-TB integration has been implemented already. Vulnerable population has been targeted for TB-HIV services with much success. However, the challenges are still existing, that includes IPT stockout, adherence, infection control, and hence the new strategies are needed to have further successful program. Last but not the least, in December 2020, 1st December 2020, which is the World's AIDS Day, there is a theme is to eliminate HIV and AIDS. And with this assumption, we have to also assume that even tuberculosis also should get eliminated, and the national elimination program of tuberculosis, which is for by end of 2025 we have to eliminate, which for this we have to work very hard. Now expected in 2019 there was 63% reduction of TB deaths. In 2020 75% reduction of TB deaths was expected. But why this is not achieved? Because there is a late diagnosis. But only 44% of male HIV tuberculosis were not diagnosed in 2019, and therefore early treatment was not possible. Now, very important point about 2020 is the impact of COVID on HIV and TB. Because of COVID-19 pandemic, there was reduced access to care for both indoor as well as outpatient services, which increase the risk of tuberculosis in pale HIV. And hence, we need to expand and strengthen the integrated services all over India for TB and HIV. Thank you.
Next speaker is Dr. Arti Kinika. She is a professor and head of pediatrics, Peranjiji Point Government Medical College, Pune, with a special interest in pediatric infectious disease, hematology, and neonatology, with the over 30-year experience in teaching clinical and research in pediatrics. She is the recipient of the Best Medical Teacher Award from MUHS. Has been an awarded Indian patent locals bubble CPAP that saved many lives during H1N1 pandemic and non-COVID-19 pandemic. She is also an advocacy scholar from the Johns Hopkins University, USA. She is a principal investigator on the various national and the international clinical pediatric research trials in the collaboration with the network from USA, UK, South Africa, Thailand for the last 20 years, and credited with over 90 research publications in national and international journals. She mentored and researcher for the ICMR and other institutional research projects. She is a member of Pune Task Force for the COVID-19 and the instrumental in formulating pediatric and the neonatal COVID-19 management guidelines. Like member of MAP and NNF, and the national trainer for various GOI national programs. Presently, Nodal Officer for COVID-19 at BJGMC College, Pune. Appointed as a co-chair of the Creation Network for 2020 and 2020 batch. Working as a pediatric BJGMC site, PI for the Report 1 and Report 2 research study. Let's welcome Dr. Arti Kinika.
Good afternoon, everybody. At the outset, I would like to thank the organizers for giving us this opportunity to present about our HIV-TB care integration facilities in India. Myself, Dr. Arti, would be starting off with the presentation, followed by Dr. Sangle, who will take over and give details about the actual integration program. As we see, the HIV burden in Asia Pacific region varies between 0.2 to 0.9%. However, if you look at the absolute numbers because of the population, it comes to over 5.9 million cases in the same region. Coming to India, we have about 2.1 million people living with HIV with a prevalence which is low as 0.2%. With not much data available on the children who are on antiretroviral treatment at present. We know that tuberculosis is the deadliest infectious disease with around coming in the 10 top causes of death globally, and it has surpassed the deaths because of HIV in 2014. 10 million cases per year are attributed to the TB infection, where more than 3 million never get diagnosed and treated, and less than 25% are recognized as the rifampicin resistant or resistant tuberculosis. If we see at the incidence of TB globally, in India, we have around 181 per 100,000 population, and it is the same age area where the BCG coverage varies from 95 to 99%. With the co-infections, HIV and TB, they are strongly linked with 1 in 3 HIV patients who have died in 2015 because of tuberculosis. Over the last 17 years, the annual trend of TB HIV burden in India has slowly gone down. However, there are about 10% of PLHIVs who still suffer from active tuberculosis. As we see here, there is a gap in TB detection and TB prevention for people who are newly enrolled in HIV care. This is data of 2017. A gap of almost 10% is seen over here. Our center paper, which was published in BMC Infectious Disease, shows the overall TB incidence among HIV-infected patients to be 3.94 cases, and among the first-line ART patients, it was 4.39 cases per 100 years. When it was compared with the second-line ART patients, it dropped down to 1.64 cases per 100 years. Similarly, a paper that was presented at TB Union Conference in 2018 on children living with HIV, we found the overall incidence of TB to be 2.8, predominantly in the age group of 3 to 5 years, where it went up to 4.6. Looking at the recent data of TB India report regarding pediatric TB HIV, out of the notified cases of 151,000, nearly 71% had their known HIV status known, of which 1% of them suffered from tuberculosis. Now, what are we talking about? In India, we have two national programs, the National TB Elimination Program and the National AIDS Control Program, who are running parallel. However, there has been collaborative interventions at various levels, starting at the national, state, primary care level, as well as community-based. These are two different diseases, but the patient happens to be one, and hence these integrations are very important. As we see here, one of the models which shows from low complexity to high complexity, where when the two programs function separately, they are easy to manage, whereas as they start integrating, you will see that more and more complexity occurs. These are existing in India, where the linkages, clinical linkages are available at the TB services and HIV services areas.
I would like to introduce our last speaker, Dr. Phyllis Reed. Phyllis Reed is a sexual health physician and the director of Clifton Road Center, KRC, in the Sydney King Cross. KRC is established since 1987. For over 13 years, KRC has provided integrated primary health care and social health for people at risk of HIV, viral hepatitis, and sexually transmitted disease to over 70,000 individuals. The key population include people who use drugs, sex workers, vulnerable young people, homeless people, and Aboriginal people under the LGBTQI community. The KRC operated integrated multidisciplinary HIV, hepatitis, STI, drug and alcohol, mental health and harm reduction services on site, and at a number of mobile outreach clinics across the inner city. It has a chain of the social worker and counselor, and also has an in-house legal clinic, and has recently led inner city COVID testing service for the disadvantaged population. Phyllis is an active health service and clinical researcher with over 70 publications and completed his PhD at UNSW Sydney in 2016. He is giving a workshop on STI or HCV. We'd like you to all to welcome Dr. Phyllis. Thank you.
Hi. My name's Philip Reed. I'm the director of the Kirkton Road Centre, which is in Sydney, Australia. And I'm delighted to have been invited today to talk about our integrated bloodborne virus care and harm reduction programme for vulnerable populations. Kirkton Road Centre, as I said, based in Sydney, Australia, was established in the King's Cross area of the inner city over 30 years ago. And it's an integrated primary healthcare service which aims to meet the health and social welfare needs of a group of vulnerable young people, people who inject drugs, sex workers, and also sees many people from the local homeless, Aboriginal or LGBTI communities. Key to the service is also an integrated opioid agonist treatment program with a particular focus on access to care. So we often see people who have had problems accessing some of the more mainstream drug and alcohol services. We have a large hepatitis C, HIV and PrEP program and offer a range of prevention, testing and treatment support options, including daily dosing. We operate a harm minimization model, a particular focus on harm reduction. And in terms of size, we're a medium-sized service, seeing about 4,000 individuals, about 20,000 appointments a year, and almost half of those people are individuals who've recently injected drugs. But across the broad service, we've integrated mental health, counselling services, we have a legal clinic, social work. We operate the district's needle and syringe program, and important principles about the model of care are that we are free, confidential, walk-in, and a one-stop shop model. Now, we've always taken a population versus a disease-focused approach, so we aim to meet the broad range of health and social needs of people at risk of bloodborne viruses, not just the blood testing and treatment of the bloodborne viruses themselves. And recognising that the health of these individuals clearly encompasses a broad range of physical, emotional and social aspects of well-being. Because in Australia, some of the activities that people who come to our service are involved in are either illegal or highly stigmatised, we offer the opportunity for people to be anonymous where they desire that. And we have very flexible drop-in appointments and extended clinical hours to suit all different types of lifestyle. The care model is very multidisciplinary, so we have joint teams of doctors, nurses, social workers, counsellors, an increasing number of peer workers and health educators who all work together focused around individual patient care. Now, we operate the classical alma mater primary health care philosophy, recognising health as being a state of physical, mental and social well-being and not merely the absence of disease. And therefore, we always frame the work that we do in terms of whether it's acceptable, accessible, affordable and equitable to the populations that we're wishing to provide care to. And just to frame that a little bit, I thought I'd provide some examples of our work that tries to encapsulate some of these important principles. So in terms of accessibility, we're located where it says KRC in the middle there, which is in the middle of the inner city of Sydney. But recognising that we need to deliver care at the point of, or at multiple points of access to the system for people at risk of hepatitis and HIV, we provide outreach services to all of those other locations that are detailed on the map. And that's all within about a 5 kilometre square radius. So there's multiple opportunities to be engaged wherever that person is that day across a suite of services in the inner city. We also focus predominantly on affordability as well. So all of our services are free and anonymous if necessary. And we try to provide as much of the medication as we can for free as well. The hepatitis C medications are provided through the Australian government, but in Australia, there is a co-payment required for many people to access these medications, which for some is not significant, but for many can actually be a barrier to accessing hepatitis and HIV care. So we've supported that cost for 300 or 400 individuals who we've treated for Hep C over the last couple of years. And we found that the populations who most benefited from this support around the finances related to treatment were people who were homeless, people who recently injected drugs, people who were currently receiving opioid agonist therapy, and people who identified as Aboriginal. And through providing financial support to people integrated into our hepatitis C and HIV program, we were able to ensure that treatment completion was maintained in groups where one might expect lower treatment completion rates. We also very much wish to ensure that our Hep C HIV program for people who are people who inject or people who are homeless is acceptable to them. And so we have a client consumer group who advise us and work with us around the delivery of care in the service and co-produce many of our activities, clinical services and resources. And we also come up with an individualized dosing plan for somebody so they can dip in and out of daily dosing, weekly dosing, or monthly dosing for their HIV or hepatitis C meds, according to their often changing social circumstances. We also offer pickup of medications from both the Curtin Road Centre main site, local pharmacies, our New South Wales users, our drug user organisation, NUA, and also the medically supervised injecting centre, which is close by. We've also tried to make testing for HIV and hepatitis C as acceptable as possible, and so have multiple testing options, including standard rapid tests, but also dry blood spot finger prick tests that go to the laboratory for an HIV antibody test and a hep C RNA test, and we've conducted many hundreds of those. We also work closely with peer-based organisations, both employing peers ourselves and also working with peers from elsewhere, and found that's been a very effective way of engaging individuals into integrated care. And we've also developed a program for people who are housed, but are perhaps housed in marginal housing situations, where we're able to deliver testing and treatment to their home environment via a mobile outreach van. The graph here just comes from a paper where we've looked at the outcomes of dosing daily for marginalised and vulnerable populations through our opioid agonist treatment program, demonstrating adherence that was sufficient to ensure virological cure for hepatitis C in the overwhelming majority of patients. This is an example of the personal assessment plan we conduct for people who are undergoing hepatitis C treatment. And very much it focuses around where their social situation is, how they can be contacted, and what the milestones for them will be as they progress through hepatitis C treatment. So it's very patient-centered, and we try to be as flexible as possible in delivering aspects of care. And we've also evaluated the effect of integrating the Hep C treatment program within a peer-based needle and syringe program run by our partner organisation, NUA. And we found that access to primary healthcare and comprehensive primary healthcare and hepatitis C treatment within that needle and syringe program setting was highly accessible and acceptable to that drug-using population locally in Sydney. We also have a focus on equitable healthcare, trying to ensure that everybody is able to reach the same level of improved health. And one of the populations in Australia it's always important to consider are Aboriginal people. And we therefore evaluated our program looking at aspects of the hepatitis C care cascade, comparing whether or not that is equitable between Aboriginal and non-Aboriginal Australians. And as you can see from this data, the results are equivalent. We employ Aboriginal staff, and we work closely with other local Aboriginal organisations to ensure that our integrated hepatitis C care program is culturally informed and culturally appropriate. Much of the care provided is through nurse-led outreach services, as described in the geographical slide I showed some slides previously. We did want to look at both the contribution of nurse-led care and also the other services that our clients accessed as part of their integrated care experience. And so the data here relates to an analysis of the first almost 400 individuals that we treated for hepatitis C, looking at the proportion of care episodes that were delivered only by nurses with no doctor involvement. And you can see there that the overwhelming majority of care components of the care cascade at all steps were performed by nurses, and the contribution of nurses significantly increased over time. The poster I've highlighted here on the other side of the slide looks at the other range of services that people accessing hepatitis C care through the Curtin Road Centre also utilised to enhance their capacity to get through treatment. So you can see that 45% of individuals had adherence plans and adherence support, 70% accessed drug and alcohol services such as methadone, drug and alcohol counselling for stimulant use and alcohol, 57% accessed housing and social support, half of them accessed HIV or sexual health care, a large proportion also accessing mental health care. And over a quarter of the people we provided Hep C treatment to amongst this population utilised our outreach services. So it's a big, integrated, flexible, multi-site, inner-city comprehensive care programme for these individuals. I wanted to talk briefly now about what sort of care is considered useful to people, particularly people who inject drugs, from a primary healthcare setting, which is relevant to, of course, hepatitis C and HIV care. So this is a narrative synthesis of the literature and models that have been published. This was submitted many years ago, but I think is still relevant. And you can see this is an extract from one of the data tables, but you can see across the top the major services that were considered important to be able to provide for an integrated bloodborne virus prevention treatment program for people who inject drugs from marginalized backgrounds. And you can see the staffing that might be required and the accessibility and acceptability. And you can see Kirkton Road Centre there as highlighted as being having many of these attributes. Now, we're fortunate in Australia to have very high coverage needle and syringe programs with over 300 needles per drug user per year estimated to be delivered. And that's been very comprehensively evaluated in our setting, demonstrating that not only is the intervention extremely cost-saving in terms of prevention of both HIV and hepatitis C, but it's also averted within our country between 10 and 25, well, between 2000 and 2010, 25,000 cases of HIV and almost 100,000 cases of hepatitis C. And you can see from the graph on the right that the antibody prevalence of HIV amongst people who inject drugs who don't identify as either homosexual men or bisexual men is less than 1% in the broad drug-using population. And that's really testament to peer-based organisation work and free access to needle and syringe programs across the whole of New South Wales and Australia. And of course, when thinking about HIV and hepatitis C care for people who inject drugs in our setting, we're also able, fortunately, to provide care for the other complications that may arise from drug use, such as endocarditis, abscesses, soft tissue infections, injecting-related injury and disease, and of course, crucially, interventions to prevent and manage drug overdose. But also important to consider the social and legal consequences of drug use in many settings, both in Australia and overseas. And two factors that clearly impact very significantly on access to healthcare, no matter how integrated your healthcare setting is, are going to be underlying stigma and discrimination, both in the general community, but also in the broader, within the healthcare setting, and also the legal response to drug use, and whether it's seen predominantly as a legal and criminal issue, or whether it's seen as a social and health issue, which is the model that we would prefer. So we work at Kirkton Road Centre under the influence of the National Drug Strategy in Australia, which and the National HIV strategies, and harm reduction has always underpinned some of the principles for delivery of this this kind of care. So harm reduction is clearly a key component of integrated care for HIV and hepatitis C. But looking at data from the Harm Reduction International Organization, we can see here that in many settings globally, there are, and this is of about 160, 170 countries assessed, you can see that the number of countries that have access to any level of opioid agonist therapy or needle syringe programs is currently suboptimal, and there are very few countries in the world currently that have drug consumption rooms, which are also very important in my perspective in terms of engaging clients at risk of bloodborne viruses, preventing bloodborne virus infection, and also connecting those individuals into broader health and social care. And these, again, are just visual demonstrations of where, as many of you may be aware, opioid agonist treatment is available in the community, where it's available in the community and in jail, and also where it's not available. And this is similar data So, as I said, there are only 12 countries in the world with supervised injecting facilities, and only one currently in the Southern Hemisphere, which is Australia, which has 2 facilities. The first of these was opened in Sydney, just 200 metres away from our clinic in 2001. And we have many staff that work across both our service and the medically supervised injecting centre. And in fact, we operate medical clinics from the back room of the injecting centre itself. The injecting centre in Sydney has supervised over 1 million injections without one fatal overdose within the service and responded to over 10,000 overdoses. It's also made many, many thousands of referrals to drug treatment, and also we've operated HIV dosing, hepatitis C dosing, testing and assessment from the injecting facility. So it's been a very key component of our integrated response, including harm reduction, testing, treatment, and reinfection testing within this local population. Of course, many of you be aware, the World Health Organization also published guidelines for HIV prevention, diagnosis and care for key populations, such as people who inject drugs and may be at risk of hepatitis C. An integrated service provision, such as the one that we're describing today, is identified as an ideal for service delivery wherever possible. And these are the recommendations from the WHO for services for people who inject drugs in an integrated, comprehensive harm reduction and care package. And we try very hard to make sure that all of these things are available across multiple locations through the network of services that we operate. So I wanted to finish off by just giving some examples of how we've evaluated our integrated care model. And how we've used that to demonstrate effectiveness for prevention, treatment, and care for people with hepatitis C and HIV. So first of all, we established a feasibility and acceptability adherence program, looking at dosing daily from our opioid agonist treatment program, but crucially, not requiring people to be on opioid agonist treatment to be able to come into the service each day and receive their hepatitis C and, if necessary, HIV medication. So we wanted to use the infrastructure of our daily methadone and buprenorphine program and leverage that to allow dosing for other bloodborne, for other complications of opioid use, such as bloodborne virus infections, without requiring that person to also wish to be or be eligible for opioid agonist treatment. So that was an interesting piece of work which has demonstrated that this is very feasible. I already showed this graph, but we looked very carefully at the sort of treatment and adherence support that most allowed people to get through treatment and end up with sustained virological response at week 12. And we found that, and looked hard at parameters related to homelessness, type of drug use, other services accessed, and mental health issues. And we're able to demonstrate good adherence to treatment and good virological cure through access to the integrated care programs. There has been little work done on PrEP and HIV amongst people who inject drugs in Australia. And so we wanted to try and connect these two issues. And so also through engaging people with multiple issues into the service, we're able to assess the needs, perceptions, risk profile, and risk modification potential for people who inject drugs who might be eligible for PrEP. And we also wanted to integrate hepatitis C and opioid overdose prevention, recognizing that although a lot of energy and focus currently in Australia is on the hepatitis C identification and treatment, many of the individuals that we see actually have a higher shorter-term risk of opioid overdose and death. And so by incorporating take-home naloxone into all of our hepatitis C program service delivery, we were able to not only impact on the long-term morbidity and mortality of these individuals through curing hepatitis C, but also provide an evidence-based harm reduction intervention, which may benefit them in the short term and reduce the likelihood of them and their friends and family dying of opioid overdose. And finally, just to have a look at data from Australia. So these are not all patients of our service. We contributed a modest number of patients to this overall large cohort. But what we found through the delivery of multiple service models, including integrated care models to populations at risk of both HIV and hepatitis C, is through treatment access and integrated care, the prevalence of hepatitis C RNA in people who are hep C and HIV antibody co-infected has reduced over time from 82% of those individuals being RNA positive to just 8% of people living with HIV who have been exposed to hepatitis C still being viremic by 2018. So that's a big population level impact, and we're beginning to see, on the basis of that, reductions in incidence within that population. And I wanted to put one last slide in on how we have modified our service model and incorporated coronavirus testing, which has obviously impacted on clinical services, on community organizations and communities all over the world. So we initially needed to provide a lot of coronavirus testing to homeless and vulnerable populations to ensure that isolation of those individuals could be achieved effectively to limit disease spread. And so we used our mobile outreach bus, which is pictured here, to deliver pop-up COVID testing services using our outreach nurses and counsellors across a network of rough sleeping and social housing locations through the inner city, provided many hundreds of social work interventions and provided temporary accommodation, and also provided to those individuals going into temporary accommodation who needed to isolate until they got their coronavirus swab result, food parcels to help them not need to leave the accommodation, mobile phones so we could contact them and let them know of their results, positive or negative, and also hand sanitizers and masks to allow them to reduce the risk both to themselves and also to others in an ongoing nature. And then once we established the coronavirus testing model, we were then able to reintegrate our original workflow of providing HIV hepatitis C testing, needle and syringe program and basic primary health care to these populations. And so now we've managed to integrate coronavirus testing to this suite of other infectious disease interventions to this population locally in Sydney. So I hope that's given you a flavour of our model of care, our integrated model of care, and what we've perceived to be the benefits of that. I look forward to answering any of your questions about our service and integrated care generally. Thank you very much for your attention and enjoy the rest of the conference.